Scientific Conference. Theme: Building Resilient Private Healthcare System in Lagos State, a strategic driver of public-private collaboration, economic stability, and good governance. Chairman of the occasion, Dr. Essien Ekong, Consultant Orthopedic Surgeon and CMD, Doren Specialist Hospitals. Keynote address, Professor Francis Adedayo, Faduyile, OON, former President, NMA. Chief host, Professor Akin, Abayomi, Honorable Commissioner for Health, Lagos State. Host, Dr. Jonathan Esegine, DMP, Chairman, ANPMP, Lagos. Date, Wednesday 10th September to Thursday 11th September 2025. Venue, Welcome Center Hotel, International Airport Road, Ikeja, Lagos. Time is 9 a.m. daily. This hybrid event will be streamed live on Decrew Media Studio. Subscribe today for instant notifications when event goes live. Announcer, Dr. Tunji Akitade, TMP, Chairman, Planning Committee, HEM/SC 2025.
Morning, ladies. Good morning, distinguished ladies and gentlemen. Please, can we settle down? Can we settle down so that we can get this wonderful program going? There are a lot of distinguished personalities here who have been appropriately positioned in the high table section of the hall. Would like them to please take their seats if they are here. The various heads of the different medical associations, you have your seats positioned in the front part of the hall. Let's all kindly take our seats. Would like to welcome everyone specially to this 2025 Lagos ANPMP Annual General Meeting and Scientific Conference. All our exhibitors and sponsors, you're all very welcome. We appreciate your support, and we look forward to always having you being a part of the story of ANPMP. We would like to start with the masterclass with MCPD points. Would like to start, so would like you all to settle down. We are running behind schedule, but I'm sure that we'll catch up. I implore everyone to have a wonderful time. Please listen attentively. The topic has been specially curated to provide capacity building. We thank you for the team from Novartis who will be taking this masterclass. Would like you to please take your seats so that we can start within the next 60 seconds. My name remains Olufunke Oluwole, and I will be your compere for the day. I'd like to welcome everyone once again as we prepare to start. This program is being streamed live. Would like to specially welcome our delegates that are viewing online. Thank you for joining us. We assure you that you will have a very nice time with us today, even though you are virtually present. And we ask you to stay tuned to all the things that will be going on here. Without much ado, the team from Novartis, are you ready for us? Can I have your representative, pharmacist Adedayo Shosomi? Where's our team? He's on his way. Wonderful. A round of applause for him, please. He's going to be taking the topic for the masterclass.
Thank you, sir. Yeah, good morning, distinguished doctors. I would like to start on existing protocol because of our time. My name is Adedayo. I work for Novartis Nigeria Limited, and I'm so excited to be here today to talk on a very unique formulation from Novartis, because in Novartis, we pride ourselves in innovation, research, and development. And in Novartis, we reimagine medicines to improve and extend people's life. I'm sure I'm seeing doctors here that have actually used Brinedine of those days to manage hypertension. And what we're about to talk about today is about cardiovascular risk management. And from Brinedine, we moved from there to Dalvan. From there again, we moved to X4-GGT in the management of hypertension. And I can tell you today that we have something in the pipeline again, which you should watch out for. But for the purpose of this presentation today, I'm talking about the topic beyond statins. I know statins has been this benchmark in the management of dyslipidemia. Even according to guidelines, ESC guideline, when your patients are not getting to go, according to 10th commandment, we have it that you've done dual therapy, you've done triple therapy, quadruple therapy. Statin should even be there to manage these patients. But today, we want to talk about beyond that statin. What other approaches should you use or explore in the management of dyslipidemia? As we all know, which is a known fact, cardiovascular disease is the leading cause of mortality globally. And data, statistics here and there, I don't like talking about data so much because it's about people, it's about human beings. We talk about data every now and then to say that, yes, cardiovascular disease account for 1/3 of global mortality and all of that, but these are human beings. And that's why I just implore us to pay attention, because we need to help these patients. A lot of non-communicable diseases that we have around. We talk about cancer. I'm sure everybody in this room will dread that. Nobody prays that for his or her enemy, as the case may be. We talk about diabetes as one of the chronic diseases. But it's interesting to know that cardiovascular disease actually is the leading cause of global death mortality. And as you can see from the slides, that looking from Nigeria to Ghana, because Novartis, we are a global company, as you can see, even out of this, looking at the mortality rates, especially for non-communicable disease, 11% of this population actually comes down with cardiovascular diseases. And when we mean 11%, for every 100 patients, that means 10 out of them for non-communicable disease is what they will come down with. In Nigeria, we always talk that we have paucity of data. There is no data, there is no data, there is no data. But it's interesting to know, I'm happy to present this today, because this is actually Nigerian data. And this is from Edafe, Oji, et al. And they say hypertension is a silent killer. Glaucoma is a silent thief of sight. But today, with some of the interactions I've had with you doctors, I've come to realize that even dyslipidemia is worse off. And why did I say it's arguably worse off? In the sense that often more than not, what we have is that most of the patients, when they have hypertension, irrespective of the blood pressure they have, of course, we know that we have to individualize treatment and all of that. Irrespective of the blood pressure, you agree with me, sometimes they'll be having headache. I cannot sleep. Bromazepam, Lexotan, and all of that. Sometimes, perhaps, if they go, some of them to see my colleagues, as the case may be, they want a medication that will just make them sleep, but these triggers are there, but they didn't pay attention. But when it comes to dyslipidemia, unfortunately, even somebody as I am can actually be a patient. But good enough, I'm not, because I've done my own routine test this year. So what am I trying to say? As far as hypertension is the leading cause, even diabetes, as it is, I can tell you that dyslipidemia is the second to hypertension. That's why we need to pay attention to it. So that statin that we're adding to that medication, then there's a new sheriff in town, which I think will better manage this patient for us. What are we trying to say is that in the management of dyslipidemia, LDLC is something that we need to pay attention to because it's the fundamental risk. It's the fundamental risk in reducing ASCVD events. And when we talk about ASCVD events, atherosclerotic cardiovascular disease events, it's all about the time, the exposure time, how long this patient has been having this condition, which, like I said, unlike hypertension that you might not pay attention to, for dyslipidemia, the patient might have high LDLC, which could predispose this patient to cardiovascular risk. So a lifetime exposure of elevated LDLC is a causal and cumulative risk factor for ASCVD. And in this, for the fact that the patient, you are just doing that test at that point in time, and you are picking it, whether the cholesterol level is high or not, the triglyceride is there, but far beyond this, I think we need to go to the breakdown, analysis of the cholesterol, not just the total cholesterol, but the LDLC, which we know is the bad cholesterol. The time factor is of great importance because this could preempt the patient to ASCVD events. So a sustained lifetime exposure to high LDLC could lead to increase in plaque burden and likewise eventually ASCVD events. What are we trying to say generally? That the total LDLC, we need to target the LDLC so that we can reduce the ASCVD events as the case may be. In targeting this, if we're able, just like in hypertension, that if we reduce the blood pressure by 2 millimeter mercury, it translates to about 7 to 10 reduction in the risk of cardiovascular events. The same thing also for patients with, in terms of glaucoma and the likes, for every reduction of 1 millimeter mercury drop in IOP, it translates to about 10% reduction in the risk of progression. Also the same thing that happens in the case of ASCVD events. If for every millimole reduction of LDLC, it translates to about 22% relative reduction in the risk in major cardiovascular events. And also 10% reduction in the risk of all-cause mortality. That is what LDLC could do to your patient. And we can look at it this way. If we don't target the LDLC, if we ignore it, it means that we are directly increasing the ASCVD event. No wonder we say, oh, I still saw him at an event yesterday. I saw him at the banquet yesterday, but he just had an event and he passed on. The reason why we need to screen our patients for LDLC. Not just their hypertension, not just their blood pressure, especially when they have some relative risk, which I will talk about in my subsequent slides. What are the treatment goals? Of course, we can talk about LDLC across different categories of patients. But what are the treatment goals? Because just like we have in hypertension, cardiovascular diseases, we need to individualize therapy. I think that's where the challenge starts from. We need to individualize treatment target for each patient, whether they are low risk, whether they are high risk, whether they are moderate to severe risk. We need to have an individualized target for these patients. And in doing this, according to European Society of Cardiology, or here's risk stratification and LDLC goal targets. It depends on wherever the patient is that determines what target you should achieve for these patients. Unfortunately, the screen is not up, but then I will try and manage to break it down as much as I could do. For a relatively low-risk patient, in terms of risk stratification of your patient, the target goal, according to European Society of Cardiology, should be 3.0 millimole, and that translates to about 160 milligram per DL. I'll take that again. For a low-risk patient, if you have risk stratifying, it should be about 3 millimole. But in terms of milligram per DL, that should be about 116 milligram per DL. And I would like to call our attention to something which I've seen in practice, especially in this part of the world or this part of the country. When our lab scientists, when we even send for risk stratification or to measure their LDL-C, total cholesterol of patients, they write back to us is normal. Or sometimes if it's between 116, less than or equal to 116, the patient is fine. That is incorrect, actually. Because this is according to European Society of Cardiology, not Novartis, not myself, but this is the standard. To say that if the risk is low, and when we are saying low risk for that patient, it means that the patient is young, less than 35 years, with DM duration less than 10 years, without other risk factor. That's when we can say, oh, that patient has a low risk. In terms of risk stratification, because that's where it starts from, to be able to stratify your patient appropriately. Then we move to maybe a patient has a moderate risk. And when we're talking about moderate risk, we're talking about a patient that has markedly elevated single risk factor. In particular, total cholesterol is greater than 8 millimole. Total cholesterol greater than 8 millimole or 310 milligram per DL, or LDL-C, which is the culprit indicated in ASCVD events, is greater than 4.9. That patient has a moderate risk. Or even the blood pressure is greater than 180/90. Systole is 180, diastole is 90. That patient has a moderate risk. Not just that, even patients with familial hypercholesterolemia, as the case may be. Of course, that's not too common here, unlike the northern part of the country. And also, the patient might be a CKD patient. That patient is also a moderate risk patient. Or a diabetic patient without target organ damage, with duration of greater than 10 years or has additional risk factor. That patient is actually a moderate risk. So if the patient checked all these boxes, definitely that is a moderate risk patient, or any of this. And the target for that patient, if you are considering the LDL-C goal, it should be the range of 2.6 millimole per liter, or so to say 100 milligram per DL. If it's more than this, definitely you need to do something for this patient. Also, if the patient, we've talked about the low-risk patient, we've talked about the moderate risk, but if the patient is an high-risk patient, we are talking about a patient with familial hypercholesterolemia, as the case may be, or the patient is actually having some traces of ASCVD. We are not sure. We send them for imaging, we send them for total cholesterol, and the target for that patient that you need to achieve, irrespective of their LDL-C, please mind my words, not the total cholesterol, but LDL-C. The target you need to achieve for this patient, if they are high risk, is about 1.8 millimole per liter. 1.8 millimole per liter or 70 milligram per DL. That's if the patient is actually a high-risk patient. We can also have a very high-risk patient. And very high-risk patient is very easy to pick. Patient with MI, patient with first incidence of stroke, patient under stent, patient with cabbage, patient with ASCVD, as mentioned earlier, patient with familial hypercholesterolemia, patient with severe CKD and EGFR is actually less than 30 mil per minute. A DM patient, oh fantastic, a DM patient that the organ damage has a major risk factor or early onset of type 1, which I would like to pause here. I learned from colleagues like you as well that even for some of these patients, when you offer statin, it might predispose some of these patients to even early onset of diabetes. So it's a risk-benefit ratio. Even as you are giving them the statin, they are coming down with something. And that's why maybe some of the patients, Their LDLC might be controlled at a point in time. You just see that you are losing that control again because it predisposes them to other cardiovascular risk. So in managing this patient generally, what we are trying to say is that you need to re-stratify those patients in front of you, irrespective of whatever the patient has come up with or whatever the condition of the patient. You need to individualize the treatment of the patient, and that's what the treatment goal is. So for the fact that somebody is at 100 does not mean that that patient is doing well. We need to ensure, is this patient a moderate risk, a high-risk patient, a very high-risk patient? Then that will tell you the target that you need to the target that you want to achieve for this patient. Different molecules, different medications are actually being used, but the gold standard as it stands today is still statins, which we are talking about the novel therapy beyond statins. That yes, statin can help you bring it down, and I'm sure if you are going to take statistics in this all today, you agree with me, most of our patients are not getting to high-intensity statins because the high-intensity statins should be around 80 milligrams. Even if you are doing moderate intensity statin, especially for atorvastatin, even if you are doing moderate intensity statin, which ranges between 40 to 60 milligrams, I don't think we want to take our patients there. And if you don't do that, most of these patients will not get to this target. Because for them to get to this target, especially for very high risk or high risk patients, you need to go as high as 80 milligrams. Even if at all, that will be under control. If at all. But we know some of the downside of statins. Sometimes they complain of myalgia and all of that. You don't want to take these patients there. We talk about rosuvastatin as well. We have some of these side effects. I'm sure you agree with me. Some of these conditions are there and you don't want to take this patient there. But we need to still achieve these targets, because if you ignore the LDLC, you are just predisposing the patient for ASCV events that could happen anytime, any day, anywhere. Some of the medications that, as you can see on the screen, some of the medications that has been used, moderate intensity statin, can offer you about 30% reduction. And remember, let's take, for instance, a patient that is very high-risk patient. A very high-risk patient, LDS is firing, and you want to achieve 30%. I don't think you have done that patient a good service. For us to achieve that, at least what the guideline is saying is that a medication that would achieve minimum of at least 50% reduction from baseline of that patient. And even if that patient, let's take for instance, around 300 LDLC, you agree with me, 50% of that for a high-risk patient is actually 150. Is that patient at target? I don't think so. The target for such patients should actually be 55 milligram per DL. That's why we need to re-stratify to know where exactly we should target for the patients. A number of medications have been used, and which you can see on the screen, that from World Heart Federation in reducing cholesterol in 2022, you can see from bempedoic acid to ezetimibe to PCSK9 and the likes, also inclisiran and icurumab. What are we trying to say? These are the ones, as you can see on the left, on the right side of the screen, that can actually help you achieve that reduction in LDLC to LDLC as high as about 60% from baseline. Different studies are available for us to know that, yes, whether you move from moderate intensity statin to high intensity statin, majority of patients, at least about 7 out of 10 patients, were not at goal based on the risk stratification of LDLC. Even with all the medication, whether from moderate to severe, 7 out of 10 patients will still not get at goal. Definitely, we need to do something for these patients. Like I said earlier, many of the patients are not at goal, and hence, ASCVD events happens. And that's why in our climb today, this patient was here yesterday, or somebody is celebrating birthday, the wife is celebrating birthday, the husband slumps. Of course, he's still under his medication. Maybe he's not taking his drugs properly. I don't think so to an extent. I think we need to do more for our patients in terms of re-stratifying the patients and getting them to go. According to Da Vinci study, as you can see, statins were actually the mainstay, but 94%, 9 out of 10 patients under primary prevention were not still getting to target because they are taking statins. They were not. This is a study that was done, and what we have seen is that most of the patients, of course, we just want to add that statin there. Let it just be there, maybe 10 milligram, maybe 20 milligram. But then we are doing them a lot of disservice because most frequently, moderate intensity statin as monotherapy will not bring them to target. From what we have seen from studies, only 3 out of 10 might get to go if you do that. And what are the reasons? It's not that the patient is not adhering to their medication, because it's easier to say for us as doctors that yes, most of the patients, because of polypharmacy, they have these drugs, they don't adhere to their medications, so definitely that's why they are not getting to target. But beyond that, sometimes maybe lack of familiarity with the guideline, or even the patient responses. You agree with me? You give the patient statins, and by the time you give them, they are coming back to complain, to say, oh, doctor, I'm having this pain, which sometimes you might not even know that's the underlying cause. We want to withdraw, and the patient needs something to address this condition. High cost of medication, not even in the climb where we have which insurance, patient pay out of pocket. And of course, we can't blame this patient, because the patient will tell you something must kill a man. The one I cannot even see you are talking to me about. The one I can see, I'm having a headache, please give me something to relieve that. I would rather take that one and leave this one out because I think I should be fine. High cost of medication could be there, and of course, side effect of that medication is another one that could be a challenge. How do we now re-stratify? Whether to moderate risk, high risk, how do we know? According to the guideline, the treatment algorithm, according to European Atherosclerotic Society, what we should do is to assess the total cardiovascular risk of this patient, to understand the baseline. What is the baseline of the patient? And if we identify the baseline, we know that, oh, this is high-risk patient, this is a low-risk patient, this is low-risk patient, very high-risk patient, to know where to categorize them and the targets that we want to achieve. If that is done, we know maybe we should initiate therapy or not. And if we are to initiate therapy, we need to define our treatment target goals. And in defining this, we need to understand, am I going for high intensity statins to reduce the LDL, or just a moderate statin if the risk is not too high, for low to moderate risk LDL-C. But if it's high or very high risk, then it has to be high intensity statin that could achieve that objective. But sometimes there are even patients, we are talking statins. There are patients that are intolerant of statins. So what is the resolution for that kind of patient? In subsequent slides, I will talk about that. If we initiate therapy, we need now to understand, are we reaching the LDL-C goal with the statins that we have initiated? If the goal has not been achieved, then we add the PCSK9 to that medication. If PCSK9 is there, we monitor again to follow up perhaps every 3 months or annually, as the case may be. Then if that is still not at goal, because we have re-stratified the patient, then another molecule is actually needed for that patient. Looking at a Nigeria guideline, a guideline that was drawn by some stakeholders in the country, it follows the same protocol in the sense that we need to re-stratify what is the target of the patient. Then we initiate statin. If the patient is not getting to go, then we'll go to PCSK9 as the case may be. Of course, like my people used to say, before the advent of maize, the hen has been eating something. Before the advent of the PCSK9s and the likes, statin has been the gold standard and is still being in use today. But the challenge, which we mentioned earlier, apart from the cost that we talked about, the challenge is that polypharmacy is one of a great deal to patients. As they are managing hypertension, some of these patients, especially the high-risk patients, they are managing diabetes, probably they are managing glaucoma. There are a lot of things. So cocktail of medication is there for the patient, which might make the patient not be able to take their medication 365 days, because you agree with me, it's every day, whether 10 milligram, 20 or 80 milligram, it's everyday medication. And this may not necessarily bring the patient to target. Sometimes, even if the patient is not at goal and you had a monoclonal antibody, as the case may be, the PCSK9s of this world, the medication is that each patient will come to the clinic, you inject them maybe twice in a month, or even 3 times, as the case may be, a month or twice in a month. And that could be cumbersome for some of these patients. But there is something again that we just innovated, which I'm so excited to preach about it. Not just excited to preach about it for the purpose of making money for Novartis, but because of the fact that it's in tandem with Novartis access principle. And when I talk about Novartis access principle, irrespective of wherever you are in the part of the world, Novartis has a commitment that any medication or formulation that they produce or manufacture anywhere in the world, it will not take more than 5 years before it gets to Africa. And this is a medication that was launched in Europe in 2022. And we are here in 2025. This medication is here. And that is part of the access principle of Novartis. Which medication am I talking about today? It's a small interfering RNA molecule that Novartis has discovered to actually address these unmet needs in the management of dyslipidemia. And the unique medication is actually called Cibrava. Cibrava, as the case may be, is a small interfering RNA. And when we are saying small interfering RNA, it's a drug that makes the biggest impact for your patient. How does it do that? Because over time, Cibrava is actually the first and the only. And I'm so excited when I'm talking about this, because most of the molecules from Novartis were always the first and the only before others will follow. And I'm glad to share with you that Cibrava contains inclisiran, it's a brand of inclisiran, which actually has is double-stranded and is indicated for adults with primary hypercholesterolemia and also mixed dyslipidemia. It could be used as an adjunctive therapy to diet and adjunctive therapy to statin. Before I proceed on this, there is a new study, a new one that was just published some days ago. Approval was gotten that this can actually be done even as first line. Cibrava can actually be used in combination with statin or other lipid-lowering therapies, especially when the patient is unable to achieve that target LDL goal that you want that patient to achieve. This is a unique medication that can give you that magic wand that doctors used to have. And I say that because sometimes most of these patients will have gone to a lot of places, but then you get to this doctor, that magic wand is there. This is a formulation that can help you achieve that. And especially, which I mentioned earlier, for patients that are intolerable to statins, are we saying those patients should go and die? That is why Novartis actually formulated Cibrava, because for such patients, even at the slightest lower dose, they will not be able to tolerate it. Cibrava can help you achieve that LDL-C goal that you want them to achieve. It's good to look at the mechanism of action of Cibrava, because this is a new medication that was just launched by Novartis earlier last year. And it's interesting to know that most of the patients that have been injected so far, it's so phenomenal to see the drop that these patients have actually achieved. But before we get to that, Cibrava actually acts by preventing the production of PCSK9. That is the way it works. Prevents the production of PCSK9. And how does Cibrava does this? It does this by increasing the uptake of PCSK9 in circulation and thereby reducing the LDL-C in the bloodstream. The fantastic thing about Cibrava is that it mimics the body natural processes. And what do we mean by that? In terms of RNA interference, it selectively targets the PCSK9 production, and you are sure that it goes to the target. It's more or less like Cibrava is a target selective system. That's what it does. Goes straight to the point of action, does the work, and gets out of the body. And how does it do this? Within 24 hours, Cibrava concentration is reduced within 24 hours, and within 48 hours, it gets out of the system. That is what Cibrava can actually do for your patient. It does follow the natural process of RNA interference. Because of our time, I would like to move faster. Like I said, Cibrava is the first and the only interfering RNA which mimics the body interfering process of RNA. There are different studies which were done across, whether Europe, whether America, whether in Africa, because I know that sometimes you say, is it done in black patients? Is it done in Africa? Part of it was done in South Africa. And specifically for this study, it has about over 3,005 patients that were enrolled, and the classes of patients that were actually enrolled were patients with familial hypercholesterolemia, patients with ASCVD, and patients with ASCVD risk equivalent. And each study, Orion 9, Orion 10, Orion 11, even Orion 7, this study went on for about 1.5 years. And at the end of the day, they tried to have, of course, the inclusion criteria, exclusion criteria was there. Because of our time, I may not be able to go into all of that. And at the end of the study, it was seen that Cibrava actually, especially for patients with familial hypercholesterolemia, heterozygous familial hypercholesterolemia, comparing with placebo, which, as you can see, Cibrava achieved an effective 48% reduction of LDL-C at 510 days. And looking at not just achieving that drop in, not just looking at that drop, the effectiveness of Cibrava, you can see that it's even sustained over a period of time, at least for that 500 and something days that the study went on. So what am I trying to say? It's not just that Cibrava or inclisiran is just effective, at least achieving about 48% in patients with hyperfamilial cholesterolemia, heterozygous familial hypercholesterolemia, but also it was sustained over a period of time. We know how drug works in terms of the pharmacokinetics and pharmacodynamic process. It comes into the body, gets excreted, peak and troughs in the body. But for Cibrava, it does the work very effectively and sustained over a period of time. Looking at patients in Orion 10, that was for Orion 9, which is familial hypercholesterolemia. Patients in Orion 10, which falls into the category of patients that we see in our day-to-day practice. Remember, cardiovascular disease, the leading cause of global mortality. For this category of patients, it achieves over 52% reduction in the reduction of LDL-C. And I'm most quick to say that this is actually from the baseline that patient is coming from. Whether the patient was on statins before or the patient has been on other medication, that is the baseline that you achieve with Cibrava. Which means that if the patient has achieved whichever medication you have used, whether it's statin or ezetimibe, as the case may be, irrespective of the wherever they are, you are sure that you achieve at least additional 52.3% reduction in place of ASCVD events. And this reduction is sustained. What are we trying to say? Cibrava is effective and sustained over a long period of time. And in this study, whether Orion 8, whether Orion 9, Orion 10, what we are trying to say is that Cibrava helps you achieve that target goal according to the guideline. At least 87%, 8 out of 10 patients will achieve that reduction in LDL-C for your patients. So generally, for Cibrava in this study, that patients were followed up to 6 years. It's not just effective, but at least 50% reduction was sustained over a period of time. What we are trying to say is that with that medication that you are given twice a year, One shot, then 6 months after, 3 months loading dose, then 6 months after, subsequently twice a year. What you achieve is over 50% reduction in the LDL-C at first, and is sustained over that period of time for the patient. This is a 6-year study, and it was discovered that at the end of the 6-year study, 50% reduction was sustained over a period of time. I mentioned earlier in the course of my presentation that what we have seen is that, yes, Cibrava was associated with lower plasma PCSK9 level and other lipids versus placebo. What I had said earlier in terms of when we sent for screening to bring back the results, the results to see the lipid profile, what you see is that most of the time you say, oh, yes, it's within normal range, the patient is normal, but we need to go further down to ensure that we, not just the total cholesterol, we check the LDL-C, check the triglycerides, check the HDL. But I'm glad to let you know that Cibrava can actually achieve a reduction of over 65% compared to placebo with respect to PCSK9 in terms of total cholesterol, about 30%, reduction on non-HDL cholesterol, even ApoB and little protein A. That is what Cibrava can actually do for your patient. But the winning streak for me is on this slide, actually. The winning streak for me is on this slide for Cibrava. We know that we have the bad cholesterol, the good cholesterol, LDL-C and HDL. Not just that Cibrava will reduce the LDL for you, but it also increases the HDL. That is what Cibrava can actually help you achieve with respect to your patient. And this is a study versus placebo about 1.5 years after. Those are theoretical and clinical studies that we have on Cibrava. Because of our time, I will not want to go into all of the details. However, in terms of real-world evidence, clinical practice with you doctors, what we have seen with Cibrava. In terms of real-world evidence, according to Italian Keynote study registry, they also observed after exclusion and the inclusion criteria of the patient, those that can tolerate, those that cannot tolerate, it was established that Cibrava, especially for familial hypercholesterolemia patients, Cibrava could achieve at least 49% reduction, 49% reduction in LDL-C. And this was sustained because the mean change at the end of the study that was done in real-world evidence, about 50% reduction was achieved in LDL over the period of time, which lasts for almost 3 months. And as you can see, whether it's Cibrava, whether it's statin, overall, what you can see in combination with lower lipid therapy medications that we have, you need to reduce that LDL-C to reduce the burden of ASCVD. And in reducing the burden, Cibrava, whether in combination with statin, whether in combination with ezetimibe, Cibrava can help you achieve as high as 79% reduction in the risk of progression and the LDL-C for your patient. Even in the US, and this I'm talking about real-world evidence, not experiments, not phase 3 trials, but we are talking about real-world evidence, especially in the US. And as you can see, at the end of the day, they achieved the same thing, which was not too different from what we achieved in Italy. Different studies, as you can see on the screen, whether from Keynote in Italy, Helix in the US, V-Initiate and Orion, as the case may be, you will see that on the average, Cibrava can help you achieve at least overall 51% reduction from baseline for your patient with high LDL-C. And by extension, you are reducing the burden and the incidence of patients coming down with ASCVD event. Am I saying this fantastic molecule has no side effects? Because you say these pharma people, they've come again. Are we saying that there are no side effects? But it's interesting to know that Cibrava, as the case may be, compared to placebo, is actually well tolerated. And when we mean well tolerated, why is it like that? Because it mimics the natural body process of RNA interference. And also, remember I mentioned that Cibrava concentration in the system declines at least 48 hours, you don't nearly see it again in the body. It does the work and it gets out, and the patient will be sustained over a 6-month period, and they don't have to actually have any untoward effect. But the major one for Cibrava, actually, which I must mention as clinician that you need to know, is just the site of injection. And when we mean site of injection, it's just the site of injection, according to phase 3 trial that we had. There might be reactions at that point, but it's mild and transient. So there is nothing to worry about the side effects of Cibrava. And like I said, most of the patients are actually, we have patients in Nigeria, close to about 200 patients now that have injected Cibrava and have not recorded any negative effect. But then the reduction in the LDL-C, and likewise, they are not coming down with the incidence of ASCVD. The safety profile of Cibrava, again, is similar in patients with whether normal or impaired patients. Because the question is, what about those impaired patients? According to Orion 7 trial, the magnitude and duration of effect of Cibrava on PCSK9 and the LDL-C level were similar, whether the patient is renally impaired or not. It is similar. So you have no fears on those patients that are renally compromised. The safety of profile of Cibrava was similar in normal and impaired renal patients. You don't need any dose adjustment. It's just the same formulation, just one shot now, loading dose after 3 months, then 6 months post that, your patient is fine. How is Cibrava administered? And what does the administration mean for your patients? Cibrava is administered 2 doses a year. That's taking care of the fact that most patients cannot adhere to their medications. So you are sure that just 1 shot now, then 6 months after, your patient is fine. Or 1 shot by June, 1 shot by December, your patient is fine for the year. And the LDL-C goal, you will achieve at least 50% reduction, depending on the baseline your patient is coming from. That's what you're going to achieve. No dose adjustment is required, whether you have a patient that are renally compromised or hepatic compromised. You don't need to adjust the dose. Whether moderate, severe, there is no need to adjust the dose. Who is actually the patient for Cibrava? Like I mentioned at the beginning of this presentation, we have patients that are actually very high risk. We have the patients that are moderate risk. We have the patients that are actually high risk. But for the purpose of this discussion, I will tell you that the ones in red, especially patients with myocardial infarction, patients with MI, patients with angina, patients with first incident, I don't think you want them to come back down with the second incident, because that patient might not be lucky to come to your clinic. Those are very clinically high-risk patients. For such patients, even if you have added statin, please, let's monitor their LDL-C. Not just total cholesterol, not just that the report that was sent to you is normal, but we need to actually investigate to see that their LDL-C is on target. And to achieve that target, that means that irrespective of the medication we've given for these patients, that patient should be achieving about 55 milligram per DL or 1.4 millimole per liter. If their LDL-C is not at this target, then you need to do more for those patients. Because ignoring that, you might be taking care of their hypertension, you might be taking care of their hypertension, taking care of their diabetes, but I can tell you, it's just a matter of time. You might not see that patient again due to ASCVD events that patient might have. And I don't just want this patient to follow the numbers. We want them to enjoy the quality of their lives, because at that age, most of these patients, they want to celebrate wedding of their children. They want to celebrate their 80th birthday. It will be good, not while the birthday is going on, for them to slump, but it will be good to actually support these patients and give them the right medication in managing their ASCVD event. Also, patients with familial hypercholesterolemia, these are high-risk patients. And for this patient, or even patients with high blood pressure, as high as 180/110, systole 180, diastole 110, we need to check their LDLC. For them, LDLC goal or target for such patient should be around 70 milligram per DL or 1.8 millimole per liter, depending on the units that you are comfortable with. And if the total cholesterol is actually above 310 milligram per DL, these are high-risk patients. The target for this patient should actually be 1.8 millimole per liter. Of course, if the patient is a DM patient with target organ damage or early onset of type 1 diabetes, or patient with familial hypercholesterolemia, the target for this patient is, remember, 55 milligram per DL. But if the patient is with a DM patient without organ damage, for this patient, the patient has had diabetes for over 10 years. This is an high-risk patient. The target goal for the LDLC of this patient is actually 1.8 millimole per liter or 75 milligram per DL. If the patient is a documented ischemic stroke patient or a TIA patient, these are high-risk patients. If the patient is a severe chronic kidney disease patient, these are high-risk patients. We need to manage them. Even if it's a moderate chronic kidney disease, this is a high-risk patient. The target goal for high risk is actually 70 milligram per DL. In summary, Cibrava can help you achieve just twice a year dose, one now, 3 months loading dose, and likewise 6 months after. Then subsequently, every 6 months. Remember, Cibrava is highly effective, it's sustained, and it can help you achieve that target that you want for that patient that you have re-stratified. It's generally well tolerated. And also it's a drug of choice to deliver that patient from the ASCVD event that is happening all around us. The essence of this meeting or this gathering or presentation is not just only for knowledge, but when you have those patients in your practice, you want to reduce the burden of ASCVD. The essence of information is not just for knowledge, but for action. Please prescribe Cibrava for your high risk and very high risk patient. Thank you so much.
Would like to take a couple of questions and answers, maybe one or two, so that we can get back on track with our program and the other presentations. Do we have questions? 2 questions? Or perhaps I might just direct him to deal with you one-on-one, which might just be a better arrangement. Do we have any questions? I believe your presentation was on point. Please give him another round of applause. And feel free to approach him and his stand for further questions. Thank you very much, sir. Can we have the next presentation, please? Redus, are you here? Yes, okay. Can you quickly identify your presentation at the table there while we call you up? This is a free event for networking. So please, the Novartis team are there seated. If you have any questions, kindly approach our presenter, Dr. Shosami, directly for more one-on-one consultation. Here, he will not charge you. So please, go ahead and do that so that we can have sound follow-up and capacity building. There's a forerunner. I think it's black with plate number KTU 200AQ. KTU 200AQ. Please, you are obstructing traffic. We need you to kindly repark rather urgently. Housekeeping. The conveniences are at the back. In the exhibition stand, you'll find them appropriately labeled male and female. The female is to my right, the male is to my left. And if you fall in between, then I think you have to find somewhere else to do whatever you need to do. You know, nowadays you have to be very careful. Some people are she, them, they, it, and so on and so forth. But as far as this program is concerned, we'll stick to the male and female. So please, to your left and to your right, you'll find the conveniences for this hall. Kindly, if you are the owner of the Forerunner SUV, KTU 200 AQ, please go to your car and help us to repark. You're creating obstruction for traffic. Our online members, we hope that you're enjoying the streaming so far and you found that lecture very, very fascinating. We go on quickly to the next one as we introduce the representative from Redus Center for Digestive Health for their presentation. Music, please. Maybe I should use this up. Several people that came into the hall while the presentation was going on. Would just like to acknowledge everyone and welcome them specially once again to this annual general meeting and scientific conference of the ANPMP. I'm finally getting the hang of ANPMP. I struggled for many years to change from AGPMP to ANPMP. But I think finally we're getting there. You're welcome. If you came in while we were here, the theme remains building resilient private healthcare systems in Lagos State. The driver for public-private collaboration, economic stability, and good governance. Would like to welcome our chairman, ANPMP Lagos State. He's very welcome. Dr. Jonathan Esegine is our Oga at the top for today's event. You're welcome. Professor Francis Adedayo Faduyile, OON, the former president of NMA, you're welcome. Please, I think you can give them a round of applause. Thank you very much. Dr. Demola Denloye, you're welcome. Dr. Austin Aipo, National President HC PAN, you're welcome. The Oga of all Ogas, Dr. Jimmy Arigbagowo, you're welcome. Thank you for gracing this place with your presence. Dr. Makinde Akilembola, our immediate past chairman, you're very welcome. Dr. Vincent Taiwo Faleti, our zonal chairman for our Papa Zone, you're here. Welcome. Thank you very much. And all our chairmen from the various zones of ANPMP here present, you're all welcome. Thank you for gracing this place with your presence. Dr. Biodun Otusoya, Dr. Akin Soya, I will not bore you with details. We have a representative of the medical director from Arjolad here. I think he's ably represented by the administrator, the medical administrator, Teguno Ogumo. You're welcome. Thank you very much for attending. We have so many people here, our representatives from the Medical Guild are here, and of course, the Guild of Medical Directors. I believe Dr. Omoni Fagbemi is here as well. You're welcome, sir. Thank you very much. I believe you're also representing the national president, Dr. Abiodun Kuti. Our regards to him. Thank you very much. There's so many people that are here. Everyone is special and highly welcome. Would like to put you all here. Is she ready? What's happening with the Redus presentation? Okay, so we'll move on to the next presentation while we give them a few minutes to sort you out. Can we have the AfriMedical team come up for their own presentation, please? AfriMedical, are you here? Can you indicate? Oh, you are. Okay, so please. Afri Medical, you have 10 minutes.
Good morning. Good morning. Sorry, please, can you hear me? I can't actually hear. Can you? Thank you. Thank you. Good morning. My name is Daniela Egbe. I am the marketing manager for Afri Medical Manufacturing and Supplies Limited. It is a great pleasure to be here to have this opportunity to be part of this event. This is actually the first time that we are participating in this event, and thank you so much for having us. Please permit me to begin with my event and also to stand in all protocols. Thank you so much. I will start with the introduction of Afri Medical. Afri Medical Manufacturing and Supplies was established in 2019 during the COVID-19 era, and we started off by producing face masks, surgical and the KN95 non-surgical face mask. Shortly after, we moved to the production of syringes. Today, Afri Medical is one of the largest syringe manufacturing companies in Africa, producing 1.8 billion syringes per annum. We have our factory here in Nigeria, which is built following WHO standards. And Afri Medical is an ISO 9001-2015 and ISO 13485-2016 certified company. Also, Afri Medical is certified by the Nigerian Medical Association. Recently, we were privileged through hard work to be pre-qualified by WHO for our 0.5 ml. So Afri Medical is also a company that is part of Meccano International. I know that a lot of people know Meccano for generators, but we are much more than generators. Meccano has 6 divisions, and Afri Medical is the medical division, as well as the motors and the power and the construction and entertainment and food. Afri Medical produces AfriJect syringes. Currently, we produce 5 different syringes. That's the 0.5 ml syringe, 2 ml syringe, 3 ml, 5 ml, and 10 ml syringes. I'm not here to talk about syringes because as professionals and in the field, much more than I, the doctors already know what the syringes can do. But I believe that we are the only ones making the 3 ml syringe in the country. These are syringes manufactured with 30% less plastics than other syringes found in the market. Our syringes are also sterilized using the electron beam sterilization technique. We are the only country in the only factory in Africa using the electron beam. And that means that we can produce syringes this morning and sterilize it and have you pick it up in the evening. So we have the capacity to do that. We don't take long. It doesn't take 2 weeks to sterilize our syringes. Also, I've mentioned that our syringes are certified by ISO standards and also the WHO PQS. This is our 2 ml syringe. And this is our 3 ml syringe. This is our 5 ml. And this is the 10 ml syringe. We also have the needles, 21G needle separately packaged and the 23G needle separately packaged. Before I go further, our stand is just by the corner there. Please come and see us and have a look at our products and also ask further questions if you would like to do that. We'll be very happy to welcome you. This is our surgical face mask. We don't do the non-surgical anymore. That we have stopped producing. This is the KN95 face mask. Thank you so much for having us. I don't have much time as I was told, so I went straight to the point. Before I leave, I would like to play you a video of our factory. For those of you, I've seen some familiar faces here who have been privileged and opportune to come to our factory. We are also extending an invitation to the ANPMP to come to our factory. We are open and welcome and are open to welcoming anyone that is available and ready to visit our factory. Please come and see us. Please, can you play the video? Thank you so much. I hope that we have a very wonderful conference. Thank you.
Welcome to AfriMedical Manufacturing and Supplies Limited, a beacon of innovation and excellence in healthcare solutions. With a distinguished 30-year legacy, AfriMedical stands at the forefront of reshaping healthcare in Africa. Step inside the state-of-the-art syringe factory of AfriMedical, one of Africa's largest,
with a remarkable annual capacity of 1.8 billion syringes.
Behold the well-organized plastic storage area where essential materials await their transformation. Advanced machines diligently create precise molds. The injection molding process takes form under the guidance of rigorous quality checks and advanced measurement devices. Here, precision reigns supreme, ensuring that each syringe meets our uncompromising standards, a testament to our dedication to global medical needs. Every detail is scrutinized, every process refined. With utmost care, each syringe is wrapped, ready to be securely stored in cartons. Our commitment to excellence extends from manufacturing to packaging and beyond. Our dedication to precision, safety, and efficiency is mirrored in every syringe leaving our facility. This ensures the highest level of safety and sterility. Finally, our journey leads to a spacious and secure storage area, where the finished and sterilized syringes await distribution to medical institutions and professionals across Nigeria and Africa. AfriMedical Manufacturing and Supplies Limited, positively impacting lives.
Where her stand is, please feel free to approach them for further discussions and purchases. We'll go on to the next presentation, which is by Hisamitsu. Salopan's presentation.
Good morning, distinguished ladies and gentlemen. All protocols duly observed. My name is Oge Sholadoye, and I'm the marketing lead for Hisamitsu Pharmaceuticals, the world leader in transdermal technology. This company has been in existence for over 150 years. It's a Japanese company with presence in over 35 countries all over the world, including the US, Canada, and the UK. And today I'll be talking to you on the topic from evidence to practice, safer pain relief through innovations in topical therapy. And then the sub-tagline is reducing systemic risks while optimizing patient outcomes. So I've talked about my company, so I won't dwell here, but it's a Japanese company, the world leader in transdermal technologies. Now, first thing I'll talk about is pain. We're discussing safer alternatives to pain management in our patients, right? So it's important to call to mind the global clinical burden that pain is. And WHO states that 1.7 billion people worldwide come down with pain in some form, especially the elderly populations, active adults, and patients with comorbidities. It reports an annual incidence of up to 80% of adults experiencing pain, and it is stated that 20% of the patients that you see in your primary practice will come with one complaint of pain or the other. So it's a significant health burden. But another key thing I would like to call out about this burden is the fact that Insight has shown that there's a high prevalence of the use of systemic NSAID prescriptions. Now, many times, there are many options to management of pain, including systemic analgesics, topical analgesics, adjunct therapies and all. But in the Nigerian market, a lot of people a lot of doctors and physicians prescribe systemic analgesics. So the study in Luth showed that there is 22% of patients were given NSAIDs, systemic NSAIDs. And then another study showed that there's common use of NSAIDs without gastroprotective agents. And that's a red flag, because if you're prescribing NSAIDs without gastroprotective agents, you know how that increases the risk of gastrointestinal side effects. But the studies show that a lot of prescription of NSAIDs are happening without gastroprotective agents. Now, another interesting point to note is that self-medication with NSAIDs is also on the increase. A study in Jos showed that many people are using high amounts of NSAIDs on their own, which is defined as 5,000 pills over a lifetime. So it's important that we are considering the fact that and that's why I'm here to talk about safer, more innovative options in management of pain. Now, what are the risks associated with the use of systemic analgesics, opioids, NSAIDs that I've just mentioned? The first is gastrointestinal. We're all aware of the fact that there's an increased risk of gastrointestinal. Contains methyl salicylate. So I'm sure that some of us are already aware of some patches existing, but this one is backed by science. It's an orthodox patch. It contains actual active ingredients that you all know, methyl salicylate, which acts as a counter-irritant, which also works as a COX-1, COX-2 blocker.
and also has some local anesthetic effects. So methyl salicylate level menthol, there are some of our patches that contain camphor. Now these three powerful analgesics act synergistically to mediate the pain relief that you see with Salonpas. Now, one of the advantages of these over oral medications is less side effects, targeted relief for your patients. That means that if you're given the medication, oh, fantastic. Thank God it's come back up. All right, so I'd already introduced the product to you. I've talked about what it is. I've talked about how it works. Apply the patch directly to the site of pain, and then methyl salicylate and menthol is absorbed through the skin to the tissues, and then the patient feels pain relief for at least 8 to 12 hours. So this is what it looks like. So it acts locally. We have a couple of... we have some patches that work, that act systematically, but this particular patch is formulated in such a way that it acts locally around the muscles where the patch is applied. And I've talked about a little bit about the mode of action and how methyl salicylate, menthol, and camphor work synergistically to help the patient achieve pain relief. What are the dosing recommendations? First, let me even talk about the indication. It is positioned for the management of mild to moderate musculoskeletal pain. So we're very clear about what what Salonpas is positioned for. Mild to moderate musculoskeletal pain. And this is based on the fact that our research shows that it's effective in this type of pain. So include back, knee pain, arthritis, management of pain. And then the dose is 1 patch per site every 8 hours. If you have a wide surface area for the pain, you are free to do up to 6 patches, depending on how wide the surface area is. So you can use up to 6 patches, or you explore using the spray because it also comes in spray format. Now, one interesting thing I want to pull out before I leave is the fact that Salonpas is backed by clinical studies. Now, we have a study that was conducted in Florida, a multi-center study, where they recruited 208 patients and placed them on either Salonpas or placebo. It was double-blind randomized study. And what they were checking for was, the recruited patients had mild to moderate musculoskeletal pain. And the primary endpoint they were checking was the sum pain intensity difference over 8 hours. So they were checking the pain intensity every hour for 8 hours. And aside from that, what they were using to check was the visual analog scale, giving it to the patients to give feedback. Now, what did this study show? The study showed that for the patients who were on Salonpas, there was 40% greater pain relief versus those that were, on placebo. And that's very significant, And it calls to mind the fact that I told you that I know you have experienced other patches, but this particular patch is backed by clinical studies conducted in the US. Another interesting thing about it is that it is the only patch that has the US FDA approval. And if you know anything about the US FDA approval, it involves a lot of stringent studies, a lot of stringent tests to certify that whatever the product is claiming to do, it is able to do. So we have the FDA approval. We also have our own clinical studies that show that this product is effective. Now, aside from being effective in managing the efficacy end goal, it also showed very good results regarding the safety profile because there were near zero side effects with the patients who were on Salonpas pain relief patch. Now, Salonpas also comes in jet spray format as well. Contains the same thing, methyl salicylate and level menthol. Now, what makes our spray different from other sprays is that immediately you apply the spray, there's an immediate drop in temperature of about minus 56.9 degrees Celsius. And with that drop in temperature, your patient experiences immediate relief. In line with the 4 cardinal signs of inflammation, a drop in temperature immediately gets the patient to feel some relief. So it's very effective, it's fast acting, it's easy to apply. And then it has a targeted nozzle. We'll make sure that the exact amount you need comes out per application. So there's almost zero wastage with Salonpas spray. With other sprays, you have a large amount coming out that might not be needed for the purpose of managing the pain. So it's very effective. You get more applications per bottle versus other pain sprays. So we have the Salonpas patch and we also have the Salonpas spray. So how do we apply Salonpas? So this is the place where we would usually do a demonstration. I don't know if I have the go ahead to do it present. Okay, so please come with a patch. Do you have a patch there? Give me one patch. So I want to show you because for this product, it's very important that we are applying it right, and our patients also understand how to apply it so that they can get the best outcomes. So I have the patch here. This is what it looks like. It comes in a pack of 10 like this. It's at our stand over there. And when you're about to apply it, here, please let me tear it up. Yeah. Okay. Bring it up. Yeah. So this is what it looks like. It really looks like a plaster, but like I said, it's not just a plaster. This is 90 years of continuous Japanese, improvements of products. This is 90 years of product, a very good product that's world #1 pain relief patch in the market. So, first thing you do is to remove, just hold this, is to remove from the film. So there's a green film. Now, you don't remove it all at once because the adhesive is really sticky. So if you remove it all at once, you run the risk of the patch sticking together and you will not achieve the desired outcome. So you do halfway and then apply it to the site of pain. So in this case, I'm going to apply just for demonstration purposes here. So let's assume she has pain here. So I stick the part, I put on the half part that I've removed, and then I pull the green film. And then I smoothen the edges. And that's it. Now, she can keep this on for the next 8 hours. And in that 8 hours, she's able to achieve pain relief for that 8 hours. Right? So that's how to apply. Usually we would ask, there's a free sample for everyone at the conference today. And we are actually giving out at least 50 samples for everyone who attends the conference today. So you can use it in your practices and for yourself, see the magic of this product. It's not magic, it's science, but people describe it as magic because when they see how effective it is, they would usually say it's magic, right? So, finally, in rounding up, I'll speak to when to recommend Salon Pass. First, as a first-line therapy, the American College of Physicians recommend that we always start for mild to moderate pain, you should start with topical analgesic. That is the guideline recommendation as a first-line therapy. Because of the safety concerns with patients, the recommendation is to start with topical and then gradually move up if the topical does not work. So Salon Pass is one option here. You can apply it for patients. You can prescribe it for patients with mild to moderate musculoskeletal pain, patients with contraindications to systemic NSAIDs, peptic ulcer patients, geriatric patients, because you do not want to be giving these geriatric patients products or medication that would further make their situations worse. Then you can also explore using it as an adjunctive therapy. So in addition to, as part of your multimodal analgesic protocol, Salon Pass can be used with other NSAIDs or other systemic analgesics. Then you can also use it as a step-down strategy if you're tapering off systemic opioids or high-potency NSAIDs. If your patients, you don't want them to, when you're taking them off opioids or you're reducing the dosing, to manage breakthrough pain, Salon Pass pain relief patch or Salon Pass pain relief spray is a good candidate for this. And then also it can be used for intermittent management of breakthrough pain in patients on scheduled oral analgesics. So in between doses, if in case you don't want to do a TDS dose on diclofenac, you want to do a BD dose, you can recommend Salon Pass to be applied in between the dosing to also manage breakthrough pain. So it's a product that is it's a product in its time. A product that will help ensure that your patients are able to get a safe and efficacious solution to pain without having to worry about the risks associated with other NSAIDs. So this is just a profile of some patients. A lady called Miriam, 30-year-old, peptic ulcer disease. She works in a bank. She's having shoulder pain. She comes to you to complain of shoulder pain. Salon Pass pain relief patch is an option for her. It manages her pain without her having to worry about a heartburn associated with her use of NSAIDs. This is Fred, who is a fitness instructor, exercising and then gets a sprain in his ankle. Salon Pass spray is a solution for that patient. You also have a Dr. Ajayi, who is 60-year-old. She's recently diagnosed with mild arthritis. She's currently using glucosamine and a couple of other medication. She can use Salon Pass pain relief patch to manage her breakthrough pain. Same situation with Mr. OK, who is a hypertensive patient. Salon Pass pain relief patch would help manage breakthrough pain associated with the use of other while she's using other NSAIDs. So finally, why recommend Salonpas? I'll speak to 5 things. First, onset of action. Salonpas has a rapid onset of action because it acts locally. So between 10 minutes to 1 hour, you start to see the effect of the pain relief when you apply Salonpas patch. Second, duration of action, extended analgesia. When you compare it to ointments, for ointments, because of the most ointment contains methyl salicylate, and we all know that substance evaporates easily and calls for repeated applications. Now, with Salonpas patch, the Japanese technology ensures that the methyl salicylate is locked into the skin for at least 8 hours. So that's reduced reapplication, longer duration of action versus other topical options. Safety profile. Salonpas comes with minimum systemic absorption and a favorable safety profile, fewer side effects as compared to systemic analgesics. Easy to use. With topical ointments, for example, you may need to massage to make sure that the active ingredient gets in right. You may have to deal with stained clothes. With Salonpas patch, you apply and move on. The technology behind it ensures that the active methyl salicylate passes through the skin to the muscle easily. With tablets, you have to swallow. Here, you don't have to swallow. You don't have to look for water. And for those of our patients who hate to swallow, have to make a bar every time they want to swallow. This is a solution for them. And then finally, patient tolerance. We are all aware that compliance is very key to getting the good medical outcomes or treatment outcomes. And with Salonpas patch and Salonpas spray, this easy compliance. Your patients are happy. It's easy to use. They're happy to use it. And that ensures that the therapeutic outcomes are good. So finally, thank you for your attention thus far. For patients with mild to moderate musculoskeletal pain, recommend Salonpas. Prescribe Salonpas. It's a safe, non-invasive first line or adjunct option for the management of mild to moderate musculoskeletal pain. And I would then hand over the mic now to the MC. Please, ma'am, may I say one thing? Like I said, every person who attends this conference is entitled to 50 free Salonpas patches that they can give out to their patients. Please, all you have to do is register. We will be sending our team down to your place to deliver the patches to you. And then even here, you are entitled to also get the patch, know what it looks like, and ask any questions at our stand. Our stand is not too far from here. Thank you so much.
Thank you very much for bringing this product to our attention. And thank you for the free sample gifts. We continue to recognize those that have come in. KBSC, you're welcome. Thank you. Dr. Anthony Omolola, you're very welcome. The program will go on with the other presentations that we skipped quickly so that we can go ahead and proceed with our opening ceremony formalities. Would like to take 2 presentations now before we go ahead to the opening formalities. I'd like to welcome everyone who came in while the presentations were going on. The hall is much fuller now. You're all welcome to the 2025 ANPMP Annual General Meeting and Scientific Session Program, running today, the 10th of September, and tomorrow, the 11th of September 2025. Thank you for making time to come here, and please make the most of the opportunities that are presented here. Redus, are you ready for us? We'll take the Redus Center for Digestive Health program presentation, and then we'll also take a quick one from Mega Life Sciences as well immediately afterwards. Thank you.
Hello, can you hear me? Good morning, everyone. How are you doing today? Okay, while we wait for the presentation, I want to introduce myself. I'm Pepe Chambanefo, a medical doctor and the Chief Operating Officer at the Redus Center for Digestive Health. Today is our first attendance at this event. We opened our doors to clinical operations this year, April, so we're quite still young. So we're a center focused on the digestive system, from the mouth to the anus. We take care of it comprehensively. These are the common symptoms and conditions that we've seen and that we attend to, which I'm sure most of the medical practitioners here are aware of. So we see patients with peptic ulcer disease, hemorrhoids, reflux disease, liver diseases and hepatitis, colorectal cancer, appendicitis, because we also have a general surgeon with us at the center, cholecystitis, gastric cancer, irritable bowel syndrome, inflammatory bowel disease, and some others. Vomiting blood and stool, and all of that. Now, we set up the center because we have observed a heavy burden of chronic hepatitis and liver cancer. So this statistic shows that about 20 million people are chronically infected with hepatitis B and C. And of this, about 95% of the people who are infected with hepatitis B virus are unaware of their status. So this is quite alarming. Many of these people will progress to cirrhosis and possibly liver cancer. Thank you. Okay, so you can agree with me that this is a huge burden of the disease. And it's alarming that many people with hepatitis are unaware. And this will mean that there's high chance of them infecting other people and of them, presenting later at centers for care. So digestive cancers are among the most common cancers in Nigeria. From these statistics, you can see about top 5 cancers in Nigeria in male and females, of which you can see colorectal cancer and liver. In both sexes, you can also see liver and colorectal cancers. So you can agree with me that digestive cancers are quite common. Now, this is our center located at Lekki Phase 1, actually at plot 40A Ima Abimbola Co. We welcome you to our center if you're ever on the island or if you want to come and visit us. We are a dedicated center with comprehensive digestive health. Now here's our mission. So we want to address the crippling burden of digestive and liver diseases in Nigeria and sub-Saharan Africa. How do we want to do this? Through the provision of empathic and world-class gastrointestinal care in dedicated and comprehensive digestive disease and endoscopy center. Here are some of the programs that we have. We're a center for interventional endoscopy. So we do endoscopy, we do ERCP, we have endoscopic ultrasound scan. We're also a program for hepatitis and liver diseases. We also offer GI surgery programs, including minimal invasive like laparoscopies. We also focus at handling cases of inflammatory bowel disease and colorectal cancer screening. Welcome again to Radio Center for Digestive Health. On behalf of our humble Chief Executive Officer and Medical Director, Dr. Kenechukwu Chudi Onwugaje, I want to invite you to our center and to let you know, if you can see that screen, that is an endoscopic ultrasound procedure going on. And I believe that we have one of the centers that have this endoscopic ultrasound scan from Fuji here in Lagos, Nigeria. This is our conference room, one of our patients' rooms. These are our reception area, and these are some of our consulting areas, our pre and post suites, which is where we care for people coming in for just routine endoscopies, people coming in for procedures, whether it's for ERCP, EUS, or any GIT, open or laparoscopy. So here are some of the consultations we offer, both in person and virtually. General gastroenterology, liver diseases, interventional endoscopy, general and colorectal surgery, anesthesiology, internal medicine, nutrition, and dietetics. You agree with me that most of the problem with digestive health cannot be fully solved without the help of a dietitian. So we have this comprehensive team on ground at the Reader Center for Digestive Health. And especially now that we're seeing most patients coming in with Crohn's disease, inflammatory bowel diseases and all of that. So it's important that as we're caring for them, that we loop them in with the dietitian for close monitoring and dietary plans. Here are some of the general endoscopy services that we offer. Upper GI endoscopy, flexible seismoidoscopy, colonoscopy, including polypeptomy. This we see often, and we do cold snare. Sometimes we use hot snare. Sometimes we also use the biopsy just to take out the polyp. We also offer small bowel endoscopy, via push enteroscopy, and video capsule endoscopy. We're seeing a lot of patients coming in there, and after having done either upper endoscopy or colonoscopy, the problem has not been found until they come for video capsule endoscopy. And for this kind of patients, most cases of inflammation might be quite minimal for endoscopy to visualize. But with the video capsule endoscopy, this actually aids us to diagnose this. We also offer percutaneous endoscopy, gastrostomy tube insertion and removal, variceal and non-variceal hemostasis, foreign body removal. Some of the interventional endoscopy services we have include, interventional endoscopy, of course, this employs advanced technology and techniques with endoscopes to diagnose and treat diseases and conditions in the GIT, bile duct, pancreas, and liver. We've had a patient that was sent to us just because there's a pancreatic mass, but they need to biopsy it. With the endoscopic ultrasound scan, you can access the pancreas, visualize it, and actually take biopsies. So some of the procedures are endoscopic retrograde cholangiopancreatography, which is our ERCP, quite a long one to pronounce, endoscopic ultrasound, stenting for obstruction due to either GI cancers. We've also stented people having, obstructions, and they are unable to swallow or retain food. Endoscopic mucosal, thank you. Endoscopic mucosal resection, endoscopic mucosal dissection. Some of the benefits of this are minimally invasive approach, avoidance of the traditional surgery, patients recover faster and they have a shorter stay in the hospital. Outpatient care, reduced complications as well. Providing advanced diagnostic and therapeutics in Nigeria, in Lagos to be precise. Dedicated comprehensive center for digestive health in Nigeria, and we provide a full spectrum of care, like I mentioned earlier, which includes gastroenterology, hepatology, general surgery, laparoscopy, interventional endoscopy, and nutrition care. We're the first endoscopy ultrasound program started here in Nigeria. We're a first comprehensive center for interventional endoscopy in Nigeria. We're the first full-service ERCP center in Lagos and second one in Nigeria. That's second to Ife, of course. Our values include compassion, excellence, respect, and innovation. All these four things are the guiding principles to what we do at the Reader Center for Digestive Health to ensure that we provide the best quality of care for our patients. Our CEO, Dr. Kenechukwu Chudionwugaja, would have been here, but he had to return to the States. He is an interventional endoscopist in the United States, and he sends his regards. Thank you, everyone at ANPMP. This is our email and an address. We have a booth by the other side. If you want to meet us, I will be in the crowd somewhere to say hello or just to connect. Thank you so much. Bye.
Thank you very much. Thank you very much. We take the next one quickly from Mega Life Sciences, and we kick off our opening ceremony formalities at 12 o'clock. Please introduce yourself. You have 10 minutes.
I would, as a proper Ekiti girl, I would like to say good morning, Kabiesi, sir. And then after that, please permit me to stand on existing protocols. Ladies and gentlemen, good morning. I am Essien Ekong from Mega Life Sciences, Nigeria Limited, and I'm okay. Greetings from Mega Life Sciences, Nigeria Limited. I know you know that Mega is a human wellness company. We have several products you can prescribe for your patients. We have Inert Natural Vitamin E. We have Livolin, the 3-in-1 liver protector, Ferrotone, Vitacap, etc. But the one I'm here to talk about today is Ginsomine, the ideal co-prescription for your patients with immune system stress, oxidative stress, or physical stress. And if you ask me, all of us in this room should be on Ginsomine, 1 capsule daily. I can assure you there's nobody in Lagos who doesn't have one form of stress or the other. Okay. So I know you know the human body has basic needs, micronutrients, vitamins, minerals, and others. And I know you know that ideally our diet should be the best source of vitamins and minerals. But for many reasons, we do not eat what we should eat, and so we need supplements. And what are supplements? Vitamins, minerals, and others that we take in addition to augment to complete our nutritional needs. But that is for you and I. For your patients who are then ill, there are many things to consider to make you give them supplements. Number 1, there is the primary inadequate intake from their diet. Your patients ab initio may lack vitamins and minerals. Number 2, disturbances in absorption. But the major reason why I'm here today, increased tissue requirement of vitamins and minerals for your patients when they are ill. I know you know that during illness, there could be increased metabolism, and there's a lot of nutrients that is utilized, especially in diseases where there is increase in temperature. There could be tissue catabolism. There is immune system support, especially when you need to give anti-infective agents, and there could be nutrient loss. So, another reason, oxidative stress. Oxidative stress. When there are free radical damage to the tissue or some other organs, and such free radicals include reactive oxygen species. Oxidative stress occurs when free radical damage exceeds the body's ability to cope. Normally, we produce antioxidants. But when the stress is too much for the body to cope, there could be wear and tear. And so the imbalance can happen for many reasons. Maybe there is chronic diseases. Maybe there is stress. Even the aging process itself can make the body prone to oxidative stress, in which we have more free radical damage than we have the ability to cope with antioxidants. And I know you know the sources of oxidative stress are all around us. Environmental pollution in a city like Lagos, toxins, etc. But I'm here today to talk about some supplements you can prescribe for your patients. Remember, diet remains the best source. but for some reasons you prescribe. So which supplement should you prescribe in your clinic for that patient? What supplement should you prescribe? Ladies and gentlemen, please prescribe ginsomine. Please prescribe ginsomine. Ginsomine contains 11 vitamins and 9 minerals in addition to ginseng. All the fat-soluble vitamins are present in ginsomine. In addition, not just that they are present, we have natural beta-carotene in ginsomine. We have natural vitamin E in ginsomine. We have zinc, we have selenium. All the vitamins and minerals that your patients need, we have in ginsomine. And I know you know ginseng is the king of herbs. Why do we call it the king of herbs? Why do we even add ginseng to supplements? Ginseng is an immunomodulating herb. These are herbs that strengthen the immune system. And Panax ginseng has been found to enhance phagocytosis, natural killer cell activities, etc. And a 2009 clinical trial confirmed that Panax ginseng improves the prognosis of HIV-1 infected patients in addition to all the other ingredients in ginseng. This is the trial that was done. This was done with HIV-positive patients that were on ginseng. They checked the CD4 count before and after, in addition to antiretrovirals. It was discovered that those who were placed on ginseng plus antiretrovirals had an annual increase in CD4 count greater than those who were not placed on ginseng. And since that time, we started to add ginseng to supplements as an immunomodulating herb. So ginseng also improves overall well-being. There are many studies that have been done with ginseng, including improving libido, the urge for sexual satisfaction. So, among the supplements in Nigeria, ginseng has one of the highest content of ginseng. Some have as little as 900 microgram, which is not up to 1 milligram. But your patients may not know the difference. They think 900 microgram is more than 50 milligram. And that is why I'm here today. Please prescribe ginsomine and let it be ginsomine. Tell your pharmacist to buy ginsomine and stock in the hospital for your patients. 1 capsule daily. So all supplements are not the same. The formulation varies. What the human body requires vary. Raw material used varies. Formulation technology, quality of the packaging varies. So for ginseng, ginsomine has ginseng. Ginsomine has all the water-soluble vitamins, B, C. It has all the fat-soluble vitamins and all the antioxidants that your patients need. So instead of prescribing vitamin C, prescribing B-co, prescribing vitamin E, just write ginsomine, 1 capsule daily at breakfast. 11 vitamins, 9 minerals. Dosage, 1 capsule daily at breakfast. 1 capsule daily at breakfast. And after 2 months, take a break for 1 week. Another reason why you should give your patients ginsomine. I know you know that our diet is the best. But studies say that 70% of Nigerians live below poverty line. Can they afford that avocado pear? Can they afford that soursop? Can they afford even orange or apple? Give them ginsomine at a cost of less than 250 naira per capsule, less than the cost of a bottle of Coke. you are giving them 11 vitamins, 9 minerals in addition to ginseng. So, Ginsomine Ideal Co-prescription for your patients. I also want to remind you of Livolene, the 3-in-1 liver protector from Mega Life Sciences Nigeria Limited. It has phosphatidylcholine. I know you know liver cells are made of phosphatidylcholine, and that is what the liver uses to rebuild and repair itself. Livolene also has the B vitamins and has vitamin E. And in the management of liver disease of various etiologies, please prescribe Livolene. And we have a liver risk assessment test in Nigeria. If you will be kind enough to help me scan to do your liver risk assessment now, I will leave it on so you can scan while I finish. I have 22 seconds left. So please scan to do your liver risk assessment test from Mega Life Sciences. My bosses have said that we will give samples of ginsomine to the first people that come to our stand. You all deserve samples and we will give. More importantly, we want to interact with you at our stand. We want to get to know you better. And if there are ways we can collaborate, we will do so. But please remember, ginsomine, 1 capsule daily at breakfast for yourself and for your patients. With love from Mega Life Sciences Nigeria Limited, makers of ginsomine and Livolene Forte. Thank you very much. While you're waiting, my time is up. I am grateful for your...
Thank you very much. Please note that all our presenters have exhibition stands and they are open for collaboration, they are open for partnership, they are open for purchase, wholesale, retail of their products as have been presented. Kindly patronize them throughout these next 2 days. I can see that the tea break is quietly going on. I believe they're taking it table by table. So we'll allow that to happen for about 5 minutes, 10 minutes, so that we can get the hall to settle back down again. And then we can proceed with the opening ceremony formalities. Can we have some music for the next 5 minutes, please? 5-10 minutes.
Association of Nigerian Private Medical Practitioners, ANPMP, Lagos State, presents 2025 Annual General Meeting and Scientific Conference. Theme: Building Resilient Private Healthcare System in Lagos State, a strategic driver of public-private collaboration, economic stability, and good governance. Chairman of the occasion, Dr. Essien Ekong, Consultant Orthopedic Surgeon and CMD, Doren Specialist Hospitals. Keynote address, Professor Francis Adedayo, Faduyile, OON, former President, NMA. Chief host, Professor Akin, Abayomi, Honorable Commissioner for Health, Lagos State. Host, Dr. Jonathan Esegine, DMP, Chairman, ANPMP, Lagos. Date, Wednesday 10th September to Thursday 11th September 2025. Venue, Welcome Center Hotel, International Airport Road, Ikeja, Lagos. Time is 9 a.m. daily. This hybrid event will be streamed live on Decrew Media Studio. Subscribe today for instant notifications when event goes live. Announcer Dr. Tunji Akitade, TMP, Chairman, Planning Committee, HEM/SC 2025. Association of Nigerian Private Medical Practitioners, ANPMP, Lagos State, presents 2025 Annual General Meeting and Scientific Conference. Theme, Building Resilient Private Healthcare System in Lagos State, a strategic driver of public-private collaboration, economic stability, and good governance. Chairman of the occasion, Dr. Essien Ekong, Consultant Orthopedic Surgeon and CMD, Doren Specialist Hospitals. Keynote address, Professor Francis Adedayo, Faduyile, OON, former President, NMA. Chief host, Professor Akin, Abayomi, Honorable Commissioner for Health, Lagos State. Host, Dr. Jonathan Esegine, DMP, Chairman, ANPMP, Lagos. Date, Wednesday 10th September to Thursday 11th September 2025. Venue, Welcome Center Hotel, International Airport Road, Ikeja, Lagos. Time is 9 a.m. daily. This hybrid event will be streamed live on Decrew Media Studio. Subscribe today for instant notifications when event goes live. Announcer Dr. Tunji Akitade, TMP, Chairman, Planning Committee, HEM/SC 2025.
Ladies and gentlemen, please, the owner of the vehicle with Kano plate number TRN20AL parked in the underground car park, please can you repark? You are obstructing the free flow. Can you please repark? Kano plate number TRN20AL underground car park. Please repark. Thank you. Do our doctors have their gowns here? Ladies and gentlemen, please, do our doctors have their gowns here for the procession? Yes. The PMP grounds for the procession. Do you have them here so that we can take the procession during our opening ceremony formalities? You do? If you have your gowns here, please say aye. Can you reduce the volume, please? Completely cut the music out. Thank you. Do you have your gowns here? If you do, please say aye. If you don't, say nay. It's looking as if the nays have it, not the eyes. If you have your gowns here, please say aye. No, we don't have adequate representation here for that. So we'll take it as done. Can the ushers please take care of serving this tea break so that we can continue with our formalities? Ladies and gentlemen, please let us proceed with the opening ceremony formalities in exactly 5 minutes. You don't have your guns. They don't have it. stand up for 1 minute and let us take the national anthem? Can we have movement? Cease while we take this, please.
We hail thee, our own dear native land, though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace all battle honored, and this we count as gain. To hand unto our children a banner without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty, Nigeria may be blessed.
Amen. Maybe we should change it to Nigeria shall be blessed in our generation. I'd like to call on Reverend Dr. Anthony Ewodaga to please come and take the opening prayer.
Hello. Please, before I make the opening prayer, I would just want to make a short announcement. You can notice that there were some seats reserved in this hall. There are about 4 seats this way. 1, 2, 3, 4 reserved. And there's a seat here reserved. Please, our elders and DMPs, FAGPs that are here, can please occupy those seats now. 1, 2, 3, 4. And the other seat there. But there's only one seat that still remains reserved, and that's that seat. Please, whoever is sitting there can occupy other seats like this. And let us start this with an opening prayer. Can we rise on our feet, please? Father, we want to thank you. So many slept yesterday night, but this morning they are no more. We thank you because you have kept us till this morning, and you will keep us till the end of this year. In the name of Jesus. Father, as we are starting this program, give us direction. Guide us right. Show us what we need to know, so that at the end of this program, we will be better for our clients in the name of Jesus. And for those who have come from far and wide, we commit them unto your throne of grace this morning. Father, be with them. We pray that you grant them journey mercies in the mighty name of Jesus. Thank you, Father. In Jesus' name we have prayed. Amen.
Thank you very much. Can we please have the LOC chairman join me on the podium? I'd like to deviate a little bit by asking him to come and do due diligence and take the recognition of dignitaries here present as a prelude to his welcome address. Ladies and gentlemen, Dr. St. Akin.
Yeah. But meanwhile, can you announce this?
Once again, we have a vehicle obstructing traffic. Please, can you have the owner of BDG 326JR, a Corolla, BDG 326JR, kindly remove your vehicle. Thank you.
Thank you very much. My learned colleague and friend of so many years, Barrister Funke Oluwole. Thank you very much. Please, can we put our hands together for this beautiful damsel, please? My job is to recognize dignitaries, distinguished colleagues. But you know that this job is too numerous for me to do, because I don't know how many names I'm going to call. So I'm going to go into the welcome speech directly, where I've already laid down the protocol. So with the kind permission of our state chairman, Dr. Jonathan Esegine, DMP, I have the pleasure to welcome all of you. And I want to start, just like the previous speaker said, as a typical Ekiti. I want to start by recognizing the royal father of today, a dignified doctor as well, the Alara of Ara Kingdom, His Royal Majesty, Oba Dr. Olubayo Adeshola Windapo. Kabiesio. Thank you very much for honoring this program. I hereby start with my speech. The Honorable Commissioner for Health, Lagos State, in absentia, Professor Akin Abayomi, the Senior Special Advisor to Mr. Governor on SDGs, Dr. Oreoluwa Fini Awokoye, the Chairman, House Committee on Health, Honorable Musba Lawal, and of course, again and again and again, our Royal Father of the Day is Royal Majesty, Oba Dr. Adeshola Olubayo Windapo, the Alara of Ara Kingdom. The chairman of this occasion, very distinguished colleagues, a consultant orthopedic surgeon, Dr. Essien Ekong. You are highly welcome to this program. Thank you very much. We appreciate you. The Vice President, NMA, Dr. Tosin Oluwajabutu. The President, ANPMP, ably represented here by the Secretary General, Dr. Adedayo Gbadebo. We recognize the National President, Dr. K. Adeshola. The NMA Lagos Chairman, Dr. Babajide Kehinde Said. The President, Healthcare Providers Association of Nigeria, my very, very respected friend, Dr. Austin Aipo. A very amiable State Chairman, Dr. Jonathan Esegine, and his amiable wife. We recognize you, Barrister Muna Esegine. The President of Guild of Medical Director, Dr. Abiodun Kuti. He actually took an excuse to have similar program going on in Enugu right away, and is ably represented here by the State Chairman of Guild of Medical Director, Dr. Omoni Fagbemi, who is also the Chairman of the Guild of Medical Directors in Lagos State. Dr. Omoni, please, can you stand up for recognition? Please, can we put our hands together for these excellent gentlemen? The chairman, AGMPN, that is the Association of Nurses, Dr. Wale Oladokbo. The chairman, ACPN, Pharmacist Tolu Ajayi. The chairman, Guild of Medical Lab Scientists. My brother, comrade, Julius Adekoya. Thank you very much for gracing this occasion. We appreciate you. The chairman, HCPAN Lagos, Pharmacist Biola Pauloze, and the body of past state chairman. I think the oldest of the past state chairman seated with us here is actually a board member today and a past president. Dr. Antonio Molola is seated right here. So today, and that zone is the zone that has produced, outside the current president zone, that have produced practically all leaders in this association. Please, can we put our hands together for Isolo Ejigbo Zone, please. Dr. Jimmy Arigbabuwo. I know he's in blue suit, but he can't run away. Yes. Please, can we put our hands together for Dr. Jimmy Arigbabuwo? He's a past chairman of this great association. Is also followed by the body of past chairman I've mentioned. I succeeded Dr. Jimmy Arigbabuwo, and Dr. Makinde Akin is also here as a past chairman. We recognize you. Thank you very much for being with us. BOTs and past president of this association, again, I'm recognizing you. Is the fathers of this association, Dr. Anthony Omolola. Once again, please, can we put our hands together for him? Please. ANPMP. Thank you very much. And we are also honored to have another very distinguished past state chairman, past president, and a BOT, who is not even residing in Lagos, and he has graced this occasion, is always with us. And I want you to just join me in also recognizing Dr. Gabriel Oga. Thank you very much, Oga, for gracing this occasion. We recognize you. Fellows of this great association here present, DMPs of this great association here present, spouses of all doctors here present, our invited guests, gentlemen of the press, ladies and gentlemen. I welcome you all to this edition of AGM Scientific Content of the largest private medical practitioners in Sub-Saharan Africa, ANPMP, and member of World Organization of Family Doctors, Lagos State Chapter, this day, the 10th of September. Over the years, ANPMP has staged the state AGMs and Scientific Congress to examine our global policies and activities as it affects our medical practices, share experience in clinical medicine, and identify new gaps in our services to humanity. Distinguished ladies and gentlemen, this is another edition. I want to appreciate the current state executive led by our able state chairman, Dr. Jonathan Esegine, for appointing me as the chairman of this year's conference. Alongside with more competent colleagues, we thank you, sir, Mr. Chairman. Thank you very much. And it is our hope that we meet your expectation for this two-day conference. The theme of this conference, like we have all seen, is building resilience, private healthcare system in Lagos State, a strategic driver of public-private collaboration, economic stability, and good governance. This topic was carefully chosen based on our annual experiences, impact of economy on health services, effect of government policies on our practice. This theme, you will agree with me, fits into the thinking of Mr. Governor on his theme mantra on health and indeed governance assessment. Distinguished ladies and gentlemen, as at 2022, and I'm glad the MD who also worked tirelessly during the COVID is also here. And she will agree with me that these statistics I'm quoting is actually true. Estimated population of Lagos State as of 2022 is a little bit above 28 million. 65% of which preferred accessing medical services from the private sector. 60.9% of women of childbearing age attend antenatal in the private clinics, and only 56.7% delivers, so there is a shortfall. The private sector has about 63% of the remaining health workforce in the states. These figures are very relevant in bringing to fore the relevance of that collaboration with the private sector on one hand, and utilizing the meager available resources of government on the other hand. One important lesson a few years back that we learned during the pandemic, of which our Honorable Commissioner and his team were champions, as acknowledged worldwide, was the important topmost position of the healthcare services in governance. Today's topic avails us the opportunity to harness the domestic human resources, capacity, and funding available in the private sector in this system of health care, especially with the global economic meltdown. The health as a social services as prescribed by our nation's constitution is almost impossible to be driven alone by the government, but with the combined efforts of the private sector. This is the reason for choosing the topic for this edition. Our choice of resource person for the areas of topics, particularly the main theme, is like choosing a round peg for a round hole. Former President, NMA, former Chairman, NMA Lagos, and a Professor of Pathology, Professor Francis Adedayo Faduyile, OON, is here to do justice to this topic. And you will surely thank us for inviting him. Prof, thank you very much for gracing this occasion. It is our hope that with the presence of the government among us, the government is hearing us. This program is being streamed live. And we have also visited NTA, where we have made what you send us to do to the public. And the communique is also going to be communicated back to the government. So it is our hope that we'll sit down and deliberate and bring out the best out of this conference for a proper engagement. We have listed for this conference other sub-themes with appropriate speakers. Masterclass, which we have held this morning. The business class is coming up first thing tomorrow morning. And, of course, the panel section before rounding up with our AGM proper. The sub-themes are enhancing patient care with AI-driven technology. And we have with us the speaker of that program, Dr. Ademolu Owoyele, here. Please, Dr. Ademolu, please, can you stand up for recognition? Thank you very much. The second is managing arthritis in the aging and workforce. Of course, we can't be tired of Dr. Chigo Joseph Eze, one of our members, and we're very proud of him. Thank you very much. Improving quality and efficiency in the private healthcare services. Also a past chairman of Lagos State and a former MD of Federal Medical Center, Dr. Adedamola Dada, is going to be here tomorrow to do justice to that topic. Strengthening the private care institution for impact through workforce, processes, and data-informed decision. Of course, Dr. Mrs. Ibirunke Dada from Safe Care is coming in with our theme to do the justice to that topic during the business classes, first thing tomorrow morning. Our panel discussion topic is on private medical practice and medical association. It's synoptic insights and sustainable future goals. And our discussants are very eminent personality, Dr. Akin, Dr. Leke Oshuniyi, Dr. Ernest Okoye, and Dr. Jimmy Shodipo. My special appreciation to all panelists. Thank you for joining this edition. Mr. Chairman, our spouses are not left out of this very important and impactful program, and they will enjoy a breakout sections and picnic section tomorrow. Mr. Chairman, our chief host at this year's edition remains the amiable Honorable Commissioner for Health, whom I always say is not a commissioner for the public sector. He's a commissioner for health, and the health is for both public and the private sector. That is very, very important. Honorable Commissioner, sir, our members have not seen the better collaboration that the private sector desires. With the private sectors that are providing services to over 65% of your citizens in Lagos State, we need better collaboration and engagement, yes, to leave the health system in Lagos State as it is done in other states. Honorable Commissioner, sir, our members have requested I call your attention to reconsider this important aspect of health, family, and the bedrock of all doctors. Whoever, and Dr. Olagbugi, you're here. Dr. Ime, you're here. No matter how much years you spend in the public sector, you're coming to your bedrock, and that is ANPMP. You are coming. So we must lay this bed very well so that you can lie on it properly. We need better collaboration. Sir, you will not regret if we collaborate, Honorable Commissioner. I'm glad our special advisor, Dr. Refini Awukoya, a seasoned public health physician, is equally abreast of the health policies and knows the importance of the private sector as pronounced by development partners in the recent past, both at the state and the national level. Mr. Chairman, we are proud to have both our royal fathers and the chairman of this occasion and active members for that matter. Our royal father, like I said, is a doctor and he owns private practice before he was called to service of his ancestrals. Kabesi, you're highly appreciated. Thank you very much for being here. Ditto, Dr. Essien Ekong, the chairman of this occasion. What wealth of richness do we have in Lagos chapter of ANPMP? We thank both of you for enriching this occasion with your presence. Your presence will inform our chief host the reason to support this occasion financially. Mr. Chairman, permit me to recognize our spouses and collaborators, especially in the pharmaceutical space. Honorable Commissioner, we have in our midst all leaders of allied medicals that constitute the medical family. We are all working in unison. Our collaboration is what gave recognition to Lagos State in the health statistics. We appreciate you all for gracing this occasion. I will be doing a lot of disservice if my colleagues' sponsorship is not recognized both morally and financially at all times. You are the reason why the private health system remains afloat. Please, a round of applause for them. To my LOC, what can I say? You have actually made us proud. Your time and intellectual planning has made this event. I thank you so much for the role you play. My state chairman and royal father, the Honorable Commissioner for Health in absentia, the chairman of this occasion, the special guest of honor, distinguished leaders, guests here present, and gentlemen of the press, once again, you are warmly welcome to this occasion. And I thank you all for coming. Thank you. Good afternoon.
Thank you.
I think this is okay. Thank you.
Thank you, sir. I think we can keep doing that a bit more. Thank you very much. I'm sure the tip of the iceberg is what we're experiencing now. The LOC chairman and his team have a lot more to offer at this year's edition of the conference. In the same spirit, would like to invite the chairman of the Lagos State chapter of ANPMP, in the person of Dr. Jonathan Esegine, DMP, to please take his welcome speech. Please keep it coming, keep it coming. He's our chief host for today. And you can see there's a difference in the 2025 edition. Oh, thank you, sir.
Distinguished ladies and gentlemen, permit me to stand, to squat, to sit and crawl on the existing protocols that have been so eloquently established by our LOC chairman. Nevertheless, I'd like to crave your indulgence to recognize respectfully our royal father of the day, Oba Widapo, the Alara of Ilara Kingdom, Kabiesio, Adiak Pelorio, Ibatak Pelese. Let me say a few things about Kabiesi. You may not know me, but I knew you long before you became the Oba of Lara Kingdom. I'd like to recall your write-up and your special eulogy of our departed senior colleague, Dr. Awojobi. And when I was reading your write-up, I was wondering whether it was a doctor or it was another Professor Wole Soyinka that was writing. Kabiesi, I'm so glad and highly honored to have your esteemed presence in this gathering today. In the same vein, let me recognize especially the chairman of this occasion, our own respected, delectable elder in the profession, respectable orthopedic surgeon, Dr. Essien Ekong. Please, a round of applause for our chairman of the day. I hope what we have put together in this year's edition deserves your esteemed presence as chairman. Thank you so much for coming. Let me pay tribute, desired one, to our elders, the past chairmen, the past presidents, and our BOT members, the ones that steer the ship of this association nationally, ensuring that we don't lose track and we don't derail. I'm talking of Dr. Gabriel Oga. A round of applause, please, ladies and gentlemen. And Dr. Anthony Omolola. They are the elders that have not allowed the head of the baby to be bent, even at the back of the mother in the market square. Thank you very much. Permit me to recognize the keynote address speaker of the day, is somebody that I knew even to the roots before he became a grown man that he is today. Let me just, maybe I should leave it there, or I should say it. The father of the professor was my geography teacher in secondary school. I don't know how old he was at that time. But I'm proud to have him as the keynote address speaker today. Very eminently qualified professor of pathology. I saw him today. We hugged like we should never part because we don't see too often. And I told him he has become a national figure. He has become international. And he's truly an erudite professor. And we are very, very proud of what he has become. And by the way, he's also the prince to the throne of Abodi of Ikale. It's my prayer that when you are going to be enthroned, I will be there. All right, ladies and gentlemen, our distinguished colleagues, the DMPs here present, the fellows of this association, respected zonal leaders, chairmen and secretaries, you, respected member of this association. Time will not permit me. I have a lot of people, solid supporters of this association at all times, particularly in this dispensation. The people that have ensured that we are able to put together a conference such as this. I am so happy to have you backing us, and we deeply, profoundly appreciate your support. It will be almost a criminal offense not to mention the people that I'm seeing directly in front of me. The Baba Adini is here, the Baba Ito himself, who does not allow things to go wrong. He will call you in the dead of the night to point out things that are about to go wrong or things that are not so right, and then he will whip you into line. Dr. Maru Oluwole Sanda, please a round of applause for him. And the Aja that is sitting next to her, I know that she's the eye and the ears of the DG NIA here in Lagos. We've met on a number of occasions. I want to recognize your intellect, your acuity in diagnosing and placing things in perspective. And I know with you in authority position, we will have a better deal going forward. It will continue to get better. Please put your hands together for the coordinator, NIA Lagos. And then our own friend, Austin Aipo, the national president of HCPAN. Thank you so much for being here. Our mother is in the house, the former president of HCPAN, and the voice of wisdom, voice of reasoning, speaks with clarity and eloquence without doubt, and making sure you see clearly our own Dr. Olaniba. Please, a round of applause. Dr. Essien Ekong is here with us. It's a name that I've known for many months and years, but today we met for the first time, flesh and blood, and I'm so appreciative of it. Thank you for gracing this occasion. And is the daughter of our distinguished, delectable elder colleague, Dr. Oshino. Please, a round of applause for her. Okay, so much for recognitions. Let me now read my speech. And on behalf of the Executive Committee, the State Executive Council, It is most humbling and honoring for me to be hosting you all, distinguished colleagues, distinguished delegates, spouses, special guests, partners, and sponsors at this year's AGM Scientific Conference. I must place on record the roles of our forebears, our past leaders, predecessors in office, for the doggedness in ensuring the growth, continuous advancement in fulfilling the objectives of our dear association. Societal evolution has brought about advancement. What with the technological innovations, advent of sophisticated, well-equipped private medical facilities, which is both heartwarming and encouraging, particularly seeing gradual but very slow brain gain in the health sector. So it is not all the time, what is it called? It's not all the time brain drain, although the brain drain is still in obvious preponderance. But it's reassuring that we are now beginning to see some who will say, yes, this country sent me and I've acquired something, let me come back home. And we want to thank God for that. It has also brought to the fore the numerous challenges which are undeniably here with us, e.g., our exploding population, growing poverty rates, hyperinflation, grossly inadequate infrastructures, especially lack of energy, cost of care, affordability, especially to the vulnerable members of our society who are clearly in majority. This is where the members of this association have filled and continuously filled the gap, providing accessible, affordable, and always available primary and even secondary care because of our presence everywhere, urban, semi-urban, rural areas, even at enormous cost to individual facilities. Compounding the scenario is the death of healthcare personnel due to many factors, particularly the Japa syndrome, the increasing and unabating hostility of many government agencies, especially the police, that has criminalized the art and science of medical practice with indiscriminate invitations, arrest and detention, harassment of our members at the slightest excuse. Others are lawmen, with prolific imposition of impossible fines with no consideration for prevailing circumstances. Local governments with innumerable demand notices, all driven by revenue generation without consideration for collateral damages. What about industrial training funds? I know that the harassment of industrial training funds is national, and every part of this nation is affected. I like to reassure you that at Lagos here, we are looking into that. We are looking into the laws to see whether they have the power to do what they are doing, and very soon we will let you know the results of our findings. In the midst of this most unfavorable environment, the Nigerian private medical practitioners has carried on stoically, preserving, promoting, and defending the health of the people, mostly at the grassroots. This makes this year's conference theme, Building Resilient Private Health System in Lagos, a driver of public-private collaboration, economic stability, and good governance, very apt. And with the well-appointed speakers and panelists, I am confident that the issue will be significantly addressed with appropriate recommendations to appropriate authorities. In spite of the foregoing, it promises to be the gathering with tremendous benefits for all participants by way of knowledge gains, networking, and insights. Let me thank every delegate, our sponsors and partners, our spouses, speakers, for the very support, for every support and effort that has given birth to this event. My special appreciation and gratitude to the LOC chairman, our very versatile Dr. Essien Ekong, the man I once described, that I still describe as a prolific author of many ideas. No circumstance can betch him. He will come up with something. A round of applause for Dr. Essien Ekong and his team of LOC members for the very sacrifice, for every sacrifice necessary to have a beautiful conference that we are witnessing today. Ladies and gentlemen, while coming for a landing, permit me to thank my friend, special advisor, private secretary, unofficial coordinator, Barrister Muna Esegine, my wife, for all the support and private counsel. Once again, I welcome you all, and I assure you a wonderful time. Thank you very much. Barrister Funke, I hope I didn't take too much time. Thank you. This for you.
Thank you, sir. Please keep it coming. Keep it coming. Our chairman has done. It's almost as if we should just close the event and go. He has spoken all that needs to be said. Would like to proceed immediately with taking the opening remark by the chairman of today. And I'd like to break protocol and
before you break protocol, sorry, I know you don't like breaking protocols, but this protocol that we are going to break, we're going to break it together so that when we go to the court of law, both of us will put our hands at the back. Distinguished ladies and gentlemen, there's somebody I needed to acknowledge and recognize here. But it was a skip because that was not written. And that is no any other person than our Lagos coordinator. It's like our own ES for NHIA. I call her doctor. Maybe she doesn't like that name. Aisha. Please, can we put our hands together for this important personality? Thank you very much for gracing this occasion. Thank you so much. The judge will give us judgment together. I would need to celebrate somebody whose birthday falls today. And it's so important that we put our hands together as Dr. Akiba. Stand up for recognition. Dr. Akiba, we want to celebrate you. Happy birthday and long life and prosperity. For he is a jolly good fellow, for he is a jolly good fellow, for he is a jolly good fellow. And so say all of us, and so say all of us, hooray. And so say all of us, hooray. For he is a jolly good fellow, for he is a jolly good fellow, for he is a jolly good fellow. And so say all of us. Thank you very much.
Thank you very much. Thank you, sir. As I was saying, I would like to break protocol by not inviting our chairman to the pulpit, but rather taking the microphone to him. If you qualify to be the chairman of this occasion, I believe that you have paid your dues. So therefore, ladies and gentlemen, our chairman's opening remarks, Dr. Essien Ekong.
Good afternoon, my colleagues. As I was going around shaking hands, I realized that this gathering has cut across a spectrum of acquaintances, some in the public sector, some as students, during residency program. For instance, none of you will know that His Royal Highness Dr. Windakpo was a very close friend when he was a civilian at Igbobi before he became Kabiyesi. Kabiyesi, we greet you. We thank the local organizing committee for the perfect job they have done. Like everybody has said, Dr. Akin is a man, a cat with many lives, and we thank him. And why is this spectrum so diversified? Many of us who start our practices, our professional career in public sector or government, many of us in teaching hospitals, many of us in private practice, but at the end of the day, like he said, that the bird may fly as much as it likes, ultimately his legs will land on the ground. So many of us have been in government practice, have been in so many other sectors, but when the chips are down, our feet will be planted on the ground as private practitioners of one method or the other. Like I said, when I was going around, I've seen people who were my students, that's house officers or so. I've seen people who were my teachers in the teaching hospital when I was rotating through UCH. I've seen people who had gone to run around and do locum in their practices when I was a younger person. So ultimately, we are intermixed. Our key speaker today, Professor Faduyile, I happen to have been a consultant to his daughter who came from America to practice in Nigeria. I guess she's gone back to America now. So ultimately, we find ourselves, the key thing we need to be, like the theme of the topic has been, is to be resilient medical practitioners, resilient doctors. What you can get away with in government practice or public practice, you dare not do it in private practice, you'll be grounded. I had a young lady who came as an anesthetist to come and ask to practice in my place. And I said, where are you coming from? She came from UCH to Igbobi, and now she wants to have a trial in private practice. And funny enough, she was asking that, I'm used to having senior registrars, nurse anesthetists working with me. I said, young lady, in private practice, you have to be resilient. There's no backup. You have to do it or sink. You either swim, or you sink. So I thank God that we are all here, and I pray that we interact and meet with people. Like I've taken photographs with His Royal Highness. I've shaken hands with Dr. Abikoye, who was my teacher in Luth, and so many other people. Dr. Chigo Eze was a big man now, but was one of my house officers in the military hospital. So as we move along, and I remember when I first met Dr. Oga, he will remember, he is a renowned urologist, but I was impressed that time. That time I had not been a member of the ANPMP. That time he was AGPMP. He was the chairman, and I had a patient to go and discuss with him. Sir, I'm very happy to have you today. We will shake hands and remind ourselves of old times. At the end of the day, it's resilience. That's the key word. And we battle with so many factors. I posted in the group the other day that ITF is on my neck. And they've slammed me with a bill of 25 million. How do we handle it? And people started giving their own experiences. So we need each other in the resilient fight as we survive without government subvention. And notably, in Lagos State, many key things are being done by the private sector who volunteer, take loan, and pay at bank rates to establish certain specialties, like we've seen the presentation by the gastroenterology team. And I remember when I started practicing, there was only one CT scan in Lagos State. But now through private entrepreneurship, many such centers and even better centers are available. So I say, dear colleagues, resilience, don't give up. Continue the fight. And at the end of the day, God will bless us all in Jesus' name. Amen. Thank you very much. Enjoy yourself.
Thank you, sir. And on that note, we're going to take one or two goodwill messages. We'll take our goodwill messages as we go along, but I'd like us to also get into the order of the program of the day. So I will just take 1-2 goodwill messages here to represent gender equality. I would call on Hajia Aisha to give us her goodwill message, closely followed by Dr. Austin Aipoi, the national president of HC PAN, to also take his goodwill message, and then we continue with the program.
Thank you very much. Thank you very much. A very good afternoon to everyone. Kabiesiu, please permit me to stand on the existing protocol to save time. I think I have the right to say distinguished colleagues because I'm here standing on Dr. Ohiri Kelechi, the DG of NHIA, esteemed members of ANPMP, ladies and gentlemen. I'm very much delighted to be here to read the goodwill of the National Health Insurance Authority at this year's annual conference themed Building Resilient Private Healthcare Systems in Lagos State, a strategic driver of public-private collaboration, economic stability, and good governance. At NHIA, we are working to strengthen this partnership. We have introduced reforms aimed at expanding coverage, ensuring quality and accountability, and strengthening collaboration with all private practitioners. Recently, we reviewed upward payment tariffs. Adibabo, is he here? That's the man that championed tariffs, upward review. Thank you. This was to cushion the effects and inflation and to respond to your concerns that you have consistently raised. We have also expanded the supply side through the accreditation of facility. Recently, we carried out accreditation of about 200 facilities in Lagos. I'm sure we have some of you here that will visited their facility. This is to increase the supply side through so that our enrollees will have wider access while providers enjoy a fairer and more inclusive system. Just last week, and I'm sure many of you were present, at the National Health Financing Dialogue that witnessed a landmark commitment and a major breakthrough from this Excellency President Bola Ahmed Tinubu, directly the mandatory enrollment of all MDAs into the health insurance. This is a game changer for sustainable financing. I expected an applause for our President, His Excellency Bola Ahmed Tinubu. This is a game changer for sustainable financing for health insurance and a stronger foundation for providers to deliver quality care, improve access to care, and to reinforce our collective resolve to build resilient systems that will safeguard the health of all Nigerians. NHIA remains committed to collaborate with ANPMP and all provider associations. Together, we will build a system that is resilient, fair, and truly responsive to the health needs of all Nigerians. I want to congratulate you all on this conference, and I wish you fruitful deliberations. Thank you, and thank you for having me.
Yes. Good afternoon, all. I want to stand on the existing and well-established protocol. I also want to say good afternoon to my colleagues here present. On behalf of the Healthcare Providers Association of Nigeria, CPAN, National and Lagos State, I want to congratulate the Lagos ANPMP, my primary constituency, for this well-organized conference, annual conference. It gives me a sense of nostalgia because I've been involved in this type of organization for this association. I also want to talk on the theme of this year's conference. It's in line with what the Lagos State government, I'm not a Lagos State man, but it's in line with what the Lagos State governor and the commissioner is thinking of. Because following the executive order of the governor on the compulsory nature of the NHI health insurance in Lagos State, the governor has set up a Lagos State private health plan where private facilities will be involved in insurance together with government facilities. So it's in line with government thinking, and I'm happy to be part of this, and I want to say that at the end of the day, we look forward to a very robust outcome that government will look into and help our facilities to grow better. Once again, I want to say thank you and welcome to this conference.
I'd like to crave Kabiesi's indulgence and also ask him to take one goodwill message while we come back to.
Good afternoon, distinguished colleagues. I want to recognize all the very senior colleagues. I can see a lot of faces, but let me just limit myself to saying very senior colleagues. I can see Mama here. I bring you greetings from our community. Ara means something unique, something spectacular. And that is the only place where God stops every day and then continue to distribute goodies. Yes. When Dr. Akitade called me that I was going to be part of this event, I looked at myself and said, how long have I been on this throne? Dr. Adedayo has been a senior colleague and has been on the throne for so long. I don't know whether he has been invited before. I said, well, it's a challenge, and I just need to fulfill his expectation. So I made it a point of duty to be here. In fact, the whole of our community will have been here if not for the economic crunch in Osun State. I'm sure some of us have heard about it, but then I just have to be here. Let me just tell us how the theme for this year's conference is very important. I care to tell anybody that cares to listen that my staying in the community, in my community, which is a very rural community anyway, is because of what I've got from Lagos. Practice in Lagos has built me, has trained me, done everything for me to be able to survive in that rural community. You see, Shomolu is a different kettle of fish when you are talking of Lagos. I'm sure my Shomolu colleagues are here, and they can tell you, Dr. Essien too has been part of us, or one of us. Well, so living in Shomolu and practicing in Shomolu for so long, for over 20 years, was not a joke. So going to the rural area to practice was just like going back to my roots with carrying Shomolu along. You see, the practice has prepared me, like I said, even economically, there's nothing in Osun State. Osun is probably one of the poorest states in Nigeria. We all know it. But because I've had something to fall back on, that's why I'm able to survive there. Not only that one can survive among people that other people in the community, they fear them. But I said, why do I have to fear anybody? If I'm coming from Shomolu among the Jebus, where people believe you have to be something special to survive. So why won't I survive even among Ajes and Oshos there? But Lagos, practicing in Lagos State, as we are all witnessing now, is something else. Lagos tries to milk doctors especially. I don't know why they are so focused, so bent on making life difficult for Lagos doctors. Because all the bills you get in other states of Nigeria, you hardly get them. You hardly get them. It's as if the revenue of Lagos State is coming from medical practice, from private medical practice. Let's face it. So I want to appreciate all of us for the resilience, and I want to encourage our executives to try and fight all those ones that we can fight, and we leave God to take care of the rest. I congratulate all of us for being part of this conference, and I want to enjoin us to please be attentive and come up with something that all of us we have to fall back on, and the government too can appreciate in us. Thank you for inviting me, and I appreciate every one of us.
Thank you very much, sir. And the final goodwill message for this session is from Dr. Essien Ekong. Dr. Essien Ekong is the CEO of Abayomi General Hospital. You're welcome, ma'am.
Thank you. Thank you very much. Good afternoon, our distinguished elders and my senior colleagues and colleagues. Ka BACO, Kadekwelorio, Kibata Peleseo. I want to also, while standing on the already established protocol, or maybe I should kneel down because they said in Yoruba now, I'm a lady, so I should kneel down. So I'm kneeling on the established protocol, but permit me to respectfully recognize my big uncle that I just met today, Dr. Ekong. I've adopted an uncle now. That is the good thing about coming for programs like this. You network and you meet people. I also want to thank Dr. Oga here. I hear a lot of good things about you, and I want to be like you when I grow up, sir. And I want to respectfully recognize the DGNHIA too. A lot of good things have been happening during this period. We give glory to God, and I want to recognize Dr. Jimmy Arigbagbo. Did you hear what she said about him? He's the one that is always pressing. A round of applause for him. And sitting very close to him, Dr. Akin, my uncle. Yes, I have so many uncles, you wonder. Dr. Sanda, I get to you again, sir, our daddy. And my mommy, Dr. Laniba. In case you don't know, I'm incoming president for Medical Women's Association. So, up ladies. How many women are here? Medical women, hello? Kind permission. I don't need to pay for adverts for that one. So, thank you very much. You'll be wondering, Essien Ekong, daughter to Oshinowo, what's the relationship? I answer Yoruba gone. Èmi ní A3 ní Yoruba. Tí bá ṣe torí àwọn àgbàlagbà tó pọ̀ jù nbí ni màá pòwe gan sef, you know. So yeah, so we give God the glory. We thank God for Lagos State accommodating all of us, yes, recognizing the little bit of potential God has put in us and allowing us to put it to good use for the community. I bring glad tidings for my daddy. Yes, my daddy, Dr. Oshinowo, who I'm representing. I'm wearing two caps. I'm medical director of Abayomi General Hospital, and I salute you, sir. I forgot to mention my former MD and the Ikorodu Division Chairman. Dr. Amure, where are you, sir? Thank you, sir. Good afternoon, sir. Yes, so there are some of us that they trained us to become what we are today, and we always recognize them. So this is goodwill. My goodwill to our Association of Nigerian Private Medical Practitioners. Congratulations to the chairman, executive, and members of ANPMP. Your theme of this year's scientific conference and AGM is quite challenging, but appropriately timely. We have to be conscious and key into the ever-changing dynamics of health practice. I'm suggesting we should consider and reflect on some key points that are very germane. We must key into current government agenda in health system by mobilizing enrollees from local government to local government, using our active and retired elders as ambassadors to overlap with the state and LGAs to achieve this. Sustainable and retention of manpower of our personnel, especially considering the Japa syndrome. Energy availability and affordability, accessibility of standard pharmaceutical products, accessibility of funding with comfortable single-digit interest. Sorry. Okay. Yes, interest rates. So the strategies, we have a lot of benefits from this partnership. We will have improved healthcare access, there will be economic growth, and there will be good governance. And he has mentioned strategies to include regulatory framework, infrastructural development, capacity building, and of course the partnerships we're discussing with innovation. We should not allow funding to be our challenges. Regulatory hurdles shouldn't be a challenge. We should work around it, and there should always be equity and access. And he sends his goodwill and says, thank you very much for accepting my apologies. I would have really loved to be here. My name again, Dr. Sylvester Oshinowo, DMP, past president, Wonka Africa Region, past chairman, ANPMP Lagos. Thank you very much.
Thank you very much, everyone. We acknowledge all your goodwill messages. Right away, we proceed to preparing for our keynote speaker of the day. And I will do that by taking a few minutes to read out of his citation. It's in the program if you would like to know more about him, but I will take a few minutes to read a brief portion of his citation as we introduce our keynote speaker for the day to take the keynote address. I would humbly request for you to take the podium while I read this very brief profile. Please oblige me. Ladies and gentlemen, our keynote speaker for today, Dr. Francis Adedayo Faduyile, OON, is a professor of pathology and forensic medicine at the Lagos State University College of Medicine, Ikeja, Lagos. He's an honorary consultant to the Department of Pathology and Forensic Medicine at the Lagos State University Teaching Hospital. And he was also former head of pathology and forensic medicine between the years 2016 and 2018. He is a former president of the Association of Resident Doctors, Lagos University Teaching Hospital, Idiaraba. He was between the years 2006 and 2007. Former chairman of the Nigerian Medical Association Lagos chapter between the years 2012 and 2014, and also a past national president of the Nigerian Medical Association between the years 2018 and 2020. He was the special advisor on health to the governor of Ondo State between the years 2022 and 2024, and was appointed chairman, governing council of the Federal College of Education, Katangura, Niger State, in 2024, as well as the chairman of the Committee of Chairmen of Governing Councils of Federal Colleges of Education in Nigeria. He is currently the Pro-Chancellor and Chairman, Governing Council of the Federal University of Education, Katangura, Niger State. Of course, he obtained his degree in medicine and surgery from the College of Medicine, University of Lagos, and several other certifications across the globe. He's had a spanning career over 2 decades in pathology and forensic medicine, cryptopathology, and cancer prevention. He was very active as the president of the Nigerian Medical Association during the COVID years, evidenced by active press releases, mobilization of medical practitioners in Nigeria to aggressively contain the spread of the disease. He is a recipient of numerous local and international awards, including Ondo State Man of the Year in the year 2018, the Presidential Award by the Pharmaceutical Society of Nigeria in 2019, Award of Excellence by the National Association of Nurses and Midwives in 2019, Distinguished Service Award by Nigerian Association of Pharmacists and Pharmaceutical Scientists in the Americas in 2018, and National Merit Award of Order, Officer of the Order of the Niger, OON, by the President of Nigeria, late President Muhammadu Buhari, GCFR, in the year 2022. Professor Faduyile is a prince of Abodi of Ikale land in Ondo State. He is happily married to Dr. Mrs. Grace Oluranti Faduyile, and they are blessed with 4 children. Ladies and gentlemen, our keynote speaker for today is none other but Professor Adedayo Faduyile. Ladies and gentlemen, please, a round of applause.
Kábíyèsí o, mo kí yín bàbá, kádé pẹ́ lórí, kí bàtà pẹ́ lẹ́sẹ̀. The chairman of ANPMP, please pardon me, I'm still of the old horse, so I may still be missing it, but please pardon me. I have so many Egbons here, many of you. You have always been source of blessing. If I start recanting, I will not leave this place. All of you are my Egbons. You helped me so much when I led Lagos State NMA. Although at that time, there was some division amongst us, but we collaborated together. We tried to close rank. And with the help of God, you also assisted me when I was the national president, and we had a very great time. I'm happy all of us have seen ourselves. Especially, I have to recognize Dr. Anthony Omolola, my born from Ondo State. Thank you for everything you have done. The chairman of ANPMP, Dr. Jonathan Esegine, the only thing you did not add, was that I graduated from the same secondary school that you went to, and I'm happy to be associated with you. Members who are here, it's a nostalgic feeling. When they actually called me here, I say, what is my word to come and talk to the very powerful private practitioners? But somehow, maybe Dr. Akin have this view that I have something to say. Kindly, I want to plead with you to follow me. Some of the things I will say are from the prism that I'm seeing it. Areas that are not totally correct, I think we can discuss it. But before we say anything, they say one adage that we cannot be doing the same thing the same way and expect a different result. It's high time we started what in the AI, in the technological world, called destructive technology. We have to break down what is on ground so that we can now have a new improvement on the status quo. We cannot afford to continue this way. It's not possible. Please, do you have my slides? My PowerPoint? Let me acknowledge the leadership of ANPMP, Lagos branch, and the LOC for inviting me as the Keynote speaker of the 2025 Annual General Meeting and Scientific Conference. I found this topic very, very interesting at this particular time that the medical practice is being threatened in Nigeria, majorly as a result of both human and material resources deficiencies. The material resources part, with funding being a perennial issue that befell the healthcare system in Nigeria, with dwindling of quality services, and it is almost grinding the practice. On the other hand, the human resources for health has been an oscillating curve, with period of mass movement of health professionals at different periods in the national history. This is not the first time we are having this mass migration. This is about the third or the fourth set. At a time during the period of Idiagbon, when that was the first, then at a time public institution went down, we had the second, and now we are having a very big one as it is. Of course, however, the one being experienced now is an avalanche where our professional colleagues are leaving massively. Of course, it has put the practice in prostate composition with manpower challenge in a profession in which more human resource is adequately required. As we are aware, government alone cannot provide the needed resources to achieve a strong healthcare financing system. This therefore makes this topic very important at this time, as there is an urgent need to redesign our healthcare system and practice in the provision of public-private collaboration for effective economic stability and good governance. We cannot forget the maxim, health is wealth, and a healthy nation is a wealthy nation. There are some words that are important to stress in this topic. The first word is resilience. According to Oxford Dictionary, resilience is being able to withstand or recover quickly from difficult position. That is according to Oxford Dictionary. According to Merriam-Webster's dictionary, is capable of withstanding shock without permanent deformation, withstanding shock without permanent deformation or rupture, or tending to recover from or adjust easily to misfortune or change. That is resilience. While collaboration is an action of working with someone to produce something, according to Oxford Dictionary. The process of two or more people or entities or organization working together to complete a task or achieve a goal. And that is the collaboration we are hoping to achieve. From these keywords, you will agree with me that there is therefore an urgent need to recover our ailing healthcare system by those of us at home. Importantly, for those of us at home, for the greater benefit of all and ensuring economic stability, both for the health professionals as well as the public in general. In the course of this lecture,
I will dwell on the history of how private health practice came into being in Nigeria. There is this maxim that if we don't know where we are coming from, we might actually not know where we are going. It is a case of a steep fall of medical professionals from a high-class position to a commoner position. From the historical perspective, there are some take-home facts that will help us understand where we are coming from, appreciate where we are, so that we can together formulate where we want to be, where we want our future to be. The origin of private healthcare practice in Nigeria. The medical profession has from time immemorial and universally, it still remains the most learned and the noble amongst the original learned professions. The three learned professions being the physician, the scribe, otherwise lawyers, and the priest. Those are the three learned positions. For the benefit of those who may not have taken time to trace the beginning of medical profession in Nigeria, I say here that the profession was a doing of all professionals in the pre-colonial Nigeria. In fact, at that period, the medical profession was the front line before the emergence of and growth of some other professions in Nigeria. In the pre-independence era, during pre-colonial period, the medical officer of health assumed a kind of larger-than-life position within the government. For example, where you had the district officer of old, usually a Briton, the next officer to him was topped by the health department headed by a medical officer of health. When the DO was not around, he handed over administration to the medical officer of health. The medical officer of health was regarded as the next in command to the DO. So, put mildly, the medical officer of health at the district council level was regarded as first among equals. The same thing applied to the national level, where the chief medical officer in Lagos acted as the governor general when the governor general was on leave in England. This was so because England, where medical practice emanated, it was only medical officers amongst other professionals who are the topmost social class, followed by industrialists and the lords. So where we stand was medical officers, industrialists, and lords. Those are the main people who are celebrated. The next social class were the older elitist groups or professionals like the lawyers, the estate surveyors, the architects, and accountants. This is because medical officers deal with lives. The implication of the foregoing at that particular time was that medical officers earned by far more than other administrative, accounting, or legal officers within the district government from the provincial to the national level. An administrative officer grade 1, which is an equivalent of permanent secretary today, earned by far less than the medical officer. This was as during the pre-independence era. The same thing applied to all cadres working with the colonial government. The late Sir Kofo Abayomi was the first Nigerian to rise to the position of Chief Medical Officer of Health of the colonial government. It was a plum position that conferred on him the respect of colonial government. This was why the colonial government allowed him to reside in the government-reserved area in southwest Ikoyi, Lagos. The late Sir Dr. Abayomi was the first Nigerian civil servant to live in GRA. That is the position that doctors were. So what happened at the post-colonial independence? Post-independence. But when the first independent government came, the state of affairs was gradually discontinued. And that gave rise to infiltration of unhealthy external and corruptive influences into the otherwise orderly system of administration. The Nigerian factor cropped in, and that led to the emergence of what we refer to as the era of super permanent secretaries. The entry of less qualified personnel into the national bureaucracy led to the elevation of mediocrity, that we witness in the civil service today. Administrative officers who were hitherto below the level of elitist class to which the medical professionals belong were catapulted above them. This now brought the medical and legal profession that were higher in the post-colonial area now at par or sometimes below the other administrative positions. The situation has continued till date, and something progressive and drastic must be done by all of us to bring about the necessary change. This mishap brought about a situation where the administrative cadre now manage government budgets as well as paraphernalia of office, and was also accorded more financial power and other consideration over and above both the medical and legal professions, as exemplified by the post of Chief Medical Officer and Solicitor General. At that time, it was a taboo for medical officer to engage in private practice or run private clinics or hospital. Certainly, at that time, we are taken at that level. But the state of affairs after was alien to medical profession, and immediately post-colonial government era, the latter led to the establishment of private practices by medical officers in government to cushion the effect of our loss of status and our loss of financial power. As if this was not enough, when the military took over, they came with a cloak of illegality and hijacked the reign of authority from the politicians and the bureaucrats. They used the legal profession to legalize the illegality of their usurpation of power through the barrel of guns. They used the legal department of government to promulgate decrees that accorded seeming legal basis for the hijack of power. To compensate the legal profession for their collaboration, the remuneration of judges now became far more and higher than those of administrative class and medical officers. You can see the gradual decline from where we are. That was when the rain started beating us so silly. This led to the exodus of highly competent, highly respected doctors into full-fledged practice. People like Dr. Olushola Saraki, that is the senior, and his partner, Dr. Ekomi. People like late Professor Bello Osage were prominent in the vanguard of that exodus. And that was the situation during the military era. From then on, the depletion of power and the financial status of medical officers continued unabated. And even after the military handed over power to the highly placid civilian administration, this led to the elimination of the Nigerian middle class and the pauperization of lower class to the extent that even doctors in full-fledged private practice could no longer make ends meet. But when the economy finally took an inevitable nosedive into depression, there was marked exodus of highly qualified Nigerian doctors to America, Saudi Arabia, Doha, in Qatar, Kuwait, and South Africa. This was about the first generation, and enough for history. We can now see where we have come, how we have gone down. So in today's Nigerian health system, having taken a look at the past, let us now return to the present situation and provide possible solution for the way forward. The first one I want to talk about is industrial action. During those times that we are falling, and that period witnessed many more interprofessional rivalry. They say one adage in Yoruba, permit me, I'm a Yoruba man, they say, the period witnessed more interprofessional rivalry. We have violent trade unionism with its attendant strikes and lockouts and abandonment of our patients by doctors as a result of demands for increased emoluments and wages. Understandably, the take-home package for doctors has remained extremely low, or rather, cannot take them home anymore. The strikes and lockout of patients marks of insensitivity, which are factors that were alien to medical profession in those glorious days. Again, for the government, they lack political will in the implementation of relevant policies. And as we all know, Nigeria is not a country that you don't have the proper laws, but we do not have the political will to implement those laws. And one of them is about funding for public health system. Distinguished guests and the audience, if I am to be sincere, there is a temptation of describing the state of funding of our health system as being precarious. The reason is obvious. Many times at gatherings like this and others at national level, even those beyond the medical community, with key stakeholders, including policymakers, I have presented papers on this subject with solutions profiled that could form the backbone for implementation of evidence-based intervention. Many scholars have done the same. Sadly, none of us will confidently describe it as an amenable state of financing. Budgetary allocation to the health sector remain far below the WHO and African Union recommendation of 11% and 15% respectively of a country's gross domestic product. The WHO had recommended that 11% of country's budget should be dedicated to the health sector, whereas in 2011, the heads of states of African Union country met in Abuja and pledged to set aside a target allocating 15% of annual budget to improve health sector, which was 4% above what the WHO recommended. The implication is making health a higher priority in government budgets. Since the effectiveness of a country's health delivery system is central to meet its health goals, Nigeria is a signatory to this Abuja Declaration, and they committed to spending 15% of total government health budget on health. However, health spending as a proportion of federal government expenditure was at the lowest and shrank from an average of 3.5% in the 1970s to less than 2% in the 1980s and the early 1990s. If you love to improve somewhere, you must be able to wanting to nurture it. When you do not put money into it, certainly something must give. By mid-1990s, the percentage of public health expenditure to total government expenditure stood at 7.05. Excuse me. It's for me. Please, ma'am. Thank you, sir. Excuse me, please. 4.22 in 2000, 6.41 in 2005, 4.3 in 2009, 4.4 in 2010. This shows an average of 5% was allocated to health sector between 1995 and 2010. And this is a slight increase of about 2% from the previous 1980 to 1990. The percentage of public expenditure on health stood at 5.4 in 2011, 5.8 in 2012, 5.7 in 2013, 6.0 in 2014, 5.5 in 2015. And this also shows that consistently we have had less than 6% of the total budget allocated to health sector between those times. From the foregoing, it is observed that the country has been off track with respect to achieving the health-related Millennium Development Goals. Also, the total proportion, when you compare it to the 11% and 15%, you will understand it is a far cry of what is expected to the health profession. From the above, it is pertinent that a sector needs medical or health practice in Nigeria. Since the government has been shying away in its responsibilities of providing the necessary funding and equip the health facility, a vibrant private sector is needed to save the healthcare in Nigeria. And this is where it affects us. I have tried to say how the thing has come down. Then it is now for us to look at where we can come in. So let's go to the well-being of private medical practice. The first generation of private practitioners had a very robust practice and experience because they are the mostly experienced medical practitioners that left the public institutions to set up their practice. They were able to fund their practice adequately and became the needed alternative in provision of quality healthcare. Practitioners to their establishment and also brought in the staff of their respective companies as retainership to the different hospitals. The practice again shore up the already battered image of medical practitioners as they once again rose in the social circle of the influentials amongst the captain of industries and most especially with the heads of military government ruling the country at that period. Many of us know many of our senior colleagues that were dining, whining, and dining with leadership of the military government at that time. At that time, we can get a lot of things. And those are the first stage. Unfortunately, private practitioners did not imbibe the business of financial management of the business of healthcare. And many of the outlets were built around the proprietors, who act as the head of every department, as well as the administrative and financial head. The doctor is the doctor, he sees the patient. He's the nurse, he decides how it goes. He's the lab person, he's the one who does the administration. And all the money comes. He alone is the person who will think how he wants to expand. A doctor will buy everything in his hospital, and the next doctor will buy everything in his hospital. The third doctor will buy everything in his hospital. And where is the financial knowledge of how to manage? Although many of the practitioners became rich and influential, but the effect of the many activities performed at the same time, which are strenuous, who is thinking that doctors, many of us have heard about so many very, very active doctors sitting in their consulting room and dying. They work themselves out. We do not have friends. We just stay there. And that was what's happened in the first phase. The advent of the second decade or second phase, many of the big private healthcare facilities became distressed, largely due to economic meltdown in the country, as well as other other sharp practices amongst medical practitioners and the companies on retainership. At that time, the in-thing is about retainership. We were now so comfortable with retainership that we are not actually doing the work. We are only earning the money. We have a lot of retainers in our place. We collect the money and we interact. And everybody goes. It cannot continue. So, that was the sharp practices that we had at that second phase. This further worsened the plight of healthcare practice. We totally left healthcare practice. At this point, sharp practices became the order of the day, with corruption in the healthcare practice with other professionals, especially with the private establishment they were servicing. The rampant corruption and lack of financial management on the part of private sector in the second phase, with the perennial underfunding of the public healthcare sector, brought a total collapse of the healthcare practice. Around this period, mushroom healthcare practice started to be the order of the day. It was because of this, we have charlatans and fake medical practitioners, they joined the trail. So every place, because we cannot define who we are. Anywhere, we have room and parlor. You have a doctor doing things and we are doing a lot, so anybody can join. That was what happened in the second phase. Because there were no major differences between the practice of a medical practitioner in terms of the practice and the hospital environment and that of a fake doctor. In actual fact, people lost all respect for medical practitioners because they have seen them like the struggling staff. Everybody is struggling. You are also struggling. We sit down with them. We cannot afford to go to that big club. We sit down with them at the Paraga Club. We take one bottle. Then we brought ourselves totally. And we discuss about all issues. We do not put ourselves in a position. Private health practice then became tough and demanding for young practitioners. Many of our Ekons here, I knew you when I was just finishing. You are still here, we thank God. But I do not see how many of them who are in my age group who are doing very well. or those who are behind me. I finished 1996. 1996 is close to 30 years, I guess. So how many? Do an assessment. You know how many of the young practitioners who are within you. The private practice then became tough and demanding for young practitioners. There was stiff competition with fake and substandard facilities, and coupled with the poor health-seeking behavior of patients, out-of-pocket financing of health, and hostile loan facility to establish a standard practice. Today, if you want to take loan in the bank, I wanted to do a small practice and tell you, you will pay nothing less than 40 to 50% from the day you collected that loan. There is no business that you can sustain on that. In the same vein, unfortunately, those in established practices were affected. Aside those earlier highlighted, age caught up with many of them, and their generations were getting tired. And their generation were getting retired, and they are gradually losing out in the general social circle of influence. By the time your age, you are now a grandpa, we now have younger people coming, you cannot struggle with them. Many revered practitioners became indigent and are forced to live a life below their supposed status. This is aside their inability to maintain the massive buildings or infrastructure they built during the heydays. At the time money was coming, you were bringing something as big as this, providing 2 or 3 generating sets, having very big things that sincerely it was of no good business thinking. So around the end of the second phase, the government injected some moderate funding into public institutions in an attempt to revive the ailing health institution. This led to a reverse movement of medical practitioners from the private sector to the public sector. This led to the movement of patients also back to the public institution from the badly damaged private healthcare sector. The government, however, failed to expand the infrastructure in response to the increase in the patient load. And this led to the notorious no bed space syndrome in most of our public health institutions. This scourge is now one of the major causes of death in emergency cases in Lagos. You see people, they'll take them to Loot, no bed space, take them to Lasut, no bed space, take them to FMC, no bed space. In that process, the patient has died. This period, which we are in at present, also coincided with the introduction of formal health insurance policy by both the national and subnational governments. Now we have analyzed where the problems are. Let us proceed way of building a resilient private health system. It is therefore imperative to change the mode of engagement with our patients in Lagos, nay, the country, especially now, as there have been major shift in healthcare outlook and financing. Number one, the national and subnational government have largely failed to avail affordable loan scheme for healthcare professionals. Hence, it is very difficult to amass the huge amount needed to start a good practice. This is therefore begging for a joint collaboration amongst medical practitioners in order to start a high-profile practice. If you look at Indians, they came some few years ago. They started aggressive advertisement amongst us. And what did they do? They have a government that gave them near less than 5%. And they built a very, very big companies, hospitals, in their places. And when they came here, they started poaching our patients. And today, India is better for it. What have we gone to do? If the government is not doing that, it is the duty of ANPMP, as well as all of us individually, to see how we have a good facility that will take care of the people. And there is need to change the outlook of healthcare practice from the generalist model to multi-specialist model. India did not come here to say, come and treat malaria. They came on a higher level. And you can see Red Doors. Who came? He's a gynecologist, he's a gastroenterologist in the US. And you see that small place he put. I can tell you, he can fund 5 or 6 generalist hospitals without even becoming too big, because he has found things to add to the system. We should start thinking of that. There is need to change or reform the outlook of our facilities to meet international standards. And more especially, to be a place of serenity, away from the very bland, uninviting look of our hospitals. When you see hospital, you know it's an hospital. Today we have left that. Life is not about you are seeing a hospital. If you see where they said Buhari died, you see it is within a community of houses. But when you see what is happening inside, you are happy. It's what the people want. This one, you are building a hospital and you have areas that you have mushroom or mucor on the side, and you are is too bland. It's not inviting. It's not about what you give. It's about how you can attract people. We have gone beyond the day. Let us just do it. Let us just come. You see good practice. We have gone beyond that. And there is need to imbibe a part of hospitality model in our facility. And when managing patients, we have to change our course to now become more hospitable. Talk to people, discuss with people, let them feel happy. A patient comes, give him 1 bottle water. Oga, how are you? You brought water. Water is less than 100 naira. If you get there, the doctor will take care of you. We must think of more hospitality. We must think of our places that, look, if you have a place, we have done it during the time of retainership. You have area of VIP, VVIP. Get some places that patients will be happy. If you see the Red Doors building, so beautiful, green and white, he put it in such a way that you want to see what is happening. Look at their reception. Very beautiful. These are the things we need to change in our place. There is need to fully embrace the health financing model of health insurance, as this will drastically reduce the out-of-pocket payment for health on health. The government has just changed us, both nationally and within the state, on the amount, but we have to start from somewhere. When I was special advisor in Ondo State, we wanted to start a contributory health commission, and we invited the ANPMP. They said they rejected it because the money was too small. And we told them we are going to start. And it was about the best in the Southwest at that time. They said it was too much. They wanted something that was far, far higher. But if we want to start, let us start. But they refused. We started, and today, I can tell you, before I left, Unimed Akure was collecting nothing less than 6 million every month. Unimed Ondo was collecting nothing less than 5 million naira every month. We have the FMC and police hospital, they were collecting over 3 million, 4 million. And how many patients actually came? And today, I can tell you, you come to Akure, you want to get treatment, many of them go there, have their surgery, and they are doing very well. We have to rethink of where we want to start. And there is also a need to form appropriate management team to comprise experienced administrator devoid of the very tedious clinical practice. If you want to practice, practice. If you want to be an administrator, be an administrator. You cannot combine the two. It's difficult. Don't build something around yourself. Because if you build it around they say, acknowledge the foreman. You can't. The word has gone beyond that. Sorry for those who do not understand Yoruba. I have not directly advocated that medical practitioners should not lead management team, but they should rather concentrate on management with less clinical duties. You can actually think well. We are one of the best, but you cannot combine the two effectively. And you only see things in just one prism. You need to find a way to diverge it. There is need to re-strategize on bringing the medical profession to its earlier and enviable stage within the society. This has to also involve our engagement model with the government. It should be more of collaborative than confrontational. Let us know and let it be known that what we have lost cannot be taken back by confrontation. Doctors are expected sincerely to sit with government, the captains of industry, and change things. Not that we'll be outside carrying placard, signing I no go agree. That is not where we should be. We have to redefine who we are. With confrontation, we give you small thing, but sincerely, what we have lost will be much more than that. And one of the most important areas that need urgent action is the need to endure strict discipline amongst the professionals. The public is fully aware of all our activities. They look at us, and I'm happy. We are seeing ANPMP leading the train. You are sitting here. We don't have people talking, shouting everywhere. But if you go to many medical places today, it's not something you want to be proud of. We need to become more disciplined. People are looking at us. The public is fully aware of all our activities. Let us ensure that we are above board at every instance because we are brand ambassador of our profession. That is some ways that I'm positing for that. Now, what are the strategic drivers of public-private collaboration, economic stability, and good governance? The primary health care centers in the country are the level bearing the most of the brunt of the underfunding of public institutions, with many of them underutilized. It is important that private practitioners collaborate with national government and the local government on how to adopt the primary health care centers around their location and agree on a workable partnership with them. This will have a direct benefit to the centers, that is primary health care centers, and their practice, that is the practice of the private practitioner already settled in that area. There is this maxim by a man who always have a bumper harvest of maize. And whenever he's about to plant, he gives some of his grain to farmers around him so that they can plant it. And somebody asked him, why are you giving your maize to this group of people? And do you want them to meet you or beat you? And the man said, if you give maize brand that are lower in quality, and I plant my maize here that is giving very bumper harvest. You know, maize is pollinated by wind pollination. Those lower quality one will come and pollinate its own, and it will have a low quality maize production. So what he does is that as he is giving them, he is also helping himself. What we have seen, and I want to be practical, is that we have so many practices around government area. And one of the things we always pray, which we know, is that they are not doing well in government area. We always pray that, okay, let them be fumbling. I know that the end comes back to me. If we do not have a viral public institution, it will bounce back on us. And that is why I am advocating that ANPMP must look at ways in which you want to strengthen the primary healthcare centers in your environment. It is important. There's also need to interact with state government, to collaborate with private facilities, to use their bed spaces that are largely unoccupied, to admit patients and treat them with the attendant physician with a cost-sharing arrangement. This will reduce the no-bed syndrome in the public institution and will allow patients to be managed under the consultants in the public and actively utilize the facilities of the private facilities. Many of our facilities are highly underutilized, 20%, 30%. And we have a public institution just close to you, and they are transferring to kilometer 10, kilometer 20. And many times they still die because they do not have that adequate treatment. If we have discussion with the state government so that some of our facilities can be used, put them there, we are all experienced doctors who can help in that treatment. It is a way in which it will be a win-win. You use your bed space, you get your nurses or your staff to do some work, you get information, interaction with those physicians, and you get your own pay. It is a thing we must do at this time. There is also need to improve and upgrade private facilities to serve as highly specialty center so that it can complement public facilities. Redos, I just heard about him now. I'm not campaigning for them. He's an example. He has chosen only gastroenterology. He has put everything needed. If, for example, LASUT or whatever tertiary institution or some general hospital around that place, if they have collaboration with them, they can actually send and have agreement. It is going to be a win-win for both the private, the public, and the general public. It's important we also look at it. There is also a need to interact with government and private practitioners to encourage horizontal referral as against medical tourism that bleed our country. Some of the private facilities have and properly maintain equipment that are needed and used in these medical tourist nations. A proper PPP arrangement can be made to bring in those equipment in such facility to use in Nigeria. The public medical practitioners can also interact with these centers to improve their knowledge and expertise. We should always put it in mind that almost all medical tourist health institutions, either wherever, in UK, in India, anywhere, are privately owned. Most of them. So what stops us? Hence, we need to develop our own. It's a clarion call to all of us here. We need to support reverse migration of highly skilled medical practitioners by providing an enabling environment in our private institutions to support the collaboration. Many of our people outside the country are willing to come home. The federal government, the state government cannot take care of what they need. The private practitioners can do that. Let us give them that opportunity. Improve your practice, give them room to be able to work, and let people know. I think when you have that, it's a good collaboration that you do with the government. And for economic stability, if half of the money, which was put at 30 billion naira, was lost to medical tourism, is retained in this country, there will be less demand on dollar. And this will certainly ease pressure on our naira and will ensure stability of our economy. Aside the highlighted microeconomic benefits, individual healthcare personnel will also be in the loop of this fund available within the system. We are losing the money, we must sit and think about it. I have so many examples, but my time is up. But I think this is a call, it's a clarion call for us to leave that our straitjacket thought that this is private, this is public. Again, we need to talk with the government. A government cannot do what we want for us. You need a lot of advocacy. I was discussing with someone just before we started, and I was saying, why do we think the government is not ready to help the private practitioner for the power? I said, the government is looking at private practitioner as business. Why do I want to look at it? He said, no. I said, look, those people who sit down to discuss it, all of them are public people. You have very few private people. If you do not get them convinced for them to see it, he said, but it's for benefit. I said, well, that is how you think. But the way they think is different. We must go back. We must. Because medicine is gradually become an extinct profession. Very soon, we, all of us, will be technicians within the medical practice. We will be technicians. Because with AI, with technology, there is reduction in the need of us. If we do not adjust, we will be technicians. When I was NMA president, I told them, if we fail to make a change now, we will see very soon. They will just call you. What do you do? Okay, it's all right. They will use one machine, and somebody who is a physicist, somebody who is a scientist, who probably just punch one or two things, put what you want, and they will not have any need to. In fact, our patients, before they come to meet us, they have googled everything. By the time you are saying A, B, C, they are the one telling you all the information. So, we need to change our thought process. In conclusion, there is no doubt private medical practice, and indeed medical profession in Nigeria, has lost its early status, and there are consequences on the practice and practitioner. Resilience is required for private practice to drive public-private collaboration, economic stability, and good governance. Therefore, practitioners in private practice must be equipped appropriately as healthcare business leaders and managers. Embrace group practice, key into and propagate the gospel of health insurance. Also, we must be brand ambassadors of the profession by practicing with utmost professionalism. Collaborative strategy approach, like being pressure group for advocacy in areas of change in public policy that will address identified constraints or challenges, including collaboration with public health facilities to tackle the no-birth syndromes, remains a potent way forward to drive this process. Let me appreciate you for giving me the opportunity And I have been given to project this all-important discourse and to enhance a cross-fertilization of ideas on how we can collectively move the health sector of the nation forward.
The present and the future of the business of healthcare. The past, the present, and the future of the business of healthcare. ANPMP has been talking about the business of healthcare for a very long time. And I hope that we'll take the recommended steps that our keynote speaker has given us today. Would like to call on the members of the Board of Trustees, the Chairman, Lagos State Chapter, and Dr. Anthony Omolola, on behalf of the BOT, to please present an award to our keynote speaker, Professor Faduyile, for a wonderful presentation today. Please, sir.
Please, I want us to give another rousing ovation to our Professor Emeritus, the national, international figure who has given us a very didactic professorial delivery. Another round of applause, please. Professor, we are so very proud of you, and we are proud of your lecture. Much more so, we are proud of the maturity. You may not know, but we have observed you. We knew when a lot of the things that you have taught us today were strange approach, but it shows that years and age bring maturity, and we are proud of that. We want to thank you for the nuggets, for the points that you have given. We will see how we will dissect them, and going forward, how we can implement some of them in order to improve healthcare delivery in our nation. Thank you so very much. On this note, in appreciation and profound gratitude, I want to call on our elder, our BOT member, past chairman, past president, past zonal chairman too, zonal chairman, to please present these awards and this little token by way of appreciation to our erudite professorial lecturer. Thank you.
More round of applause, please. On behalf of Nigerian Private Medical Practitioners, ANPMP, Lagos State Branch, we proudly present this award of excellence to you, our dear brother and colleague, Dr. Professor Francis. I will rather say Professor Dr. Francis, that's why we put it in NMA. Professor Dr. Francis Adedayo, Faduyile, OON. in recognition of your contribution and support of the 2025 edition of this annual general meeting and scientific conference taking place here today, dated 10th of September 2025. We thank you for this presentation, and we want to see you in near future. Thank you very much. We are giving a token. I think that's the envelope. I don't know what is there, but we need to appreciate him for what he has done. I am very sure most colleagues will have a copy of this lecture, and we will dissect so that we can improve our healthcare delivery in Lagos State. Congratulations.
Thank you all for being an amazing audience so far. We will take a tour of the exhibition stand by the dignitaries here present once the chairman of the day has done the formality of declaring the national president has done the formality of declaring this event open. And to introduce the representative of the national president is Dr. Akin.
Thank you very much, my very distinguished and able, I don't want to call you MC because I don't want to be charged. But I will just know that you have done a very good job for us. During one of our sections where we were discussing at the LOC, the question came up, who is going to MC this program? I said, please, let this go to Barrister Funke Oluwole. And then I asked me why. I said, because she's the only one that knows about this association. While we were standing there, she reviewed the lecture of Professor Faduyile, and she said, exactly 20 years ago, 21 years ago, this same lecture was given by late Dr. Tosin Ajayi, and the topic then was business of medicine, business of healthcare, 2004. And in his lecture, he mentioned that the barbarians are the door. Now, that has come to be. The barbarians are no longer at the door. They are actually within us. And he also mentioned doctors in Nigeria would be looking for a job from the so-called barbarian. And all the recommendation he made was the same thing Professor Faduyile actually gave to us now. Distinguished ladies and gentlemen, I said you will thank us for bringing Professor Adedayo Francis Faduyile. Please, can we put our hands together once again for this icon in the medical process? Thank you so much. At this point, I want to invite the national president of ANPMP, Dr. K. Adeshola, ably represented here by the Secretary General, Dr. Debo. Adebiyi, the Secretary General of this association, is going to give his goodwill, and thereafter, with the BOT, declare the conference open And afterwards, please can we put our hands together for the president of this great association, Dr. Adedayo. Thank you.
Thank you very much, the LOC chairman, Dr. Tunji Akintade. I want to say good afternoon to my senior colleagues and everybody here present. I also want to stand on the existing protocol, but not before greeting the KBAC Oba Windapo, Kadepelori, Kibata Pelese, Irukere Adokeni, Essien Oba Jeko Pe, KBAC. Thank you very much. Dr. Debo Adebi has already introduced, and I'm here representing the president of the Association of Nigerian Private Medical Practitioners. And I want to use this opportunity to congratulate my chairman, Dr. Jonathan Esegine, for the success of this program, which is his first during his administration. The Lagos State has been very, very active since it took over the leadership from the former chairman. All the former chairman has actually performed very credibly well as well. But he is also keeping the flag flying. So congratulations, sir. And I also congratulate the LOC and all the executive officers of the association. Without taking much of your time, I will read the good message from the president, Dr. K. Adeshola, who is unavoidably absent from here today, and it goes thus. It is with mixed feelings I write my good message to this honorable gathering. Mixed feeling because I would have loved to be seated among the Lagos State members of our great association at an event as big as this. I had perceived a most successful and beneficial 2025 conference, judging from the level of planning, promotion, and the caliber of executor, as ably led by the chairman, Dr. Jonathan Esegine, and his dependable ESCO, and of course, the local organizing committee led by no lesser person than the past chairman, Dr. Tunji Akintade, the MP. I therefore miss this fun, the banter, and the opportunity for further learning. The other side of the miss, however, runs in line with your mandates of leadership given to me since 2022. It is no secret I strive to ensure better welfare and treatment of the private practitioners at all time. 2 issues are keeping me extremely busy here in Abuja. The first one is the first national stakeholder dialogue on power in the health sector. This has been in the front burner for a long time. The second one is a meeting of the National Emergency Medical Service and Ambulance Sector, named SAS. I'm sure we are quite aware of ANPMP started the agitation for electricity bill subsidy since 2021. And even when last year the Federal Ministry of Power and Health finally gave some attention, it was given with a bias to only the public institution. I have therefore keep calling on inclusion at every opportunity since then. I was delighted when finally I got invited as a panelist among others with the opportunity to speak to this matter in the presence of the President of the Nation, His Excellency President Bola Ahmed Tinubu, JFR, at the Villa. May the Lord grant us private medical practitioner His favor. The NEMSAS meeting must have been catalyzed by the recent increased agitation from the office of the ANPMP president that led to initial online meeting by the ESCO of ANPMP, and it was the meeting that demanded for physical meeting with the stakeholder. For those who are not familiar with NEMSAS, it is the body saddled with the management of the money being released since 2018 for the national budget, from the national budget annually. It is meant to pay for all emergency services the health facility are rendering to Nigerians on a daily basis. My constituency member, the ANPMP members, are yet to start getting paid for the emergencies we treat across the country on a daily basis. All we continue to get are threats as embedded in the 2014 National Health Act, as well as attacks from those who we are treating, and those that accompany them to the hospital. Enough of our deserved compensation entering voicemail every year. I'm sure you can now appreciate the opportunity cost of not being in your midst today. Aso Rock Dialogue is for 5th and 10th September, while NEMSAS meeting comes up on 11th. Kindly pardon my absence in Lagos at this time. I wish each and every participant the best of times together as we navigate with the team and sub-team of this conference. Long live Lagos State ANPMP. Long live Nigeria. Long live the National ANPMP. I remain yours in service. K. Adeshola, ANPMP President. That is the message from the President. And with that, I want to also, on behalf of the President and on behalf of our BOT members who are here present, Dr. Gabriel and Dr. Gabriel and Dr. Anthony Omolola, I want to use this opportunity to invite Dr. Gabriel to come to the podium to declare this conference open.
Mr. Chairman, Kabiyesi, all protocols existing are withheld. I'm very, very happy to be here today. Although, as most of you know, I do not live in Lagos right now, but I come to Lagos often because half of me is still in Lagos. And whenever I come, the first thing I do is to phone the chairman and ask if there's any activity of AGPMP going on so that I can come and attend. That was what I did a few days ago, and I was told this meeting was going on, and I promised to be here. I must say that over the years, for the past 25 years, we've had experience with ANPMP. I've noticed a steady increase in tempo. I've noticed that despite all the odds our doctors are working on, people can still find happiness and they can still have that resilience to perform what they are doing today. I'm highly impressed with the turnout of this meeting and the standard of this meeting. So I'm very, very glad to declare this conference open.
And on that note, would ask the representative of the national president to please lead the other BOT members and other members of the high table through the exhibition stand. And for the next 15-20 minutes, I would implore our distinguished delegates, yes, our members here to please also go with them through the exhibition stands. We have a wide variety of exhibition services out there. Please patronize them, pick up their contact details, and of course, let's make this as much of a networking event as possible. While we do that over the next 20-25 minutes, we'll reconvene at 3:30 to take our artificial intelligence topic, sub-theme, and the rest of the program for this afternoon.
Distinguished ladies and gentlemen, it is time to reconvene for the second segment of today's section. Please, let us leave the exhibition booth and reconvene, please. Our lunch is going to be served while seated. The chairman has directed that we ask you to come back to your seats. Please, let us reconvene for this section, please. All LOC members, please kindly assist in redirecting our members to come back to seats. The exhibitors will be with us till tomorrow. We need you back in the hall. And we need to understand that our royal father, His Royal Majesty, the Alara of our kingdom, is still seated with us. Please, we need to come back and reconvene. The BOT are already seated. Please let us come back. LOC members, please kindly direct our members to come back and reconvene, please. Thank you.
topic. He's also a doctor, so he knows what he's talking about and how to relate it directly to what is going on. So, ladies and gentlemen, please, let's come back into the hall and settle down. You don't want to miss this presentation. You don't want to miss this presentation. Please come back into the hall. Let's settle down and let's take this presentation before we go on with the other quick presentations as well. We're here, we're going to have a good time. I have the BOT members seated.
It may be difficult for us, but the food is enough for everybody. So the first thing is just ensure that your ticket is with you. The ushers will come for it and deliver your choice meal to you. Please, we do not want any doctor to be upstanding during this section. That's number one. The second thing is that SWIFA is introducing to this conference the first and the only WHO pre-qualified sulfadoxine and pyrimethamine, SP, for the intermittent preventive treatment of malaria in pregnancy. The product was produced for WHO, USAID, UNICEF supplies. And is extending the offering to all the participants at this conference at a discounted price, combined with free packs of pregnancy multivitamins, Suprafen. For this conference, they are saying if you buy 2 packs of 100 pieces of SP at a discounted value of 45,000, you get 9 packets of pregnancy multivitamin Suprafen worth 16,200 for the least category. Please, we are pleading that after this section, and indeed tomorrow, that offer still subsists. So we can visit SWIFA stand while this offer lasts. Distinguished colleagues, you can't get it better than this. And we appreciate you for visiting their stand. And on this note, I want to return the mic back to the owner of the mic, Barrister Funke Oluwole.
Would like to take the presentation sub-theme 1, enhancing patient care with AI-driven technology. And I'd like to call on Dr. Ademolu Owoyele, the D Business Doctor, CEO, Harley and Wall Healthcare and Business Consulting, to come and take this presentation. Please, a round of applause for him, please. And kindly settle down so that we can pay rapt attention to this presentation.
Good afternoon, His Royal Majesty, Alara of Ara Kingdom. I greet you, sir. The chairman of the occasion today, in person of Dr. Ekong, who is also my teacher. I think there's an adage that says that if you honor your teacher, you will live long. So I honor you, sir. At the same time, I think Dr. Omolola Salute to you, sir. We have a long list, so there's no way I'm going to be able to mention everybody. So I stand on existing protocol. Standing here before you this beautiful afternoon is Dr. Ademolu Oyele. I'm popularly referred to as the business doctor. And some people may wonder that, what does it mean by the business doctor? I remember that when Professor Faduyile was speaking earlier on, he said quite a lot of things. And among that is something that caught my attention. He said, we doctors need to look at medicine or healthcare through the prism of business. And I think it's very important for us to begin to do that right now. This is one of the ways we can achieve sustainability in our healthcare today. But today we're going to be talking about something very important to us. At the same time, I think it's also important I mention that we founded what we call the Business Doctor Mentorship Academy, which is Nigeria's first health and medical business academy in 2017. And this was done in collaboration with people like Dr. Odo, who was the president of the AGMPN at that time, and also somebody here present, that is Dr. Aipo. I salute you, Dr. Aipo. Thank you for always being very present in transforming medical practice through entrepreneurship. So it's important I mention that. So if we look at the screen in front of you, there are certain keywords over there. AI, which is artificial intelligence in healthcare, revolutionizing patient care. There are 4 keywords there. Artificial intelligence, healthcare, revolutionizing, and then patient care. So can you allow me to ask a few of us in this room today? Because some of us may feel that maybe artificial intelligence is another buzzword. But it's important I ask. I don't know if 1 or 2 people can tell me, what's our impression of artificial intelligence? This is not a lecture class. So it's going to be like an interactive session. I believe that we'll be able to, I cannot lecture my seniors over here. I can't lecture my teachers. But they've appointed me as a servant leader to lead the discussion. And I hope I'm able to do that. So can I hear from us, what is artificial intelligence? If 1 or 2 people can tell us, just so that we can just understand where we're coming from. Is it just another buzzword? Artificial intelligence. What does it mean? Sir? Something that is not real. Somebody says something that is not real. So it's very abstract. Performing a real thing. Something that is not real, but performing a real thing. Something very abstract. So one of the best ways to actually discuss this is by using what I call analogy. That is practical scenario. That's one of the ways I feel that we're going to be able to talk about this. Then healthcare. What is healthcare basically? What does healthcare mean to us? You know, because healthcare has moved away from the way we used to see it about 20 years ago. It's about treating our patients, right? But it goes beyond that. Healthcare is now total. This is the reason why they call it total quality management. You must see healthcare in your various facilities, from the security man at the gate to the billing officer, to the customer service person, to the doctor, to the nurse, to the what? To the marketing officer. So it involves everybody within the facility. Healthcare involves what? The operations within your system. The profitability within your business. This is the reason why what Professor Faduyile spoke about is very, very important. Every healthcare practitioner must be trained and must understand entrepreneurship. And this is one of the reasons why people like Dr. Odo brought us in as a consultant, Ali and Work Consulting. That's my consulting firm, which we can take advantage of. The reason is because, let me give you an example. Even if you bring a finance man into your system, you need to be at the same wavelength and understand what he's talking about. That is what awareness does for you. I do not know anything about, is it Red Doors or something like that? The facility in Ikeja. I don't know anything about that facility. But today, there's an awareness about that business. We now all know that there's something called Red Doors or Regos or whatever it is. The first stage of any marketing process or any sales process is called awareness. You must know. So there are 4 processes in sales. I'm not doing business right now, but let me just mention. It's called what we call the AIDA complex. AIDA. A-I-D-A. there must first be awareness before you can generate any sale for your business. You must know that. That is what Regos has done today. I don't know if I got the name right. They are creating the awareness for their business. So we now all know about them. But aside from that, is the fact that for those of us that are married here, before you married your wife, what did we do? You must let her see that you have an interest in her. Or else, she's not your wife today. So that is the analogy I can use for marketing. You kept on telling her that, look at me now, I like you and things like that. You even bought something for her. You generated interest. That is the I in AIDA. Awareness, interest. When you go to a mall and you see people giving you something, taste this wine. It's very good. They are creating a desire in you. That is the D in AIDA. Awareness first, interest second, desire third. They call it sampling in business. They give you something to sample so that you can say, oh, it tastes good. Okay. Then you now finally take an action. That is the AIDA complex of marketing or sales. So let us move on. Okay. So we already say, what is artificial intelligence? I'm going to, basically, we all understand computer science, right? And medical science. A branch of medical science is gynecology. A branch of computer science is artificial intelligence. It focuses on what? Using computer or using machines to perform tasks that human intelligence will naturally do. It's as simple as that. Artificial intelligence is what? Is a branch of computer science. The same way gynecology or pediatrics is a branch of medical science. So that branch, rather than focusing on women, it focuses on using machines to perform tasks that natural human intelligence will do. So let us give you an example. There's something I use when I speak at international conferences. I use what we call the 100 apples in a basket task analogy. 100 apples. So if I put 100 apples in a basket right now, and I ask you, can you please identify how many apples are green, how many are red? That is a task, right? Do we agree? It requires what? Human intelligence. So now, for us to do that, a dog cannot do that. Do we agree? A dog cannot perform that level of intelligence task. So now, for you to do that, what are you going to do as a human? Can somebody answer? You're going to sort it out. That's the first thing you're going to do. First of all, you need to sort out the 100 apples to know which one is red, which one is green. So now, if I now create a machine to do that same task for me that my human intelligence will naturally do, I have created artificial intelligence. It's as simple as that. So it's nothing abstract. And let me also tell you something. Okay, so what should we do as healthcare practitioners? Should we be afraid of artificial intelligence? Or should we feel that it has come to take over our job? What should we do, basically? So now, it's also important for us to know that we all know the internet, right? Do we think artificial intelligence came after the internet or before the internet? Sir? Before the internet. Who agrees with him, sir? You agree with him? I think I wrote it over there, so it's okay. So actually, AI has existed with us for over 100 of years ago. So it's not a new thing. It's not a new philosophy at all. There's only a reason why people tend not to know so much about it. Because of what is called the AI winters. The first time the word AI was coined was in 1956. So I'm going to take you down history lane. 1956. That was the first time AI was used in 1956 in a place called Dartmouth College in the UK. But before that time, more than 50 years ago, there's always been robotic engineering. People seeing how they can I create something that can think like humans? Let me also use another analogy. If I live in my house and I have to, as a doctor, I have to go to the office, and there's always something that needs my attention in the house. What do you think? If I have a machine or something that can do the same thing for me while I concentrate on my job in the office, is it better? Am I a better human being or not? Exactly. That is what artificial intelligence is. To create machine or something that is able to make my job easier so that I can focus and concentrate on something bigger. So I can be what? Efficient. So I'm going to talk about efficiency later on. But now, when I also speak at conferences, I tell people that there is no better place in the entire world that has a better case study to justify the need of artificial intelligence than Nigeria. Do we agree with me? Maybe you don't agree, but let me tell you. Let me give you a statistics. What is the doctor-to-patient ratio in Nigeria today? Sir? Dr. Akin Tade says 1 to 5,000. That statistics was probably 3 years ago, sir. 1 to 10,000. Fantastic. Currently, as I speak to you, it has increased to what? 1 to 10,000. That means that for every doctor we have in Nigeria, one, the doctor-to-patient ratio is 1 to 10,000. I have one doctor available to treat 10,000 people, while the recommendation by the WHO says 1 in what? 600. 500 to 600. Yeah, the same. Can you see the gap in that place? So there is no better place than Nigeria where AI should be working day and night other than Nigeria. Because on a daily basis, our workers, our healthcare practitioners, they are jackpotting on a daily basis. So what we need to do is that we need to find a way to balance artificial intelligence to assist us in providing the right care for our patients. Because we do not have enough human resources to deliver on our objectives. So I talked about the AI winters. And again, let me quickly talk about something, because some people are afraid, saying that maybe AI will come, take over their job and the rest of that. Yes, do we agree that AI can replace human beings? Somebody said yes. Not really. Is there any reason? Not fully. Yes. Not fully, right? Why do you say not fully, madam? Why do you say not fully? That is, sir? Not fully. So why do you feel it can replace human being to an extent? Even doctors right now. Let's go to healthcare. Why do you think artificial intelligence can replace doctor to an extent, but not completely? Is there a reason? Sir, it needs your presence. Okay? They said it needs our presence. Okay? It's okay. We are going to look at some statistics and we really confirm whether it's true or not. Okay. So now, what is patient care? I already said that patient care encompasses the full spectrum of anything about care. It goes beyond just treating a patient. It goes beyond just treating malaria. So patient care involves the physical, the mental, the emotional, and social well-being of your patient. And I'm going to refer to this particularly by using the definition of the Institute of Medicine, IOM, which is now called the National Academy of Medicine. It defines that the focus of healthcare, the focus of patient care, should be 6 parameters. If you are able to achieve those 6 things within your facility, you are delivering the right care. And your business will be what? Profitable and sustainable. Your business is going to go beyond just patient outcomes. And this is also one of the reasons why every doctor must understand business. That is the truth. You don't have to be an expert. Like we're speaking about AI right now, we are not planning to be an expert, but we must understand where things are going, and that is very important. Because efficiency, we're not taught in school how to be efficient, but you must understand operational efficiency. What is efficiency basically? I use that thing over there to describe it. Efficiency basically, 3 parameters. Number 1, speed. Number 2, quality. Number 3, cost. 2 parameters out of it, they will do what? They will go up. Your speed goes up in efficiency. When you are efficient, that means you are able to do things faster. When you are efficient, that means what? You are able to improve your quality better. When you are efficient, that means your cost comes down. So it's about doing more, achieving more with less. That's efficiency. And this is what artificial intelligence helps us to achieve in patient care. And we're going to see the statistics. But now, let me quickly talk about what I said earlier. The 6 aims of what? Patient care, according to the IOM. Number 1 is patient safety. Your patient must be safe in your facility. So when a patient comes to you to treat malaria, it does not go back with what? With HIV, infection control. You need to have infection control systems. Beyond infection control, your patient does not come to your facility and he trips on the floor, hits his head on the floor. It becomes your responsibility. The second thing is what? Timeliness of care. A manager leaves the bank and comes to your facility and is spending 4 hours to get care. It won't come back again. You lose such business, profitability is affected. But AI tools can also help to improve that timeliness of care in so many ways so that you can attend to your patient better, you can make better profits, and the rest of them. Effectiveness, you can achieve better accuracy in diagnosis. Efficiency, you are able to reduce your cost in so many ways. We're going to talk about that later. Equity, and finally, patient centricity. Once you are able to please your patient, make them happy, your patients will keep coming back, and your revenue goes up, your business does better. That is basically what AI will help you to do. So AI-driven technologies enhance patient care by doing so many things. Through diagnostic accuracy, personalizing treatment, and also streamlining your operation. So let's look at the first thing. Improved medical image. Let me pick out diagnostics and let's talk about it. How has artificial intelligence been able to help us in patient care? Just focusing on diagnostics alone. Faster and more accurate disease detection. And there are evidences to back it up. Number one, AI has been shown to be better than humans in mammograms. And that's the statistics over there. Human beings, expert I'm talking about. I'm not talking about a junior reg or a senior reg. I'm talking about full-blown experts. They have an accuracy level of 77%. But AI has been able to show accuracy of 85%. Even better than humans. So don't we think that it can replace human at that level? That is one. So AI has been shown to have better diagnostic accuracy than humans. Number two, let's do something else. Sensitivity and specificity for diseases. Whether this, there are a lot of forced errors. We all know what that means with human beings and things. But AI, the things that human beings are not able to pick, AI is able to pick them by 75% even more. Do we understand? That is to say, when you bring specialists to look at particular cases, they missed the diagnosis. They did not see it. Those cases that human beings missed, AI detected them with 75% improvement. Can we see where technology is going? So these are the kind of things that you want to ensure that you adopt to improve whatever thing we are doing. Next, let's talk about personalizing treatment. This is another thing that AI has been able to achieve very well. Healthcare has gone beyond generalist treatment right now. The way you just say, okay, everybody malaria treatment, give everybody chloroquine, give everybody something like that. The world is going into what we call precision medicine. What that means is that we are able to look at your genetic information, your DNA, to really see your genetic makeup and see whether there are mutations within your gene that predisposes you to certain diseases. Do we get it? And for that reason, we are able to intervene early on and do some things for you. So that is even what artificial intelligence does. So there, in every facet of healthcare or patient care, artificial intelligence is able to help us to achieve more. Okay, yeah. This is very important. It can also help you to what? To streamline your operations. Everything that you do, your support systems, your billing, your this, your that, your support beyond the core clinical practice. It can smoothen your operations and make things better, make things faster. Yes. Now, there's something called, we've all spoken about, okay, can AI replace humans or not? But we have come to the realization of something called the human in the loop model. This is the recommendation that when you combine artificial intelligence with human being, you are able to get even better results. So the combination of artificial intelligence and human is able to give you better results. But it is important that we recognize that for human beings that do not improve on themselves, if you don't improve on yourself, you will be replaced by artificial intelligence. It's important. We need to know that. So human beings, doctors can be replaced replaced by artificial intelligence. That is the truth. Because we just spoke about the accuracy level, we just talked about the efficiency. So in situations, you can actually bring in artificial intelligence and say, I do not need this. But bottom line is that it's important that doctors, we continually improve our knowledge. We continually improve our skill. Because that is the only way, I think I'm going to talk about it, maybe let me go back. Because that is the only way that, artificial intelligence may not be able to replace human beings. Let me give you the reason why. I talked about the AI winters. That's the reason why I gave you a bit of history. The AI winters was after 1956 when AI started. But people didn't know much about it. There were reasons. Number one, because artificial intelligence was not well funded. There were no fundings going into research. Research is what brings out evidence-based. So if you starve artificial intelligence with funding and starve it with research and starve it with data, artificial intelligence is going to die. Because artificial intelligence feeds on what? Data. Artificial intelligence feeds on data. And this is the reason why they say data is the new gold or data is the new oil. Data is so important. What artificial intelligence does is that what? It processes, it's still human beings. What happens is that every data that we have through research, you put it within the computer system and it sees a pattern and it uses those data, those information to give results. So what AI does is that it's able to reason and process information faster than humans. And this is where we get to what we talk about, informed decision making. You are only as good as what? The information at your disposal. So AI is only as good as the information you give it. Human being is also as good as the information that it gets through research, through improvement, through knowledge base. And this is the reason why the ANPMP must continue to invest in its people to see how the body of practicing private doctors continuously improve their knowledge, whether through, educational things. As I told you that we had the mentorship academy in business. The NMA recently, we just almost concluded it to train the young doctors in business side of medicine. And we've had this partnership going on with the ANPMP since 2017. And we're not really taking advantage of it after Dr. Odo moved on. So these are some of the things that we need to do better on and ensure that we give to our people. Let me also quickly comment. I know that Dr. Akin spoke severely during his welcome address. He talked about the fact that the government needs to come to the aid of the ANPMP. But I'll say this. I think I'll delay it till tomorrow. But let me mention, because I'll also be among the panel session talking about medical association and private medical practice. Now, when you create value, people will chase you. Should I repeat it again? When you have something to offer, people will chase you. You don't have to chase people. So now, the question is that the NMA, I appeal to everybody. Maybe tomorrow is really going to be something very, we need to really speak to us. Dr. Molola, do I have the permission for us to really, no holds barred tomorrow? So that we can, Oba, I seek your permission, sir, to speak Yoruba and proverb. Yoruba says that, si omo ya meji, toba wonule, toba soro, and they come out smiling and laughing, they have not really spoken to the right thing. But when they come out and you see their faces, then they have really, really got into the, So I think it's important that we need to talk to ourselves so that we really know. We must really be sure that the ANPMP is delivering on its promises. Let us reimagine what we are doing. Let us create value for our people in line with our mission. Let the members of the association feel protected. Let them feel supported. If they feel supported, protected, I tell you, everybody will be running here. You won't chase them to come and join the association. They won't be going to other associations. I'm sure you are aware there are many associations. And they are taking your members. That is the truth. I'm just saying it. Because they are seeing some relevance over there. So we need to reimagine ourselves. It's important. And at the same time also, so what I mean by that is, if we give value, the government will come and meet us. So let the government see that we are giving value. We have to collaborate with them. It's not about fighting with them all the time. So just as you said, I'm going to re-strategize. You need to. When you fight with them, they will abandon you. There's no reason why the Commissioner for Health is my Oga, and is my friend. It should be here. Because 65% of the care is in private sector. There's no way you can achieve. People talk in Abuja, they do UHC all the time, universal health coverage. How do you achieve UHC without private sector? It's not possible. When they are responsible for 65% of care. So those are some of the things. So it's important that, what I will say is that let's give value. When we give value, for example, in discussions of policy making, ANPMP should be leading. So when you are discussing policies, you are leading. And definitely the government must call you on the table when they are discussing policies, when they call strategies. Now, I just talked about artificial intelligence and the workforce. Nigeria is still battling with brain drain, how to resolve it. Artificial intelligence is one of the ways we can resolve it without no stress, by adopting AI into this system. You have a doctor ratio to patient ratio of 1 to 10,000. How do you think you are going to provide very good health care? You cannot. And you have a system that can help you augment that and things like that. So what the government should do is that the same way the government is doing with solar system, where they subsidize the solar system, they need to subsidize AI to come into the country. That is what you do. So when they say that, do away with subsidy and things like that, it's not possible. You cannot do away with subsidy in particular places. The United States of America is the largest subsidy payer in the world, US. And every country of the world pays subsidies to its people. So what the government needs to do, what you need to fight for the government as a policy direction is that the government is not going in the direction of AI yet. So let me give an expo to everybody. Develop yourself in artificial intelligence. Get the knowledge. In the next 5 years, 10 years, I tell you, in the next 50 years, the future of the world is artificial intelligence. There's nothing you can do about it. I'll give you an example, a practical case study. We all know Nokia, and we all know Kodak, right? For our fathers that are here, you all know Kodak. You can see my PA over there. She's doing a video on her phone. About 30, 40 years ago, she will have used a Kodak to take my picture right now. But what happened? Kodak did not listen to his environment. Kodak. They were doing films. You know films now? Film to take picture. So when people were making the first digital cameras, Kodak said, digital camera, what is that? I'm the biggest film company in the world. Don't worry. 5 years after, 10 years after, they eroded them and Kodak ceased to exist. There's nothing like Kodak again. It used to be the largest camera company in the world making films. How about Nokia? Well, I was still in medical school. Nokia Communicator, Nokia and the rest of them were the largest telephone companies. You can never imagine that Nokia today... Sorry, how many people use Nokia in this room? Nokia. Nobody's raising up their hands. How many people is using Samsung in this room? You can see hands. How about iPhone? You can see hands. So bottom line is that if you do not listen to your environment, if you do not look at what is happening, things will go on under you. Artificial intelligence is the future of the world. The ANPMP needs to key into it so that we remain relevant. And each individual doctor that also keys into it, you become relevant in the future of artificial intelligence. So everybody needs to what? Develop themselves, understand it, and things like that. And at the same time, the government, I know very well, in the next few years, and you can take it up. Let the HBMN take it up as a model, commit to the body, and let us look into that area and things like that. That is one of the ways that we can definitely make it easy and improve efficiency. Okay. AI robots have been used to do surgeries. We know that. And patients have been able to go back the same day, even within hours. What will have kept them in the hospital for about 1 week, they are able to perform surgeries using robotic surgery, and they go out the same day. So it reduces what? The cost, the bed cost, and so many things. Yeah, thank you. You can also see there's a wristband that can monitor epilepsy. So what you wear the wristband in your, these are technological innovations. So you wear the wristband on your hand. What does it do? It monitors your vitals and tells you when you're going to have the next epileptic attack. So you are able to act before it happens. That is the way the world is going. A lot of technological advancement to help patient care. So now, are there challenges with artificial intelligence? Yes, there are quite a lot of challenges with them. Number one, there's something called algorithmic bias. What it means is that sometimes AI can also give you a wrong information. That's what it means for certain reasons. Apart from that, also, trust. Some people still don't trust AI. So we need regulation. So regulation, and that is one of the core functions of the ANPMP, and also there needs to also be a part of regulation over some of these things. So now, what is the impact on private medical practice? Number one, okay, thank you very much. So productivity. So for our hospital groups, it helps with productivity. And what is productivity? Effectiveness plus efficiency gives you a productive staff. What is effectiveness? That means you have a staff that's able to do his job. If your staff is not able to do the job the way you employ him, it is not productive. I hire you as a laboratory scientist. You are not able to pipette. You are not able to do basic things to give me results. Or you are able to run a test that should come out in two hours. You give it to me in 7 hours. You are not productive. Efficiency. What you are supposed to use 2 meals for, you are using 10 meals. Automatically, what it means is that you are increasing my cost. So those are the areas where doctors need to pay importance to. We're not saying that it's not a must you have to be a financial expert, but you need to have the openness to know that there are times that I need support, people to assist me in my business, getting the right people to assist me and look at the books, and they can save me a lot of money and make me more sustainable. Competitive advantage. Now, for those of us that are able to adopt AI faster and better than the others, we have edge over the others. So that's competition. So it also helps with competition. So you have a competitive edge over other people. So another thing is potential cost reduction. We've said a lot of things about cost reduction. You're able to bring down your costs. And what is profitability? Profitability is just two things. You achieve a profitable business by what? Increasing my revenue and bringing down my cost. But which one is easier to do? Reducing my cost. It's easier for me to reduce my cost than to increase my revenue. So when I come into a new business, when somebody brings me in as a consultant, one of the first things I do is to reduce the cost from day one. That one is easy. Analyze the situation, because to get in business, I must get marketers, I must hit the road, get new business and things like that. You will do that. But from day one, look at leakages in the system. There's always a leaking point. There's always so many things going on within your system. So you can actually look at those things and see what you can do to transform the system. Opportunities for private practice. What are the opportunities with adopting AI? We've talked about it. Increased profitability, enhance provider satisfaction, competitive advantage, reduce overhead. What are the considerations basically? Number one, we need to look at training and implementation. People need to get trained towards implementing. We need to look at ethical consideration, because people already feel, will AI be used ethically? Because if you allow it to just, they said that anything that is good can also give you, it's like sugar. As good as sugar is, but if it's too much, it gives you the negative side. So that is it. So this is the reason why there must be regulation. It must be regulated. Once it's regulated, then people are able to use it ethically and appropriately. Financial considerations, possibility of physician organization and association coming together. So what can we look at a situation whereby the ANPMP as a body gather people together and adopt AI system, and people are able to pay for it together rather than as individuals? Is that a possibility? Is this something that the ANPMP can do? A possibility of paying together to adopt it, and people are able to use it together. That's like a co-payment system, so that we reduce the cost per unit on every individual. That's another thing.
So, as I said earlier, the future of artificial intelligence, the future of healthcare is what? Is AI. AI is not just a tool, it is a transformative force in healthcare. By embracing these technologies responsibly, we can unlock unprecedented potential for patient care, operational efficiency, and medical innovation. Having said this, it is important for us to know that the future of healthcare is AI-powered. And the earlier we begin to find ways to position ourselves, the future is better. So thank you for your time. Thank you for having me. If there are any questions, I can take some of them quickly.
Thank you, Dr. Ademolu, or something, yes. Thank you so much. I've been using AI for the past 7 months in my practice, and it's been wonderful. But I've been using it, but I saw something you wrote now. You say, we have to adopt it. I don't know whether I've adopted it or I'm just using it. That's my question. Thank you.
Thank you very much, sir.
Is there any other? Okay, so we have 1, 2, 3, and 4. Mommy? We've been unfair throughout this program without allowing question and answers. But this particular one, we're not going to miss this session. So we will go as far as 6 questions, and we'll leave it as that, 6. I'm sure that anybody else that has questions can see Dr. Owoyele directly for personal consultation. Number 2.
Thank you very much, my brother, for this very exciting lecture. I think you have said it. The future of healthcare is AI. Having understood this very well today, I want to advise Mr. Chairman to see how all members of ANPMP can have a full understanding, irrespective of age, about AI. So in view of that, we want to see how we can collaborate with you to have structured training about AI. Because a lot of us, we say, you are too old. There's no age barrier in learning. You learn until when you go to grave. Like I've told some people, by next year, I'm enrolling for a leadership course at Harvard. And I will continue to do this. I've done one in Lagos Business School. I'm doing another one I want to do. So, my colleagues, today, let us ensure we embrace AI. This is the beginning of AI solution to healthcare problem in Nigeria. And this will be driven by ANPMP through our chairman. Lagos State is a pay center, and we need to embrace it. Thank you very much. My advice to our chairman.
The oracle has spoken.
Thank you very much, Doctor, for your beautiful presentation. I know I've been using AI, but I don't know, maybe it's original one or fake. I don't know. That is number one. Because you are talking of maybe we can co-own something AI. I don't know what you mean by that. And my second question is that from my own perspective, when you talk of AI, and then as a doctor, that probably you can change, but there is still something, being a doctor, the way we were taught to come up with a diagnosis from presenting complaints and all that and all that and all that. I don't think AI can substitute that. There is no way you can AI will palpate a patient. There is no way AI will ask with a patient. There's no way, even seeing very well some little spots all over the body. Maybe you can see it, but you still need close observation. So I don't know, is anyhow this can be done? It will be possible forever to eradicate doctor, physician as doctor seeing a patient. I think it will ever happen. Thank you.
I'm not sure he made that allegation, but we'll take it as he has said it. We want to move to this side of the hall.
Thank you so much, sir. My name is Dr. Essien Ekong. Let me help the previous speaker. I don't believe that the future of healthcare is in AI. I think the future of healthcare is in human beings and not AI. What I was told is that what you can say is that AI holds the future in the analysis, integration, and application of data generated by human beings and experts. So, who generates the data, who generates the knowledge is human being. So it's when you generate it and feed it to the machine, that's when they integrate it and apply it for our use. So I don't believe that the future of medical care is AI. Human beings still remains the future of Medicare, but AI can better make use of its application, storage, and recovery. There are so many things I know that may not recover easily, but when you feed it to AI, they can recover it. Even something that is 20 years or 50 years ago, they can recover them and integrate it. AI can hardly produce anything, but they can apply, they can integrate, and make the usage possible. That's my own submission. Thank you very much.
We have several future guest speakers and keynote speakers here in this audience. I will pass you.
Please, considering empathy, when reviewing a patient or seeing a patient for the first time, I want you to emphasize how AI can really deal with empathy in the management of a patient. Thank you.
Question, I believe that's the second question. The comments have been taken, well noted. Question, sir.
Thank you very much, the speaker. So many things you have said that I quite agree with. But I think there are still so many gaps in the area of artificial intelligence adoption and implementation in a country like Nigeria. You rightly pointed out that AI is largely dependent on data. Unfortunately, many of the technology that we're going to adopt or models that we'll be using in Nigeria will be probably trained with data from Europe, from North America. And we always know that because of so many differences in environmental, genetic, and all of that, you may not be able to rely on the accuracy of a diagnosis and the treatment. I think we have enough data in Nigeria, but many times they exist in silos. We have not synchronized this data. So my question will be, where are we starting from? Because you also mentioned the fact that here we have doctors to patient ratio of 1 to 10,000. That's an issue. However, majority of this gap are in the rural community, out to reach underserved environments. Because I'm sure majority of our practitioners want to practice in the cities. They don't want to go to the rural environment. It is also, unfortunately, these rural environments we have the infrastructural deficit is huge. And you need the infrastructure to support AI. So, where do we start from as a country? Because it's good that we have AI. All of us are looking out to it, and we don't want to continue to start from the end. Let's start from what do we need to do, the minimum we need to do to be able to get there. Because it's not about what we think alone. We have to look at the infrastructure to support this. And this is where personnel, the network, the electricity, all of those things will come in, and then the data. Thank you very much.
Please, we're going to take the presentations back to back. Can I have Activity, LB, and NEMEL, and SJS have your presentations ready so we can proceed right after the question and answer session?
Thank you. Thank you. Yes. The question is, you mentioned subsidy from the government and regulators. Before that comes, are there any immediate tools that a small practice, a medium-sized practice can implement, like living here today? Thank you.
Thank you very much, sir, the business doctor. My question, I am a psychiatrist. AI, how do we go about those our expressions in psychiatry, mood symptoms, and then culturally, the way Africans present is not typical, not what we see in the books. And also sometimes the symptoms are masked. So you really, really need to be skillful as a psychiatrist when you do one-on-one, getting those symptoms out and making the correct diagnosis. So when it's AI, how does it go? Thank you.
Thank you very much. Nice presentation. I don't want to answer the question for you, but I just want to say something, sir. Number one, the person who invented the computer, after inventing it in a very big room, they asked him, the person who invented it, that how soon do you think we can get it everywhere? He shook his head and said maybe not in his lifetime. And just 20 years, 15, 20 years, we now have computers with us. Now, every one of us is carrying a computer. We don't need computer. So if you think AI is not the future, you are not ready to understand the system. I'm sorry, I'm not giving lecture. With your permission, you will still say your own. I think the system is garbage in, garbage out. That is what they say in computer. If you are waiting until they do for Africa, it is what is on ground. Africa has no telephone. It is this telephone you are using. The book we are reading is not African, but we are doing an exam, and we are writing what they are doing. So I think we should first understand this stage, those old methods. How will we touch? How will you do this? AI will do it. And it will do it even better than human being. So, but importantly, my fear for AI is most of this technology improvement, it comes long before the regulation. You remember about this embryo? Suddenly, it became a big issue on regulation. My fear is that I always tell people, you sit in your clinic, you have 10 patients you have been seeing, and you are sitting in your office or using your own personal AI thinking they will come to you, and they're actually consulting doctors in Switzerland, in all other places, taking money through AI and doing the medication and collecting the drugs and collecting the money. How do we regulate it? When Indians came, we were still sitting on MDC and don't advertise, don't do this. They came and took all of our patients. They have gone beyond that. They are now in our place, and they are taking all our patients right in our presence. How do we regulate it? Why don't we now start forming committees on how to regulate AI for our benefit? Lastly, when I was NMA president, a lot of these bankers, a lot of these people came. They wanted our phone numbers. Once they get your phone numbers, they don't need you again. They will get everyone, interact with them, and you will be sitting, hoping that the next patient is coming. Meanwhile, they are using our data freely that you have given. They will use it against us. I think it's important for us, for you to tell us
how we can regulate it so that they will not turn us to small workers in our area. Thank you.
Thank you very much. Yes, please go ahead as quickly as you can.
Okay, quickly. So, thank you very much. That's a whole lot. I think I have about 10, but I'll try my best. Professor Faduyile, may God bless you for your wisdom. You've always been, full of wisdom, and I appreciate you for that. You've made my job very easy. So I'm going to start from there. Just as you said, the truth of the matter is that you cannot say because we don't have something specific for Nigeria and you will not adopt. Just as he said, the truth of the matter is that a lot of what we're even using right now is based on something that started from another place. We need to start. If I may ask a question, sir, just, to get there. Is it possible to eat an elephant, sir? Yes, sir. Yes, sir. So that I can get to your response. Is it possible to eat an elephant? No, I get all of us will, Dr. Prasad has answered it and we are good. I just want to, is it possible to eat an elephant? Somebody said yes. How is it, sir? Simple. That is wisdom. You can actually eat an elephant. All you just need to do is that cut it and be taking it one bite at a time. Someday you will finish it. It's as simple as that. When you think that the problem is enormous and you leave it and you move away, you will never ever get to the end. But when you see the problem and also tackle it one step at the other, break it down. In project management, that's called work breakdown schedule. Whatever thing you have, you break it down and you begin to address it one by one. So it's as simple as that. So the way we see it, bottom line, is that whatever it is. Now, if you look at my slide, can we go to the slide, please? There was a slide there. I couldn't dwell much on it because of time. I talked about algorithmic bias as one of the challenges with artificial intelligence. That is what it means. A result of how an algorithm is developed or trained, resulting in unfair outcomes because of flawed data sets. It is recognized that, for example, let me give an example. You want to use artificial intelligence. The data we put into it is from America. So it does not take full cognizance of what we have here. So it's possible we have an outcome that we don't exactly want. So what that one will happen is that, just like with regulation also, you don't have people forming regulatory bodies if there is no stimulus. It's usually a stimulus from people starting to use something that will make people say that let us regulate this thing. Let us keep it in check. An example is this: clinical governance. We've heard it before, which to the UK people is called clinical governance. For to people in Japan, it's called Kaizen, continuous improvement, or total quality management. That's where it came from. What it means is that it never came to being before 25 years before now, until 1996 or thereabout. I can't get the exact year. As a result of what is called the Bristol case model, the Bristol models. You can Google it over there. Just Google Bristol in the UK. Some children were being killed by healthcare providers. Somebody now analyze and say, why were children dying in this place? That was the origin of clinical governance that regulates quality that we're all doing today. So what I'm saying is that it is when we begin to adopt some of these things and there's adequate knowledge, then people begin to say, let us have some regulators around it. But we can start early. So that's the reason why we're saying that ANPMP right now should begin to look at those areas and begin to form policies to support the government. When government sees that you're already doing something, they are driven towards you. So ANPMP or ANPMP must be drivers of regulation, must be drivers of policy. By saying that, the government come closer to you as a body of knowledge. That's the reason why I say when you give value, the government will come in your direction. Then there was another question from Sir over there. He said that he uses AI, but he doesn't know whether he has adopted it. Basically, I don't know what you use, sir, but if you use an AI tool, it's as simple as that you have adopted it. The word adoption is just to show that a larger group of body have accepted to do something. That's just what it means. And it usually comes from awareness for us to understand what we are doing right now. This is the reason why we need to educate ourselves. We need to know more. You can't even regulate things when you don't go for training. So when we're talking of regulation, that's the reason why our members need to attend courses, training to understand artificial intelligence more. So even when there are tools, new trends, you are able to say this is the direction to go. You cannot regulate something that you don't know, you don't have knowledge about. As a regulator, your knowledge must be at par or superior to the people that you are regulating. So you must continuously understand and improve yourself. There's another question from there. I can't, fully remember right now. Sir? He said something like it's not possible to do some things. And somebody also talked about empathy. The truth of the matter is that there are, how will I say it? There are already AI tools that can respond to human feelings. So bottom line is that we don't know, just as Prof said, we don't know where it's going to get to. Even me, I do not know. But I know that it's important that we see that this thing can go to even where we don't imagine. Now, imagine 100 years ago when there was no telephone. Could anybody have imagined that we will be able to talk to somebody in America today from here, if not Juju or Jazz? Think 100 years ago that I can be in Nigeria and talk to somebody that is in America. They can never imagine it. It's the same thing with AI. What you think that you cannot imagine right now is going to happen under your nose. Kodak cannot imagine that another person will do this, but it definitely happened. So it's just for us to what? To be prepared. And that's what I can say about that. So another, I don't know.
One final question is...
Who did I miss? Is there any other question?
The young man at the end there who asked that what are the immediate tools that can be taken away from this conference?
The truth of the matter is, with regard specific, there are so many tools. What happens is that organizations usually develop them. For example, IBM has its own tool for HR, human resources. That is to say, it is called Ask HR. That is the IBM tool for human resources. And they created that to solve everything, not everything, a lot of things with human resources. What do human resources normally do in the organization? They developed it to solve them. Anything about employee payroll, anything about so, and so, they developed it to respond to it. What we must understand is that when you are able to use AI for certain roles, you free yourself and do the more complex thing. That is how we should see it. That is the human in the loop model. Use artificial intelligence for the basic thing. Just in response to your question, sir. Use AI for those things and so that you can free yourself for the things that are much more important that needs your expertise. Thank you very much.
Thank you very much. I think we can give him a big round of applause. Where is it? I would like to ask a question here, please. How many of you were present at the African Digital Health Summit that was held in June this year? African Digital Health Summit, the third or fourth edition was held this year. It's been going on for the last 4 years at Eko Hotel. 1, 2. That is where everything digital that is happening in the healthcare space is going on. And it's an African summit. It's across, you have participants from across Africa who will tell you and show you what AI is doing in the healthcare space. We think it's not doing anything. Oh, it is doing a lot. And they are achieving a lot of data and outcomes. Please, don't miss the next one. June, it holds the last week in June every year at Eko Meridian, Eko Expo Center, African Digital Health Summit. You can go online, www.adhs.org, and check out what you see there. You'll see that ANPMP cannot afford to be left behind. God bless you. Thank you very much. Oh, yes. Dr. Akitade.
Thank you very much. I believe that Dr. Ademolu Oyele have done tremendously well on this topic, and the only thing to support him with is your applaud. Please, can we give another round of applause, please? Thank you, thank you, thank you, thank you. We want to use this opportunity to announce the entrance of the first doctor in Lagos State, the chairman, NMA, Dr. B.K. Said. That's Babajide Kehinde. Thank you very much for coming. May I crave the indulgence of the chairman of this organization, Dr. Jonathan Esegine, to climb the podium, while the chairman of today's occasion, Dr. Essien Ekong, to join us to present this beautiful plaque for the resource person on AI, Dr. Ademolu Oyele. You deserve it.
Association of Nigerian Private Medical Practitioners, ANPMP, we present this to our able presenter on artificial intelligence. God bless you and thank you very much.
Okay, it's humbling receiving an award from your teacher 25 years ago. So thank you so much, sir. I appreciate this. Thank you. God bless you, sir.
Please make sure you follow through with Dr. Molola's suggestion that you work on capacity building and training programs with ANPMP. It's very important. Well done. Thank you, Dr. Oyele. We're entering the last segment of today's activities, and I want to say that we've had a marvelous series of presentations so far. So we're going to end on a high note as well. We'd like to take short presentations. I see 5 minutes for activities presentation, 10 minutes for LB's presentation, and 10 minutes for Nemel's presentation. Can I have the presenters for these 3 presentations show themselves? Activity? Oh, please. Right away. We're taking them back to back. Please make sure you have Dr. Chiagozie Eze's presentation ready so that we don't have any time wasting in bringing him to the podium after we've done with these presentations. We also have one from SJS. Quickly.
Good evening, all. Permit me to stand on the existing protocol. From Gladstone Azubike from Activity Pharmaceuticals. I'm here to present a product called Femenica. Most of our female patients has lost their joy. Some people, their home has been broken due to infection. But this product, Femenica, has returned the joy of every woman, making them to be more beautiful. Femenica is a product used to treat and manage infections in women. First of all, let's look at the microbiota of the vagina. The vagina composed of lactobacilli 80 to 100%, which is Crepatus, Acidophilus, Ramonos. We have bifidobacteria 1 to 10%. We also have the non-beneficial bacteria like Streptococcus, Enterococcus, E. coli, Candida albicans, Candida glabrata, then Gardnerella vigilis. These are also found in the vaginal wall, but they are not beneficial. They are the causatives of the infections, which this makes up a healthy vagina. And what does this lactobacillus and bifidobacteria does to the vaginal microwall? It protects it against pathogens. It regulates the activities of the cycle, menstruation cycle, reproductive health, and it also maintains and regulates the acidity of the vagina, which is between 3.8 to 4.5. Now, what's the composition of my Fermenica? The Fermenica composed of boric acid, 600 milligram, aloe vera, 130 milligram, apple cider vinegar, 20 milligram. The apple cider composes of ethanol, lactic acid, water, and polyphenolic acid. We have prebiotic blend of fructo-oligosaccharide, 150 milligram, and we have 60 billion spouts of probiotic. Now, if you look at the selected probiotic, they are the ones that are found in the vagina microbiota that maintains, regulates, and also protects the vagina. Now, the mechanism of action of this drug is to return back the imbalance, because when a patient is infected either by Candida or Staphylococcus or vaginitis or even gonorrhea, there's an imbalance in the vagina microbiota. That means the non-beneficial bacteria are of high population, thereby creating the environment to be favorable for their growth. But when you insert one Fermenica in a day, what it does, it tries to restore back the balance. So we call it a broad spectrum treatment for all infection, because it takes care of pathogens generally. It's not a targeted drugs for either Candida or vaginitis or Staphylococcus or gonorrhea. Its basic target is to bring back the vagina to its balance by maintaining the pH back to 3.5 to 3.8 to 4.5, and also bringing back its mechanisms. Forward and backward.
It's for...
No, here is for front and back.
Yes.
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 Good evening, doctors. Permit me to stand on the established protocol. My name is Essien Ekong. I'm medical sales rep from ANPMP Limited. Is it? Okay. We'll be looking at the use of clotilidol as a mono and combination therapy in management of hypertension. But before we move further, it's important I give you a brief history about our company. Just like I said, I'm from ANPMP Limited. ANPMP Limited is an indigenous company. So the antihypertensive combination we'll be talking this evening are all manufactured. The factory is situated in Enugu. So we manufacture, we don't import. We only import the raw material. So these products are our own products that are locally manufactured. So we have a lot of products, but due to want of time, we'll be looking specifically at our antihypertensive and its clotilidol as used in mono and combination therapy. Hypertension has remained a global health challenge. We can start now till next week and talk about hypertension. But it's important we know that the incidence of hypertension is quite increasing every day. In fact, recent studies have shown that 1 in every 3 patients that comes into your clinic are likely to have an hypertension. But the good news is that in as much that this hypertension has no known cure, it can be properly managed when appropriate drugs is being used, more especially when you use a combination therapy. And research have proven that patients that are being placed on double and triple combination tend to being better managed, unlike monotherapy. So you find out that it's only few patients that may need a monotherapy where you need a one molecule. Most of the patients may need a combination therapy, be it dual therapy, as in 2 drugs in 1, or a triple therapy, as in 3 drugs in 1. So having said that, for we blacks, the 2 major drugs that is recommended for management of hypertension are what we know, the thiazide and thiazide-like diuretic. But we'll be looking specifically at the thiazide-like diuretic, which is the preferable diuretic for blacks. And here is where we have the clotilidol and indapamide. Most of us are familiar with hydrochlorothiazide, which is an example of thiazide diuretics. But today, it's important we bring to our notice that the thiazide diuretics have a lot of advantage, benefits in management of BP. So we are hoping at the end of this lecture, we'll see the need for us to always recommend a thiazide diuretic, be it clotilidol, over the commonly used hydrochlorothiazide. So we also have the calcium channel blockers, which is also good for the blacks. Then the last there, in some cases, some patients may be placed on the AROB, the angiotensin receptor blocker, and the angiotensin enzyme inhibitor, converting enzyme inhibitors. So having said that, we'll look at our clotilidol, which is our brand of, our Cypre, which is our brand of clotilidol, as being used as a monotherapy. We'll look at the pharmacokinetics, the mechanism of action, the advantages it has over the commonly used hydrochlorothiazide, as well as the suitable side effects. So for the pharmacokinetic, the great takeaway about clotilidol is that it has a long duration of action. And for most BP patients, if you look at the most BP drugs, rather, the pharmacokinetics, the half-life, you find out that most of the drugs that has a long half-life tend to have a longer duration of action. And once that drug has a longer duration of action, it's preferable in maintenance in controlling the BP of the patient. That's why you find out that drugs like temsirtan, amlodipine are most of the commonly used drugs because of the long half-life they have. By so doing, they have a long duration of action because this is the only way that will ensure that that patient can take that drug once daily, thereby ensuring a 24-hour cycles BP control without the patient having this rebound increase in rise in BP. Unlike the hydrochlorothiazide, which the half-life is within 12 hours. So you could imagine, by the time that patient takes that drug, for instance, 8 a.m. in the morning, before the patient gets to the next morning, that drug must have reduced significantly, thereby causing a rebound increase in BP. So this is like a comparison of hydrochlorothiazide and clotilidol. you find out that the key takeaway there is that the duration of action of hydrochlorothiazide is between 6 to 12 hours, while that of clotilidol is between 2 to 3 days. So when you take clotilidol, it tends to ensure a 24-hour BP control, just like I said earlier, unlike hydrochlorothiazide. So the mechanism of action of the thiazide and the thiazide-like diuretics are quite similar. What they do in simpler terms is that they inhibit the reabsorption of water and sodium. By so doing, they control the BP through reduction in blood volume. And these are one of the ways you can control BP. So that's why they ought. But another thing to note is that outside controlling the BP, the clotilidol does what we call going beyond the BP control, which are quite seen in the AROBs. Clotilidol also have these intrinsic abilities that tend to reduce the end organ damage. So outside the BP control, they tend to reduce patients from coming down with incidents of stroke, cardiovascular events, in comparison to hydrochlorothiazide, which doesn't have any of such effects. We are not saying that they are drugs used for stroke, but when you put it in comparison, the patient is less likely to come down. So these are what the thiazide-like diuretic comes with, which you cannot see with the thiazide-type diuretics. So these are when you are used for monotherapy, most times they are used for black, which we have established. The diuretics are drugs that are purely recommended for blacks. They are very good due to our the way our physiology treats our sodium elimination. So diuretics stands out for we blacks. So the side effect, most of the side effects are not so worrisome. There are side effects that goes off over some period of time. The only side effect that may be a little bit we have to look out for is the hypokalemia and hyperglycemia, as in reduction in potassium level. But the good thing is that when some of all these combinations are being used, like when you bring in temisartan in the combination, you find out that the issue of low in potassium level will not be an issue, because the AROBs are notorious for increase in potassium level. And also, when these drugs are being used in minimum strength, 12.5, the issue of reduction in potassium level will not be significant as well. So these are the combination therapy we have with our clotilidol, our Cypress. So the dual combination will have what we call Medira. The Medira actually have the AROB, temisartan specifically, and clotilidol. So this is a dual combination that has the AROB and the clotilidol. So this Medira comes in the strength of 40, 12.5 milligrams. So we also have the higher strength of it, in case you want to titrate higher, where we have the temisartan, 80 milligrams, and clotilidol, 12.5 milligrams. We also have another combinations of the two first-line drugs in management of BP, where we combine the calcium channel blocker, specifically amlodipine and clotilidol. So we have this in the form of aniline. So for the triple combination, for some patients that may benefit, maybe the dual combination are not working, you may need to step up a bit. So you go for triple combination. So the triple combination, where we have the temisartan, amlodipine, and clotilidol. So we also have in different strengths, where we have the amlodipine 5 milligrams, temisartan 40 milligrams, clotilidol 12.5. While the higher strengths have amlodipine 10 milligrams, temisartan 80, while the clotilidol have 12.5. So in all the strengths, the clotilidol is being maintained at 12.5. Because research has shown most times when you increase the strength of the diuretic, you tend to come down with more of the side effects as against without having proportional reduction in BP. So that's why in all the combination, be it low or higher strength, the clotilidol is being maintained at 12.5 milligrams. So someone will ask, why doing combination therapy? Why wouldn't that just place patients on one of the molecules, let's say amlodipine and temisartan, and titrate up? Why bothering giving patients more of the drugs? So there are reasons why patients benefit a lot from combination therapy with respect to management of BP. So one of them is that it ensures effective BP management. Specifically, give what we call synergistic effects. Just imagine when you use our Medira, which is a combination of a clotilidol and a temisartan, they are known to cause what we call synergistic effect. You tend to achieve better BP control. That is to say, for instance, let me assume that you give amlodipine, you give temisartan, for instance, 80 milligrams to a patient, and that temisartan was able to achieve a 20 milligram BP reduction. And you give clotilidol separately, it was able to achieve 10 milligram BP reduction. You find out that when you combine them, ordinarily, it's supposed to give 20 milligram BP reduction. That's what we call additive effect. But in this case, you have what we call synergistic effect. Instead of having that 20 milligram BP reduction, you have 30. You can have as much as 40. So it's synergistic. So they tend to potentiate the effect of each other. So this is one of the good things combination therapy does. So it also ensures shorter BP control. Mind you that BP, when you look at the pathophysiology, or rather the physiology of the mechanism of how BP occur, you have many things contributing. We have the cardiac volume, we have the peripheral resistance. So you want to attack the BP from different angles. So when you use drugs that have different mechanisms of action, like the amlodipine that may tend to reduce the peripheral resistance or the temsirtan, while the diuretics tend to reduce control from the blood volume or cardiac output. So you tend to achieve a shorter BP control while avoiding any reverse effect that may occur from the patient. Also, you would also achieve a reduction in side effects, just like I mentioned earlier. That's the temsirtan, the ARBs are well known for causing high potassium level, while the diuretics are also known for causing low potassium level. So any combination that contains the two tend to cancel each other, thereby maintaining the patient on a normal potassium level. Then greater end organ target combination. Some of all these drugs have the intrinsic ability to prevent patients from coming down from cardiovascular effect. Like the ARBs are well known for that, the temsirtan. And today we also bring to your notice that the thiazide diuretic, the clotilidol, also have the ability to prevent patients from coming down from cardiovascular risk, be it stroke and end organ damage as well. So, but the good thing is that it's not that you are giving this patient many drugs in forms of combination. These drugs are being present at a single P, thereby making it easy for patients, convenient for patients to take. So that you not become so worrisome for patients to take this drug. Mind you, some of all these patients also have some comorbidities, be it arthritis, be it diabetes, and other diseases, malaria once in a while. So they may have a lot of drugs they are taking. So this drug, in as much as they are combination, they are present as a single P. So the issue of convenience, the issue of compliance becomes easy for the patients to maintain with the daily or whatever you prescribe for the patient to how he has to take it. So this is how the cypress look like, the clotilidol. Most of us here know that this drug is not actually a new molecule, but we are bringing it back to Nigeria because we know that even outside the country it's being used. Even JNC8 also recommend it as one of the preferable thiazide diuretics in treatment of hypertension in black. So this is how it look like. So this is like a dose when it's used as a monotherapy. This is just a single dose of clotilidol, and it's called cypress. So this is a double combination, the Medura, which have the ARB, specifically the temsirtan and the clotilidol, 40, 12.5. So we also have the higher strength of it, 80, 12.5. So this is the combination that has the two first line, the amlodipine 10 milligram and clotilidol 12.5 milligram. This is a dual combination. So for some patients that may need to benefit from this, depending on the patient's comorbidities, you may decide to go for the Medura or you may decide to go for the Anuli. Then this is a triple combination of clotilidol, where we have the clotilidol 12.5, amlodipine 5 milligram, and temsirtan 40 milligram. So we have the higher strength of this as well, which is 10/7/4, where we have the amlodipine 10 milligram, and temsirtan 80, and clotilidol still being maintained at 12.5. So just like I said earlier, these products are manufactured in Nigeria, so you can rest assured of the availability, and they are also very affordable. So, and effective. So these are our own products. We are believing at the end of the lecture, some of us here, some of the doctors here can attest to the effectiveness of this product. So they are products you know if you place on patient, anytime you call us, they will always be available. And they are affordable because pricing is very important on this part of the world, especially for a BP patient. You wouldn't want to place a patient on a BP. By the time the patient buys the drug the first time and you want to do a refill, and you go to the pharmacy or you go to the doctor and they tell you the price, only the price of the drug will now become a trigger to the BP as well. We wouldn't want that. So the issue of the patient maintaining it based on the purchasing power is very important. So these molecules are quite affordable. Our stand is over there. So for those of you that have not visited, at the end of the lecture, we'll employ you to try and visit us and pick our contact as well. Pick your contact as well. Thank you very much.
Very much. Thank you very much. Well done. Thank you very much. The Yoruba says you say always save the best for the last. Our final presentation, sub-theme 2, is by our very own, and he'll be taking Managing Arthritis in the Aging Workforce. Dr. Chigozie Joseph Eze is the CEO, Medical Director of Chigoko Specialist Orthopedics Hospital. He has a BSc in Physiotherapy from the University of Lagos and MBBS Ibadan, MBA Lagos. He's also a specialist in spine, arthroplasty, joint replacement, so many wonderful things as far as the orthopedic section is concerned. Of note, he is also the host of Time Out with Dr. Bone show that hosts on Jordan 105.5 FM every Wednesday at 6:15 p.m. So you have the opportunity to listen to him. Ladies and gentlemen, please welcome Dr. Chigozie Joseph Eze to take Managing Arthritis in the Aging Workforce. Please have his presentation up for him.
Thank you very much. Ladies and gentlemen, the sponsors of today's section, the biggest sponsors of this section, they're going to say, I'm keeping the indulgence of Dr. Eze to allow DJ World, who are the headliners, to speak to us in 2 minutes, while the Sam Pharmaceutical also speak to us in 2 minutes, and we allow Dr. Eze to take us arthritis topic. Thank you. Please, 2 minutes.
Good evening, everybody. Fine. My name is Olugbenga Isaiah. I'm from Worldwide Healthcare. We are now known as DP World, which is, we've been into distribution of pharmaceutical products for almost 20 years now. And I would actually be presenting tomorrow, so I just said I should come and give you a heads up on what I'll be talking about. We'll be introducing our learning platform, which is actually Knowledge Lab, where you could actually be educated and you can interact with other professionals and all over the world, and then you would actually be able to do your CMEs, you'll be able to actually do things that would actually promote your journey on this, your professional journey. So tomorrow I will be presenting on Knowledge Lab, and I would want you guys to please come on and come and listen and come and hear us out. Our stand is actually right there, and you would definitely come register. One thing I'll want you to please come with when you're coming to register, which will be of benefit to you, is that you should come with your license number, which makes it easier for us to be able to actually get you registered. Thank you very much. Do have a wonderful evening, and God bless you.
Good evening, distinguished doctors. My name is Adedayo. I represent Sam Pharmaceuticals Limited. I want to thank the LOC, the entire members of ANPMP, for giving us the opportunity and the platform to showcase our products and to go into partnership for this conference. Well, I will not be spending more than the 2 minutes here given to me, but I would like to restate the existence of Sam Pharmaceuticals. While I was engaging with some of the doctors, one of them told me, "Sam, are you still in existence? Are you still in the drug business or pharmaceutical business?" And I told them, "Yes, we have been in existence for the past 54 years. And this year, 2025, is going to mark a very big milestone in the history of Sam Pharmaceuticals and the pharmaceutical business at large." What do I mean by that? The company is building state-of-the-art, the modern factory situated at Songotso Gates. That's between borderline of Lagos and Ogun State. And I can tell you categorically that we are 90% completed with the factory. And what that means is that our production capacity is going to be not even tripled. But I can tell you for sure that Our production capacity of tablets is going to be 1 million tablets production per day on daily basis. And most of the modern equipment we are using, they are modern equipment. So you can be rest assured. Now, that's just about the product company review. Then our product line. Some of you have seen some of our products there. We have the likes of Acipep antacid, the Omocool antacid that contains dimeticon, contains arginic acid for reflux episode. We also have our Facita brand of anti-malaria, the only anti-malaria that works. We have our Maxiron capsule, paracetamol infusion. We also have it. I've met a couple of doctors. They said they have been looking for this paracetamol infusion for the past 2 years. I told them it's readily available now. And we also have amlodipine, 5 and 10 mg, lisinopril, 5 and 10 mg, Ultraflux, a brand of ciprofloxacin. But I tell you, most of our prices are quite affordable. And it's going to be even more affordable by the time we open our factory in the next 2 to 3 months. And I want to use this opportunity to invite the chairman, the ANPMP Lagos State chapter, by the time we are about opening the factory. And to cap it all, we are not just here to come and exhibit. If you check some of if you check the conference bags with you there, you will see that Sam has decided to come out of a shell this year, this time around. We have gone into partnership with you, and the partnership doesn't end here. It still continues. I will continue to partner with ANPMP. And I tell you, this, I am representing, okay, I'm actually giving you my word from the managing director that we are here to partner with you. And as far as some of the private hospitals that are represented here, we are open for partnership, and that partnership is a win-win situation. I'm telling you, it's a win-win situation. You win, we also win. You gain, we also gain. And that is what I have for you today. And overall, our stand is just right behind you there. On your way out, you can visit us, and we'll actually give you some of the gifts available. Thank you very much.
Thank you very much. Please, we'll take the goodwill of the chairman, NMA Lagos, Dr. B.K. Said. Please, can you come to the podium for your goodwill message? Thank you. Please, can we put our hands together for B.K. Said? The welfareism doctor. Thank you.
Good evening. First of all, I'm sorry for coming late. There's some other engagement, but I said I must be here. I'm really happy and also excited in the sense that if you see any event that involve doctors, I only see the crowd like this. Really appreciate the ANPMP for bringing the crowd of doctors to come for this type of event. Did that mean that the ESCO really did a lot of work? And secondly, the elders, I don't know what really happened. They hardly come to any other program apart from this. Probably because of the maturity and understanding. Please, I'm using the opportunity. NMA Lagos will be having his AGM next week, this Tuesday. And we are happy if people, elders can also be available at the airport hotel on the 16th Tuesday. And again, it's surprising when I look at the ANPMP building. It's surprising that in the whole NMA Lagos doesn't have a permanent secretariat, which is not really good for Lagos State. And what I'm saying is that during this tenure, we want to launch. Therefore, thank the governor of Lagos State for providing land for NMA Lagos. And I pray to Almighty God that we will start the building of a permanent secretariat for NMA Lagos. we should be proud of every one of us. Now, as the Google message, as I said, when I see Eda, I'm always happy, in the sense that when we walk, we come here to come and talk this. And what I've seen here is something all associations should try to emulate and get people educated on what is happening in the science, in medicine, and in current affairs in the country. Thank you very much, the ESCO of the ANPMP Lagos State.
Distinguished ladies and gentlemen, the round of applause can go on and on and on for our chairman, NMA Lagos, Dr. B.K. Said. The time we're waiting for is now. The aging arthritis patients. Dr. Chigo Joseph Eze.
Thank you very much. Thank you. I want to stand on existing protocol, but I must appreciate the Almighty God first for bringing us all here. And I must recognize our royal father, the Alara of our kingdom, for spending time from the beginning of this program up to this very moment. And one of my mentors, Dr. Essien Ekong. I was his house officer in 1993, and he signed my MDCM form without hesitating. Till now, every time I carry the form, I see Dr. Essien's signature on my form. Thank you, Dr. Essien Ekong. And the elders of the association, our current chairman, Dr. Esegine, called me and said, I want you to be in the academic committee. And I said, use me as you wish. And I am really, really certain of that. And when Dr. Akin called me and said, you would be giving a talk at this show, if those are in the state hub know, they know that I was asking a question because I wanted to travel for an international conference. And when they told me 10-11, I had to cancel the conference to be here. Thank you very much. I want to start by, though they said arthritis in an aging population, but we are the drivers of health. 70% of healthcare is in the private sector. So I want us to understand what is arthritis so that we can also help to manage the population. That is why I'm having this as my topic. My hospital is a small one, a small specialist hospital. In Abule Egba, I'm sure I have put Abule Egba on the road map, landmark of Lagos, where it's actually a specialist hospital. But I'm the orthopedic surgeon and the principal. So orthopedic care is gotten fastest anywhere in Lagos, Nigeria. I stand to be corrected. In another less than an hour, I'm supposed to be at this show. But I have asked the radio station and my producers to do a recorded show for today so that I can be here with my family. This show started 2020 December. Today is supposed to be episode 220. One per week, every Wednesday, 16:15, drive time. And by virtue of this show, people started calling me Dr. Bone. But I say Dr. Bone Chigoko. With this small machine, orthopedic practice has been revolutionized. And with this machine, you can go into people's joints, into people's spine, into any bones in the body to do what you need to do. In Ikeja, comprising of 92 private hospitals, I believe Chigoko is the only one that has a CM. In Alimosho, there are a lot of my colleagues with CM, and I know on the island there are plenty of them. This was when I was training in Istanbul, 2013. a spine center. I did arthroscopy, arthroplasty, and spine surgery there. And now this is the name of the practice. This is what I want to do. This is what I am bringing to each and every one of you. We don't need to send anybody to India. You want to discuss business, discuss with me. You want to bill your patient, take your commission, discuss with me. That is what I'm bringing to us. These are some of the surgeries I have done in my facility. This is a cervical decompression and stabilization, neck. This is a lumbar decompression and stabilization, severe low back pain with degenerative spine. This is a pelvic fracture. This was done last week, Wednesday. An open book fracture of the foramen fracture. And the man could not even get up to walk. But he went home yesterday. And all fractures of the body, we touch it. AO says we should treat all fractures operatively. AO simply means Association of Osteosynthesis. There's AO trauma, AO spine, AO arthroplasty, arthroscopy, and the rest of them. This is a clavicular fracture. In the old times, we would put this patient in collar, in broad arm sling, or collar and cuff. But now we fix it, and the patient goes home within 48 to 72 hours. This is a hip fracture. This is a hip replacement and a knee replacement. For the hip, for a known sickler. She's walking up and down in Ibadan, enjoying her life. This is a shoulder arthroplasty. People tend to think we don't do it in Nigeria. We do. An ankle. Next week, I will be in the Arthroplasty Society Conference of Nigeria, and we are starting with ankle arthroplasty. So it is here in Nigeria. Now, this is me sometime in June in Hull City, UK, trying to learn a lot of things about deformity. K-leg, bow leg, X-leg, wiper leg, all the legs. And this is me just 2 weeks ago in Igbobi, trying to do something in foot and ankle. It's not all ankle injury you limp for the rest of your life. They can be sorted out. And these are the British Orthopedic Association Foot and Ankle Society gurus that came to train us, 5 of them. Now, I'm going to use this outline. It's very simple. Case 1, introduction, and the rest of them. Arthritis simply means degenerative changes occurring in the articular surfaces of bones. I'm not here to teach you arthritis. I'm not here to teach you pathophysiology of arthritis. I'm here to teach you how to recognize arthritis and what to do as a private practitioner. What to do, when to release this patient, what you can do for the patient that will be of benefit to the patient. And the best joint to use to describe it simply is this synovial joint, which is the knee joint. Arthritis have different causes depending on the types. Now, this is a knee joint. We all know the knee has the femoral bone and the tibial bone articulating. And that is the practical knee. And we know in between there are cartilages, the extra-articular and the intra-articular. The extra-articular are actually the collateral ligaments, and the intra-articular are the cruciates and the menisci. And tendons run across joints to move, to contract via their muscles. Muscles attached to bone via tendons. And this, when the muscles contract, they pull the tendon and the joint can be moved. Now, when you remove all those structures, you can really see inside the knee. You can appreciate the meniscus, the and lateral meniscus, the cruciate ligaments, the collateral ligaments, and even the patellar ligament that we separated from the bone to look into the joint. Both arthroscopic surgery, debridement, cruciate ligament repair, we do it here in Lagos, Nigeria, especially in Abule Egba. Now, this is a 71-year-old retired secretary, mother of 5, pain and deformity. Most arthritic patients do not come to me until they have K-leg, bow leg, wiper leg, any leg. Because why? We, the private doctors, we keep them. We keep them. We continue to keep them. When deformity sets in, is now severe arthritis. They say, oh, go and see the orthopedic surgeon. And these patients come to me and they say, the doctor said, you should come and you treat me with drugs or injection. And I tell them, sorry, do an x-ray first. We'll start from there. Then some say, I have taken this, I have taken that, I've taken everything. I've even taken agbo. And I tell them, you have a deformity. With this deformity, it has to be corrected. The best time to correct any deformity in anybody is before the age of 4 years. So when you see those children with bow leg, K leg, and X leg, tell their mother, it is not hereditary. It may be familiar. It's not hereditary. If you leave those children with deformity, before the age of 35, 40, they will need knee replacements or hip replacements. So this woman came with bow leg, varus deformity. We can see the limbs. Look at the joints compared to the one I showed in anatomy. Completely gone. This woman is working on bone upon bone. She came to me 2020. We fixed the right leg. She ran away. Now she's coming back 2025 to do the left leg. Do you think the left knee will be like this? We did x-rays, of course, subchondral sclerosis, complete loss of joint space, subluxation of the knee. Somebody will sit down and want to get up and the leg locks because the bone are on themselves, can't straighten the leg. And will struggle and struggle until he gets to straighten the leg and gets up. Because in Africa, we bear pain. We have high pain threshold. We can bear pain. We can walk on bone. Those are the kind of patients I see. And they are very terrible patients. Of course, when you have arthritis of the knee, there will also be, because the knee is the weight-bearing joint. And the weight-bearing joint of the trunk is the low back. So there will also be arthritis of the spine, which is the degenerative spine. So I usually ask for a lumbosacral x-ray. It's a must. And when the radiologists shoot the x-rays, they are very quiet. They don't want to tell us whether it's mild, or it's moderate, or it's severe. They just say features of arthritis, chronic arthritis, features of this. Some will mention there's deformity. Majority of them will not mention. They play safe to stay within the safe corridor. Now we did all this investigation. We planned her for surgery. We got a spinal anesthesia, tourniquet applied, surgery done within 2 hours. Patient drain removed, patient home. Patient is actually ambulated 24 hours post-op with a walker. Physiotherapy continues. Patient goes home in a week because we don't have plenty of bed space and luxury of keeping patient on the ward. They see me weekly until we remove stitches. 21 days for non-diabetic and 28 days for diabetic. That is not what the book says, but that is what I have seen from experience. And that is the post-op x-ray. Patient 2, this one is a tetanus. The first one is arthritis from degeneration. This one is arthritis from trauma, post-trauma. Had an accident, had implants. One of my teachers fixed the supracondylar fracture, and the patient was able to walk. Less than 3 years, the knee was gone. And they came. This was the implant that was there. And instead of giving her 2 surgeries, we had to do it one because it was the church that was paying. So we went in there, we took out this implant, and the same incision, we did the replacements. And all the tests, this is our x-ray. It was a primary complex knee replacement. This was done around 2019. Now, this is what the prosthesis looks like. The metallic one, sorry, this diagram is upside down. I just took it from the head of the patient. The metallic one shining is the femoral component. The metallic one that looks like a tray is the tibia and the plastic inserts.
Yes, these are the
the femoral processes, the tibial processes, and the plastic inserts on the right knee. Now she has spinal anesthesia, she had tourniquet. Those are the routine. Now we come to the meat of the problem. Types of arthritis. Number one is osteoarthritis, and it's a topic of focus because it is 90% of arthritis are osteoarthritis, and they are found on weight-bearing joints of the hip, of the knee, of the spine. Now, you see it more on the knees. In Africa, if we take our BMI, a lot of us are not within the range of 18 to 20, 24.9. A lot of us are above 26 to 30 BMI, kilogram per meter square. A lot of men are around early 31, 32, which is obesity class 1. Obesity class 2, 35 to 39.9, obesity class 2. And obesity class 3, which is morbid obesity, above 40. We see Africans. Anybody that does not have body like me, they say is not a rich man. Is it true? Anybody that does not have body like my chairman or our board of trustee, Oga, they say Kolowo Abi. So we are always very fleshy. Now, we also have the rheumatoid arthritis. This is autoimmune. It's just the body soldiers targeting the joint structure and destroying it. And there's nothing one can do. We try to give drugs. The rheumatologists give a lot of drugs, the immune modulator, to suppress the immune. But when they come to me, they already have deformity. So I have to fix it. Then the gouty arthritis, to crystals of uric acid just being synthesized anyhow in major joints of the body. And the very, very important one is the post-traumatic arthritis. Any long bone fracture must be treated properly, because in no distant 5, 10, 15 years, the joints adjoining that long bone may develop post-traumatic arthritis. The human body has the mechanical axis and the anatomical axis. At any point in time, they must be restored. What are the clinical features? Dr. Esendumi, sorry if I speak Yoruba. I speak Yoruba more than Igbo. Esendumi, ode wu, timbade emari, o mama lock, mi o nile rin. Ode ngbono si, bata ba gbese soke, o pupa o red ni. Do you understand? I'm just taking all this, and at times, mi o ti le rin láti bí by don yen. Translation is this, sorry, I will come back. Joint pain. They tell you the leg is paining me. And at times, when I get up in the morning, it's stiff. I will be praying to God, Jesus, let the leg straight. I will not be able to do that. At times, it's swollen for no reason. When I move around in the morning, it may not be swollen. When I move around, it swells. When I lie down, it goes down. At times, when I touch one leg compared to the other, one is hotter than the other one. And if I'm fair, I'm not a dark person, you see that it's red. And I can't even use it very well. Those are the classical complaints. They don't come to me to tell me that. They come to you and you, because you are the first point of call. Then we shoot an X-rays. And the radiologist says features of osteoarthritis in a 29-year-old person. How come? And we say, take NSAID. We give NSAID. They come back. We change from one NSAID to another NSAID. They come back and say, my epigastrium is paining me. We add omeprazole to it. That's very wrong. I've seen a lot of patients on NSAID with omeprazole and ask them, what is it for? They say, my doctor gave me. It will help me neutralize the ulcer. That's wrong practice. When we get to treatment, we will see. Now, most patients, arthritic patient, comes to me when they have varus deformity, bow leg, valgus deformity, K-leg, windswept. The leg is going like wiper. Or X-leg. or any leg. And most of them also have degenerations of the spine, the pain running up and down. Any pain running up to down, the layman calls it rheumatism. We call it degenerative spine. Arthritic pain is localized in the joints. It's a low back pain with neurological sequelae that runs from up to down, or the patient will tell you is running from down to up. Anytime I speak on low back pain on my radio show, callers will not allow me talk because it's a wide spectrum. Hotness of the leg, paresthesia, baja, pain running up and down, and this and that. The first thing I ask the patient, do you think you stepped on juju in your compound? Somebody wants to kill you, or the village elders sent arrow to you? If you tell me yes, then I tell you need to go to spiritual house. It's not a place to come to. But if you tell me no, then I tell you it's okay. We can work things out. You can get proper treatment. This is a blouse. Easier to get deformity explained in pictures of children. This is a blouse, double bow leg. This is double K leg. This is a wiper leg. That is an adult with knock knees as a result of arthritis. Now, the moment a patient steps into my office and started examination, I tell them walk down the corridor in front of my office. I look at the gait. They may have a painful gait, a tragic gait. They may be limping. They may be taking short leg gaits. All these are important. Then I tell them, please, if they are women, what are you wearing under? Is it a short knicker or what? Please, can you raise whatever your gown or your skirt up to your thigh? Let's see the knee. While you are standing, not before you lie down. So we see the weight-bearing stance of the patient. And we'll now say, okay, go and lie down. Take the joint, move it, put your hand on top of the kneecap to feel the crepitations, whether they are crepitations. Touch with the back of your hand. Touch this, touch that. Or touch the knee, touch the same ipsilateral thigh to know whether there's differential wound. Then compare to the other side. Then now palpate the joint line. Is there pain? Is there pain? Is it tender? Then try to do all these valgus, varus. They are simple tests. You Google on YouTube, you will see them. Know which ligaments are lax. And a quick general examination. Every patient, you must do a quick general examination. Then we ask for this gamut of investigations. We want to know, because when they come to me, they are not, majority of them are 60 and above. Is the liver okay? Is it battling with hypertension, with hyperlipidemia, lipid profile? What is the chest saying? Chest X-ray and ECG. What is even the blood level? Full blood count. Most of them are on antihypertensive and anticoagulants. Vasoprene, clopidogrel. So we do a clotting profile to be sure. And one thing that is very important is a C-reactive protein. That is specific for bone infection, apart from ESR. Then you want to check the urine. Are there ketones? Are there sugars in the urine? And what is the sugar like? The fasting blood sugar. Because if you have a diabetic on your table, whether you're a surgeon or not, you must manage the diabetes to be euglycemic before you start talking of your surgery. If not, your wound will not heal. That is why they stay 28 days before I remove stitches, whether they are controlled or not. Investigations. All I need is a simple plain X-ray. Please, not analog X-ray, digital. The one you can see, the patient can see, is not the one that it is only you and the radiologist that can see it. The patient can see it. A digital plain X-rays. You notice I wrote lumbosacral MRI. I see patients doing MRI of hip, MRI of knee, because the GP has requested for it. It's even worse, those coming from abroad to see me, they are sending me MRI reports of a badly knee, and they have been on queue in health insurance to do a knee replacement or a hip replacement. All you need is a simple, plain X-ray. All you need. Hip, knee. Because we know there's degenerative spine, we also ask for X-ray of the lumbosacral region, X-ray of both knees, and X-ray of both hips. And CT scan is not a prerequisite for diagnosis. Others are like for the rheumatoid arthritis, you can ask for the rheumatoid factor, which they say is non-specific. These are the X-ray features of an osteoarthritis of the knee. Please, the pointer. Okay. We look at the joint line. That joint line is as if this patient, obviously a woman, is walking on bone upon bone. There are no ligaments to help this patient glide the knee easily. Look at the edge, the edge, the lateral edge just above the fibula. You see extra bone forming above the fibula. Extra bone, those are osteophytes. Even on the distal tibia, on the medial side, these are osteophytes forming. Then if you look at the subchondra, is thickening. There's sclerosis. The bone is trying to heal itself. The thing is breaking down. It's trying to heal itself. Some, you will even see the cysts also. And this is another, the same X-ray, but a better view. Now, this tells about the tibia spiking, the osteophyte forming at the edges, the narrowing of the joint space, the regularity of the subchondral space. These are classical. Even when I did steeplechase in my part 1 exam, these are the things national they were asking us. And because I'm from Igbobi, it was child's play. Now, for the hip, the left hip is okay. But you look at the right hip, compare yourself. You see some changes. The head of the right hip is a bit collapsed. The acetabulum is sclerosed. There's deformity. And for every X-ray of the patellar joints, you must have two views: AP, anteroposterior, and lateral. Now, treatments. It is here I want to talk. Now, a radiologist gives you a report of a 21, 29, 32, 35, and they say osteoarthritis of the knee for knee pain. I don't believe in that. I said arthritis is a degenerative disease without any previous history of trauma or fracture. I don't believe in that. So most of these patients will come to us. If we don't have those 5 cardinal signs and they can still ambulate, the best of care is analgesia. Whether it is the NSAIDs, non-steroidal anti-inflammatory drugs, which are the most effective. Initially, we're supposed to start from paracetamol. Then we go to aspirin. We go to ibuprofen. But you and I know that when Nigerian patients come to you, they've taken all those things at home. So you can't start them on that. So the step-ladder approach of painkillers, you must go up. Then some tell you, if you want to keep them longer on painkillers, give NSAIDs that are coated. Either they are coated with cholestyramine, diclofenac coated with cholestyramine, or coated with misoprostol. I'm not going to mention brand. Nobody has paid me money. Now, if you must give the one coated with misoprostol, maybe I should quote brand so that we know. If you must give the one coated with misoprostol, which is Atrotec, misoprostol is an abortion drug. You can't give a lady of between 25 and 39 that may need to get married and get pregnant and say be on Atrotec. You're only going to be aborting all the babies she's trying to conceive because she came to you for pain. She didn't tell you, you are not the gynecologist. She didn't tell you, I have a fiancé, we want abati loyun, lama loshe introduction. And you are giving the person Atrotec. You're only going to be aborting whatever is going to come in there. So you think of another coated, Flotac. That one is coated with cholestyramine. They say pyridine. That can go across all age. But it's more expensive than Atrotec. Atrotec can go for elderly people. Most times I ask, are you looking for a child? Have you finished your gynecological career? If you say yes, you want one more. I put you on Atrotec. It's cheaper. So we should know that. Please, Let's take note of that. Then, some will tell you, we've taken phenobuta, we've taken this. It is wrong to give anybody with ulcer symptoms. It is very wrong. Omeprazole and say be on NSAID. And if you have any of your patients that is called you and is complaining, every time I take this drug, my stomach is hot, I feel like vomiting. Those are early gastritis. We don't need to go to Lekki to go and do what we need to do that costs money. But you can take that patient off that drug and place the patient on an aceclofenac. Studies have shown that aceclofenac is safe in gastritis or any form of PUD. And aceclofenac now has the one with paracetamol, with the one without paracetamol. You can place that patient on that. We can also do opioids. Some people take tramadol. Now, have you tried to go and buy tramadol in a pharmacy? You can't get it. The people that bring it to you, bring it in black nylon in the middle of the night. Yes. Your vendors, if they are bringing it to you, instead they tell you go and buy Antajet. That is a mixture of something. I'm talking of tramadol, 50 milligram, 100 milligram. You can't take it in that, you can't give them for too long because they become dependent on it. They start abusing it. You can also consider a knee support. Please wear something that holds your knee so that you can walk easily. You can also consider physiotherapy. But there's a new prescription which contains, the only prescription which contains hyaluronic acid, which is the component of synovial fluid. That prescription is the Bonvite. It's a new drug. It's the only oral preparation that contains hyaluronic acid. And if you add it to whatever medication, we talk of chondroitin sulfate and the rest of them. You can also use them in mild first stage of arthritis. But Bonvite has all that plus hyaluronic acid. So if you have hyaluronic acid as oral medication, you don't need to inject it into anybody's knee. The second stage of arthritis is the moderate arthritis, where the cases are severe. You want to give analgesia, you want to give physiotherapy, and you want to give intra-articular injection of hyaluronic acid, not steroid. A lot of us, we go and get methylprednisolone, and we inject it into the knee. Yes, the patient will feel transient relief. Whether the patient gives you money is good. But the patient, after 2 or 3 months, will come back. Doctor, share mo abere nyete fumi ni oru what they call this? Ewa fumi si. The next time you give, that, do you remember that injection you gave me in my knee 2 months ago? It worked very well. Can you give it again? Please, I want it again. You go and give it again. I bet you, within 6 months, that mild arthritis will catapult to severe arthritis. Then you give me patients. Is this patient ready at 42 for a knee replacement? Please, if you want to inject anything into the knee, it must be a hyaluronic acid. There's a company in there, SJS Life Sciences. They have the brand. One shot of Excel is almost 250,000. You ask the patient, can you afford it? So we need to be very careful. Then the last type of arthritis, which come to me, are the severe OA. At this stage, there's deformity. So nothing the person is telling me, I'll be canceling the person for joint replacement. This is Bonvite. It contains sodium hyaluronate and chondroitin sulfate, the only oral preparation of hyaluronate, and is marketed by a company there. And the rep, that's the number of the rep. And this is another calcium. I give a lot of calcium, but I've not seen a calcium that contains algae calcium, which makes my work very, very fast. The same company, wow. What did I do? Hello. Now, for joint replacement, which is what concerns me, I'm just going to summarize. I won't saddle us with that. For knee, it can be primary, primary complex, or revision. That is my problem. Hip, the same thing. Now, we should know that when you are shooting steroid into the knee, you know that you are going to tell the patient to be preparing for almost 5 million for knee surgery, knee replacements, and 1 million more for hip replacement. That is the ideal price now. So let's help them delay the arthritis. Let's delay it as much as we can. These are the processes for the knee, the femoral, before we go for any operation. And I tell them, don't worry, village elders will not be looking for you because you will not be asleep. We're going to give you spinal anesthesia. You'll be awake. If you are a pastor or imam or the leader of a prayer group, you'll be the one to pray for us before we start the surgery. And within 2 hours, we are done. The next day, I'm out to bend your knee and get you to work with a worker. I hand over to the physiotherapist to continue. 2 days after, we remove the drain. You continue physio. 5-day post-op, you are in your house. You are in your house. You don't need to stay 1 month, 2 months, 3 months. One can do both knees or a single knee. This is post-op X-ray of a bilateral knee replacement. This is what it looks like on X-ray. And this is what it looks like on hip. This lady is a 29-year-old sickler. Both hips destroyed. Even to get this done, we spent 4 hours. She has not come back. She ran away. But she's working. This is the same knee picture. This is a 62. These are live videos. Year-old retired businesswoman with bilateral the right knee was done. Genovalgum, A-leg, the right being worse than the left. You can see how patient is struggling to ambulate. The right leg is very, very curvy. She has not knees. The right knee is usually anterior to the left.
She had the first leg in November.
That's what we call
6 weeks after
severe
the second leg.
osteoarthritis.
This is 3 months video. That is bilateral locked knee. This is a single lock knee. This is a retired. Patient. An elderly that is bedridden is going to develop all manners of complications and join the ancestor sooner than we plan. And so the most patient will say they want to live like that for the rest of their life. Or they will say, okay, if the Nigerian doctor has said that, let me ask Oyibo doctor. And that's where they go for medical tourism. Now, what should we do? We are talking in ANPMP, best practice. We want to collate the names of different specialists. Is good. We want to do group practice. Group practice doesn't mean you will collapse your hospital and join me. Group practice means we have chain around ourselves. Oh, this man is a gynae case. So who am I going to call? Dr. Akin is closest to me, is my Egbon. I sent to him. Oh, he's a cardiology case. So even though my VP2 is a cardiologist, but he's in Amu Odofi, I will ask the patient, Combo, are you ready to go to Amu Odofi? I know this guy well. His hands are that of genius. It's what you tell the patient. They will go and they will give you feedback. Pediatrics, so Dr. Mustafa of Intin. That's where I send all my patients to. That's where my children go to. So the networking will be closely niched. That patient will benefit, not us keeping the patient. And some persons will say they refer patient to me. When they come and say, please, give the patient my number. My number is in public domain. Everybody on radio number. So why are you holding my number? Let the patient call and let's get a proper time for appointment. I may say I consult 10 to 4, Monday to Friday, no weekends. But some patient will call and explain their predicaments. And I'll say, okay, come 8 a.m. or come on Saturday around 11, 12. Or Come so time because I'm stepping out so time. Give the patient the specialist number. That is why he's a specialist. One thing I don't do, I don't take calls after 7. When I get to my house, it's my family time. But if you chat me 24 hours on WhatsApp, I will reply you. But if any of my Egbon here call me after 7, one day Dr. Akin woke me at 1 a.m. I knew there was problem. A man got to his house, maybe was apparently drunk, and fell into the louvers, aluminum door with glass, and the thing slit his hand. The man was transferred to me at 2 a.m. with 20 artery forceps, trying to catch the vessel. But the hand, we didn't lose the hand. Those are emergencies. Will government pay for that? Who will pay for it? The patient will come and say, I don't have money. But you must save the life. Now, we collaborate with our colleagues and other specialties. And I know a lot of patients here a lot of doctors, senior doctors here that have sent patients to me. And I respect that. At times when they call me, I ask, this is your patient. What do you want? This is the bill, I do it. Do you want to do like National Assembly, padding? You pad it. And the patient pays you. You pay me my own. You send the patient to me. Or you want me to bill the patient and factor your interest. Majority of them will tell you, no, just sort out the patient. That is one sincerity as ANPP doctors, PMP doctors. A doctor is seen as a charity donor. But there's the business part of medicine, and we must partake in it. There's business part of medicine. Gone are the days a doctor gets a 3-bedroom flat, buy bed from government salary, buy things small, and starts business. If you have a landed property and you want to start a practice or you want to expand it, go to the bank. You have a CFO, take a proper loan, make your practice a limited liability. It's just that is borrowing the loan, not you. Loan is insured. We're not saying default. We don't default as doctors. We are responsible. Loan is insured. The worst come to the worst. Nobody is going to sell your property. As long as they can prove that you are bankrupt, nobody's going to sell your property. That is why hospitals should be limited liability. LED. Make the company different from you. So your personal responsibility is not the personal responsibility of the company. Totally different. If you're running a medical center or you're running a business name, call your lawyers. You can upgrade. CAC has a window for all that. Please, let's see it as business. Be ready to learn procedures. When I go to most hospitals, before the jackpot thing became very bad, I couldn't go. I try to teach the Oga on ground. Oga, come and stay with me. I'll be explaining so that at least he has an idea. He has an idea. A compartment syndrome comes at 1 a.m. He won't call me because the TBS has tied bamboo on the limb and the limb wants to die. Will he now be calling me? When I've told him, the way I'm putting cast, I'm explaining all the complications of casts. Okay? And for children, I don't put a full cast most times, especially when they have this supracondylar fracture. I put a back slab. I'm teaching everybody now. Put a back slab in 90 degrees of flexion. The TBS will splint like this. My first posting in Igbobi between October to December 2007 was a 7-year-old child. We had to cut the hand. It remained vivid. And that child grows, they will say, they cut your hand in Igbobi. That child grows up to resent Igbobi. They will not say, we took you to a traditional bone setter who tied splint so tight. And while the child is shouting and they are calling them, they say, I feel it. That is how it should be living. And you wake up the next morning, the limb is gone. You put a cast for a child. Most parents will say they have other children at home. So I put a back slab. At any point, I say, my number is open. If the child is crying excessively, come back. If you cannot come back, use blade, cut through the gauze bandage. If it's a cast, cut through it, soak it in water. Because compartment syndrome takes away the limb faster than any of us. Orthopedic has only 3 emergencies. Fracture is not one of them. You broke leg, my doctor does not wake me up. He only stabilizes you. When he has and send me videos and pictures. When you have X-ray, we talk what we want to do. Vascular injury. If you have a vascular injury in this country, one ischemic time is 6 hours. Where do you get a vascular surgeon in 6 hours? So most likely you get an amputation. I say it on my radio show. Even if you fly from here to Bagada, they call the vascular surgeon. They tell you, go and pay money. Go and do this, go and do that. 6 hours has passed. We don't make it. Another orthopedic emergency is compartment syndrome. A tight cast, a tight splint, take it down. Because if the artery kinks, if the vein is the force that kinks, and the artery is still deep, sending in blood, nothing is coming out. The artery finally kink. The nerve will start first with pain, then the vein, then the artery. That child will lose that hand, or that adult will lose that limb. Then you see diabetic foot. In the foot and ankle course I learned in Igbobi from the British guys. Please, they made us realize that it's not all foot you go and cut. Don't. The more you cut, the more the at risk of the other limb. If it's the toe, do a reamputation. Forget about prosthesis. You can always carve out something with the orthotis now. Because we tend to say, anywhere around there, just cut below the knee. In military hospital then, when I was appointed a consultant between 2015 and 2020, before I resigned, before Corona lockdown, I have a lot of diabetic. Doppler says the vessels are bad from the popliteal. So you're supposed to give an above knee. Then most of them will start fighting. Above knee processes is difficult to use and expensive to get. But below knee, they can cope with it. So I tell them, you sign 2 consents. We do a below knee. If the wound doesn't heal, we go above knee. I can bet you, undocumented, 90% of those patients get away with it. I've never even gone back to do an above knee. The wound heals. The Doppler says the plaques is from the popliteal region. It heals. And they get away with it. An average good below knee prosthesis is about 1.2, 1.5 million. We should know this cost. So you don't just say, go and see. Immediately anybody is sending a diabetic foot to an orthopedic surgeon, it's amputation. But because of the foot and ankle cost, even though we do amputation, we do limited. Try and see whether you can salvage some of the good parts. But you know, with we and our ancestor in Africa, amputation is a procedure the surgeon does not want to do. The patient does not want. Nobody tells you thank you. The children says, see that stupid doctor. He's the one that cut our father's leg, our mother's leg. That's the way they describe you. In government setting, it's not done by any consultants. It's done by the least in the surgical team, which is a registrar, not a senior registrar. But out there, it's done by a consultant. So somebody will tell you, you are charging me 1.2 to cut my leg. Yes, it's a consultant that is doing it. If you want to go to government hospital, it's a registrar that is going to do it. So the choice is yours. And because we believe in reincarnation, we don't want any cut to, when I come back in the next ward, I may have one leg. So we don't want amputation. A doctor told me, doctor, I can never allow you to do amputation in my hospital. And I told him, sir, your hospital is a gynecology theater. I can never do any standard orthopedic procedure called ORIF or joint replacement in your hospital because infection will kill the patient. So we concluded, he refers his patient, we get it done. The golden hour of trauma patients, please resuscitate. Gunshots. Even, I love lawsuits. They have no bed space, but they'll come to the car, they'll put a line. They put an IV line, and they say go to Igbobi or go to Lut. Don't just send away. You are not the person that shot the person. You are not an investigator to think police will come and arrest you. Your own is to take in the patient and inform the DPO of the nearest police station around you that you have a gunshot. And they will come and do their work. But save the life, even if it's a thief. Save the life. Start the resuscitation. If you cannot, then transfer. That is what it should be. Don't just say, no, go and get a police report. They are busy looking for police reports. Patient is dead. They are busy going up and down. That's what happens in Lagos. A 20-year-old old boy had a ring. We don't know whether they call it Oruka in his index finger. And the thing got stuck, ring in the finger. He went around all the government hospital on a Thursday night. Nobody took him. Everything they tried didn't work. He presented to me on Friday morning. We got out the ring. And he was in pain. And the parents were all agitating. Please, let's try and do something. First, preserve life. My wish is that trauma in this country is made free, like antenatal and immunization. Because when you're leaving your house, you didn't pray to God. God, please, I want to have accident. I want to break leg. You didn't pray to God for that. And when it happens, the government should be able to step in and say, do the basic minimum. Here, trauma is free anywhere in the world. So people will now wake up and say, I don't have 500,000. I want to go to Babalao. Or my daddy said I should be coming to the village. Or my mommy said I should be coming to the... When you hear that, you know they are going to traditional bone setter. Please, that is what the government should try to do for us. Preserve life first. Anybody rushed into Chigoko, we are not interested. Is when we finish stabilizing person, say, oh, who is the caregiver? Go and open card and make deposits. Distinguish one's practice based on specialty and interest and corporate social responsibility. If you're in an area, let them feel your presence. They will fight for you in terms of adversity. Now, recent advances. According to Association of Osteosynthesis, AO is a group of young guys, a lot of research into trauma. They believe that all fractures must be fixed. That is the teaching. Whether it's the pelvis, is the vertebral spine, is the clavicle, is the humerus, it must be fixed. And all joints, all fractures that gets into the joints cannot be managed on cast, please. Only few fractures can be managed on casts. All fracture, a supracondylar fracture or a pylon fracture that cuts into the joint must be fixed. It must be operated. As if physiotherapist is telling the patient, no, don't allow him do operation for you for a supracondylar fracture with intra-articular extension into the knee. And I left them. Years later, the man will need a knee replacement. But this time, a complex or a revision knee, not a primary knee, which is about 8.5 to 10 million. Now, fractures of the femur in adults, radius and ulnar, clavicle, spine, pelvis must be operated upon. There's no conservative management there. And you explain to the patient. I know our patients, we love Dr. Google more. I give them the diagnosis and I say, go and type it in Google. When you see the search engine, Wikipedia, read it. They come back and say, Doctor, Doctor, you are a winch.
Dr. Eze, if we leave you, you will be the only one left in this hall at the end of the day.
So they come back and they agree with me and we sort it out. And my foundation tries to bring down costs for those that cannot afford it. But for those that can afford it, they pay. You have to let Peter pay to manage Paul. There is no room for conservative management for fractures with exceptions. And it's also good for us to try. I want to see ANPMP say we want to organize basic life supports or advanced trauma supports. Because whether you like it or not, when Okada people jam themselves, it's the nearest hospital they are running to. And it's that simple. We don't need to go the whole way out. It's not for orthopedic surgeon alone.
Take that one question and we'll just round up by telling us all the things that are still lined up for the social part of this evening. And I will also allow somebody to just...
Thank you very much for your wonderful presentation. My name is Dr. Batu Febuna. I represent Grace Valley Medical Center. My question is simple. We have some drug preparations that contain NSAIDs and a proton pump inhibitor. Should we do away with them? Thank you. Based on what you taught us.
Thank you very much, Doctor. Now, if you have drug preparations that have NSAIDs and whatever combination. They are better off if we just have plain NSAIDs. So you shouldn't do away with them. You shouldn't do away with them. But the physician administering those drugs should try and limit, because it's you the patient talk to. It's you that know how bad the symptoms, gastric symptoms are. So you try and reduce the rate of the use. But those drugs can still be applied to even those that don't have ulcer. They can take it. Do you understand? Thank you very much.
Thank you very much. I think that has been answered. Please, and to appreciate the lecturer of the day, please, can we put our hands together, please? It's very, 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 very important. Thank you. Okay, you said you want the phone number. The phone number will be displayed on the board. But we want the state chairman, Dr. Jonathan Esegine, to mount the podium, and NME chairman, who is also a consultant orthopedic surgeon, to mount the podium to present an award to Dr. Joseph Eze.
Well, thank you very much. I think we can put our hands together one more time for Dr. Eze, because for him to be the last man to give a lecture at this time, and he commanded rapt attention, then that lecture must be very stimulating. Once again, a round of applause for him. And I also like to use this opportunity to thank you. When we came in, I brought a lot of them to form the Professional Development Committee. Professor Ogun, Dr. Eze, Dr. Akin, and so many of them. And that committee is headed by one of the students of Professor Ogun many years ago. And they all attend the meeting. And that is why we have topic of professional development throughout the whole year. You will testify. Dr. Elogo, the cardiologist. In fact, it's a committee of specialists. And I've also told them we are going to make a compendium. We are going to have a directory of specialists so that we can have horizontal referrals. Thank you very much. I just thought I should say that. So I'll hand over to my chairman. Thank God you are here. I think the best person to determine whether an award should be given to an orthopedic surgeon is another. So please express our gratitude to him.
Thank you, Mr. Chairman. On behalf of the Association of Nigeria Private Medical Practitioner ANPMP Lagos State Branch, I want to appreciate Dr. Eze for the lecture, also for the support he has been giving the association. Also, he's the second vice, or the first. Yes, yeah. Now, Dr. Eze for this presentation and also for the support you have been giving the association. Thank you, sir.
Thank you very much. I believe we can all give ourselves a wonderful round of applause for being such a beautiful audience. The evening is gradually coming to, the formalities gradually coming to a close. I would like somebody to come and speak generally about one or two products just to make sure. Dr. Eze, your number is being requested as a presentation. I would like to know if we will be having the same amount of people here. Just announce it.
Please, my number for everybody, 080 61 52 72 92. I'll take it again. 080 61 52 72 92 92. Please, when you chat me on that, 080 61 52 72 92. When you chat me on WhatsApp, you will see Chigoko Specialist Hospital. That's my official WhatsApp number. And at times, please, it's just better you chat. I'll reply faster than calls. But if I see 2 missed calls, I call back as soon as I'm available. Thank you.
Thank you very much. Like I said, the evening is gradually coming to a close. There's a social aspect of the activities today that will be taking place around the welcome poolside while they get themselves organized and we begin to wind down. I want to be sure that we will all be here again tomorrow. I'd like to encourage you that tomorrow is even going to be more dynamic than today. But as a prelude to one of the presentations that we'll be having tomorrow, while we're still here winding down our day, I'd like to invite Dr. Chukra, AJ, yes? I believe your main presentation is tomorrow, but I just want you to come and talk about some of your products so that the people who are here will have an insight of some of the products that you have brought here today. I would like to thank everybody for being here today, invite you to be here bright and early tomorrow. There is a Fidson glaucoma screening, free glaucoma screening right just outside by the generator. The Fidson stand is there, and Dr. Anibaba is there to offer initial tests for glaucoma. But as we are all winding down and just waiting to take over the next set of activities, I want you to listen to Dr. Shukra, PhD, pharma marketing, and the products that they have brought. They'll be having their main presentation tomorrow, but he insists that the men want to listen to what he has to say today. So I'll just give him an opportunity to just discuss. He wants to say it by himself.
Thanks for giving me an opportunity. It has been a long day. I can understand. You must be tired. More precisely, the upper half must be very, very tired. Today, to give a powerful presentation so the entire body gets charged. But unfortunately, we are on the verge of close, so tomorrow I'll be there. My topic remains, if time permits, technical aspects of pharmaceuticals. Doctors, you're not in manufacturing of the product. Your pharmacist is not in a manufacturing of a product. You are not in a quality control. But there are certain technical aspects which are supposed to be known to you. But at a time, in absence of those informations, what happens? We'll land up selecting wrong product for your patient. Remember, doctor, no patient comes to you just like he wants what? High efficacy, whatever product you are using, that should be efficacious enough. He wants a quick onset of action. See, all the doctor is in a hurry. They are going. But your patient is in worry. They want a quick onset of action. Your patient wants a good side effect profile. He comes for bronchitis. You prescribe him a drug that gives him diarrhea. He may not like you. So good side effect profile. Excellent compliance. Followed by cost effectiveness. So let me repeat, sir. High efficacy, quick onset of action, good side effect profile, excellent compliance, followed by cost effectiveness. Do you agree? These are the things you want from product. And remember, doctor, these are the things we keep at the back before we manufacture products for you. So that we make 1 + 1, 11. Right, sir? And patients should fall in love with your diagnosis and treatment. So tomorrow, I'll bring different product which will help you to treat your patient more effectively, more efficiently at affordable prices. So tomorrow they'll give me time when hall is full. That is my sincere submission to organizer. Give me chance when hall is full. So I bring the technical information that will definitely you're going to appreciate. When it was AGPMPN, I used to be in a Calabar. I have given presentation in Akure. I have given presentation in Abuja. A lot of places. Islamic Medical Association, and those technical aspects has been appreciated by doctors left, right, center. So tomorrow, right, sir? And please don't forget to collect your bag from exhibition stall. There is inside one product which is used for erectile dysfunction and premature ejaculation. Just one tablet. It's there. Sample is there for your patient or friend. You can collect. If not today, tomorrow, I'll ensure that on every table it is available, my bag, like this. So it will be there with you. So you can extend the benefits to your patient. Thank you very much. And I'll wait for tomorrow when crowd is full. When you are present over here. Right, sir? Thank you very much, man.
Thank you very much, Dr. Shukla. And Barrister Funke will round up, and everybody will revert to the poolside. Thank you.
Yes, so it's pool time, relaxation time, and would like to give special thank you to all our distinguished guests, members of the BOT here present, all the chairmen and presidents of all our associations, and especially to Kabiesi for sitting through this entire day. I hope that you were able to pick up some wonderful bits of information. Kabiesi, we thank you. God bless you. Kade Komak Pelori Kibata Pelese. So we wish you well, and we pray for the progress of our kingdom during your reign. Thank you, everyone. Time to unwind with your spouses at the poolside as we retire for the Asun night and barbecue night session of today. We resume 9 o'clock tomorrow morning for the first session. Please come early. Go to the Fidson stands. Go around the exhibition stands. You have exciting products here and a lot of free products. So please ensure that you pick up your free, if you can pick up your free package from SGS stand, please pick it up before you go today, or make sure you pick it up tomorrow. God bless you and have a very good evening. Barbecue, 7:30 p.m. at the poolside.